Good morning. Today is the day 2 of the anesthesiology training session of the pre-intern training program. I cordially invite Dr. Piyusha Jayawardena to start the session. Those who cannot log into the Zoom meeting can join us with our YouTube live broadcast. Over to you, madam.
Excuse me, doctor. Good morning. Doctor. Good morning, doctor. Hello?
Yes, madam. Yes. Yeah.
Yeah, I'm Nandika here. Can you please admit the doctors in the waiting room?
No, I'll admit, madam.
Okay. Okay. Thank
Hello.
you.
Right. Good morning. I see that still people are entering the waiting rooms, no? So I'll give it 1 or 2 minutes and I start sharing, and I'm going to switch off my video because of poor quality of signal in this area. Can all of you see my screen?
Yes, madam. We can see.
Right, great. Then we'll start. So this is good morning and welcome to the second day of pre-intern training. We are going to start with a very important topic for you all, because as interns, you will be the first respondent to a patient with anaphylaxis. And by knowing how to diagnose quickly and treat quickly, you will be able to save the patient's life. And you must have heard all these media, all these news and everything regarding how patients have died recently in the wards. I'm sure if we train you all like this, and if you get this into your head, how to diagnose, how to at least suspect if a patient is having an anaphylaxis, it would help greatly by reducing patient mortality and morbidity. So this is a very important topic, and I want all of you to listen very carefully and make notes also in case if you need, right? So in this lecture, I'm going to talk what the objectives are, to talk on what is anaphylaxis, how to diagnose it, how to exclude anaphylaxis from a fainting attack, and the immediate management, how to use adrenaline, and what are the things should be done before a patient is discharged, and special events related to anaphylaxis. Okay. Now, what is anaphylaxis? I'm sure you all have learned in your pathology and physiology in your clinical practice, but just to recapitulate, now anaphylaxis is a severe, remember these words, it's a severe, life-threatening, generalized or systemic hypersensitivity reaction. It could be severe and life-threatening, and it's a hypersensitivity reaction. Now, anaphylaxis is characterized by a rapidly developing life-threatening features related to airway, breathing, circulation, either in one of those or as a combination, in either two or either one of these three systems, airway, breathing, circulation, right? So if it is not there, if it is just a skin rash, we don't call it anaphylaxis, okay? And then these airway problems, what are those? You get pharyngeal, laryngeal edema, right? And symptoms related to that. And breathing, bronchospasm, and the features related to that, right? In circulation, severe vasodilatation, thereby the features related to that, okay? Either one, or two, or all three, or something like that. Now, one thing I want you to remember is patients can have anaphylaxis without skin features also, right? About 10% of patients who have anaphylaxis will not have skin features. But you have to suspect if a patient has had a new drug, has had something to eat, and present, right? In the clinical situation, you have to suspect, although if there is no skin manifestations. Now, if a patient develops anaphylaxis, you have to treat immediately to prevent life-threatening reactions and death. Okay, right. So I lost it. Right. Probably you can see it, no? Can you see my screen? Can you
We
see
can't see
my...
Dr. Piyush.
You cannot?
No.
Right.
Yeah.
You saw earlier?
Yes, we did. So might have to reshare it.
Right. Just give us. Can you see now?
Yes, we can see it.
Right. Good. Right. So coming back to the definition of anaphylaxis, right? There are few definitions from different organizations, but what we want you to remember is the one by the World Allergy Organization. What it says is the same thing we talked in the previous slide: a serious systemic hypersensitivity reaction that is usually rapid in onset and may cause death, right? So remember that. Now there is a 90% of patients will have skin features, that is the urticaria, rash, edema, angioedema, like that. But 10% of patients may not have it, but they will, all of the anaphylaxis patients will have something wrong with their airway, breathing, circulation systems, either in one or all. Now, if we come to epidemiology, we don't have data for Sri Lanka, but in Europe, it's said to be 1.5 to 7.9 per 100,000 person, right, per year. Now, if we reduce it, like if I give some other numbers, it is said that 1 in 300 people will experience anaphylaxis at some point in their lives. This is according to the World Allergy Organization. So it's quite a number, isn't it? So as interns, the chances of you getting patients who have developed anaphylaxis is quite high, right? If you consider the prognosis, they say the case fatality rate is under 1%. That is in UK, of course. Right? But what we want to do today is to teach you anaphylaxis, how to give you an idea how to identify it and treat it, so that our numbers for case mortality rate is also such a low value, to make it such a low value and reach good medical status in the country, right? For that, we have to start with you all, because you all are going to start your internship and you will be the first responder. Now, pathophysiology, I'm not going to talk a lot about it, but if you remember when you were students, you were taught this hypersensitivity reaction, type 1, you get IgE antibody formation for antigens, right? And those IgEs stay in the body. And when the second time the antigen enters the body, there would be antigen antibody response, thereby leading to release of mediators from mast cells and other cells, right? So mediators like histamine, tryptase, anaphylaxins, so many other mediators, right? It is these mediators that cause these pathophysiology changes in the body. Now, I have to tell you that recent findings are, in addition to these antigen antibody reactions, there are other ways of developing anaphylaxis also, right? It is not entirely due to antigen antibody response, but most of it is due to this IgE mediated response. Now, what happens with these mediators? They activate a multiple inflammatory pathway, right? Related to this airway, breathing, circulation. What are those? They produce tissue edema, and smooth muscle contractions. That's why in the airway you get bronchospasm, right? And then smooth muscle in the vasculature is actually relaxed. They reduce the venous tone due to vasodilatation, right? And fluid extravasation. So then a problem in the circulation system comes. What is it? Hypovolemia, tissue edema. Those things happen, right? And if severe, you get a hypovolemic and distributive shock. In addition, your heart is also depressed, right? Your myocardial function is also depressed by these inflammatory mediators and going into cardiogenic shock. The shock in these patients are multi origins, right? And then in the bowel, this fluid leakage and smooth muscle contraction lead to abdominal cramps, right? So remember, a patient can only present as having abdominal pain And you have to consider if the patient has had an allergens, like if they had an antibiotic immediately, and the patient starts shouting, the pain is there in the abdomen, you might have to consider whether this is anaphylaxis. Okay. So this is the pathophysiology. Now, what are the factors that would cause anaphylaxis, right? So commonly for food items like peanuts, milk, right? Like that, any other nuts, okay? Pork, like that. And sometimes, mostly, commonly what we encounter in our hospitals are due to medication. And out of medication also, the commonest would be what? Antibiotics, right? Especially the penicillins. But in addition to antibiotics, you will see neuromuscular blocking drugs. In anesthesia, we use succinylcholine, right? Those drugs can cause anaphylaxis. Some other things like contrast media, then non-steroidal anti-inflammatory drugs. Those are common drugs that cause anaphylaxis. In addition, you get, or some of the patients also get due to insect stings like bee stings, right? But this is not just, these are only few causes, but the common causes of anaphylaxis. Now, signs and symptoms of anaphylaxis, you have to know. I told you earlier, skin and mucous membrane signs and symptoms are seen only in 80 to 90% of patients, right? 10% may not have it, right? So most of them will have, but remember that also, right? How do they present? Tingling sensation around the lips, edema of the lips, facial edema, skin itching, right? Erythema, urticaria, and angioedema. Angioedema is the swelling in the throat, okay? Throat, the lips, the airway edema, right? Then hoarseness of voice. Those are the symptoms that you see when the skin and the mucous membranes are involved, right? Sometimes patient will start by itching themselves and then crash immediately. But some of them may not, right? In the other airway, and I told you, airway, breathing, circulation problems have to be there to say it's anaphylaxis. So what are the airway and breathing system problems? In the respiratory system, right? What are the airway problems you see? Difficulty in talking, right? Hoarseness, stridor, that is, there's a noisy breathing, cough, right? And then that is airway problems. And what are the breathing problems? In the lungs, right? They get bronchospasm, wheezing, thereby difficulty in breathing. And their respiratory rate may be increased, causing tachypnea. And ultimately, the saturation may be also low. Those are the respiratory system features. That's airway, breathing. And then what about circulatory system? In the circulatory system, what they will have is hypotension, blood pressure may drop, weak pulse, thready pulse, right? Increased heart rate, cold and clammy hands and feet, right? So look for these A, B, C problems, right? So some other problems also. Now, because the blood flow to the head or brain is reduced, they will feel anxious, faintishness, even loss of consciousness. In the digestive system, I told you earlier, due to smooth muscle contractions in the gut, they get abdominal cramps, right? So these are the signs and symptoms of anaphylaxis. Now there's a spectrum, right? I told you earlier. Now look at the left side of the screen. If it is just mild, localized skin symptoms and swelling of lips or face, but if the airway, breathing, circulation, all are normal, then we don't call it anaphylaxis, right? But the moment they start having problems with airway, breathing, circulation, with or without skin symptoms, now we call it anaphylaxis, right? Even anaphylaxis could be mild, moderate, even severe, which would lead to cardiac arrest. So it's a spectrum. You don't see a textbook picture of just a case of anaphylaxis. Right? So varying symptoms and signs, you have to have your mind trained to identify or even to suspect if is this the anaphylaxis. Right. Now, how are you going to confirm like whether or like identify between some other condition that led to having a faintish attack, right? Compared to anaphylaxis. One thing is that the onset of fainting is within seconds. But anaphylaxis, it starts immediately, but it takes the time, minutes to hours to develop, right? They continue to have the faintishness or continue to deteriorate, the anaphylaxis patients. But faint patients, they will recover in a while when we lie them flat or raise their legs like that, then they will recover. And fainting people do not have airway breathing circulation, but maybe the blood pressure will drop a little bit. Heart rate may drop. It's more like bradycardia in faintishness. But anaphylaxis, always there is some problem with one of these systems, airway breathing system, or all together, all of the systems, right? So there will be no skin in developments in faint patients, but anaphylaxis, 80 to 90% will have some kind of a skin or mucous membrane symptoms, right? That's how we identify against a faint attack versus anaphylaxis. Now we come to the most important part, which is the management of anaphylaxis. Now, this is according to the Resuscitation Council UK guidelines. They every 5 years, I think they update their guidelines, and the latest is 2021 guidelines. Now, anyone can download this algorithm through Resuscitation Council UK website. Okay, so it's even good if you can have it with you, but I will discuss each step by step from the next slide, right? Just remember there's an algorithm. So the moment you identify a patient now is not doing very well, right? You learned this yesterday, how to identify like deteriorating patients, how to monitor and identify all this. Now, if you see a patient or if your nurse calls you saying, doctor, this patient is not doing well, what would you do? You have to immediately go to the patient and start assessing, right? How are you going to assess? According to the ABCDE approach. Now, since you are going to be the house officer and only maybe there will be nursing staff around, maybe not. So the very first thing you should do in an emergency situation, right? Now you identify this patient is having some problem. We still don't know what it is, but you know. Then what should you do? You have to call for help. How are you going to call for help? You shout for the people nearby, nurses, minor staff. You get them to your place with the patient. And if no one is there, you can also give a call, right? Especially if you suspect this is a hypersensitivity reaction or this is an anaphylaxis, please call your immediate senior. That is your senior house officer, SHO. Okay, call them immediately so that you won't be managing these patients alone, right? You have to get help. But at the initial step, you will be the only person there. So what should you do? You assess the patient, right? At ABCDE approach, right? You talk to the patient. If the patient is talking back, you are happy with the airway. But if the patient is having stride or difficulty in talking, they have hoarse voice. Now you are you are thinking, oh my, this patient is now having airway problems, right? I have to manage immediately. Now, if the patient is breathing all right, rate is normal, saturating normal, then you're all right. But if the patient is having tachypnea and you can hear an audible wheeze, or you listen to the lungs and you hear a rhonchi, that means the patient is having a problem with the breathing part. Then you check your blood pressure, your pulse, everything. You will identify if the patient is in hypotension, 3D pulse, tachycardia, right? And then you do disability. Disability is you talk to the patient, see what they respond to, their pupils, their blood sugar, right? And then you go into exposure. You expose the patient. And most of the time you will see there is a urticaria, rash or something like that also, right? And then you confirm that this could be a anaphylactic reaction, especially if the patient has had a drug beforehand, right? In the ward, or the patient may have come after taking a drug, like that. The history is also important, right? Now you give oxygen to the patient, apply the monitor, right? And one thing you can do, now your patient's blood pressure is low, that means the preload is not adequate. Even before you get IV access, you can immediately raise the legs, right? Lay the patient flat and raise the legs, so that at least some of the blood is conducted to the thorax, so that there at least some amount of circulating fluid is there in the body, because they are severely vasodilated, right? And they have a high distributive shock. Now you have to give fluids at this state. Now, if the patient is dyspneic, of course, they might not be like, they don't like to lie down. You can keep them seated, but never in an upright position. Okay. Now, whatever you do for anaphylaxis, the drug of choice is adrenaline. You can do other things also at the same time. That's why you call for help and get everyone there. No? So some people will have to get IV access, some will have to attach the monitors, some will give oxygen, right? But what is the immediate drug you have to give is adrenaline. Now this you have to remember, right? Please jot this down, the dose and how to give, so you will save a life. How are you going to give adrenaline? It is given without dilution. You just draw it from the vial itself. Vial is coming with 1 in 1000 adrenaline. You give 0.5 ml of that intramuscularly to the anterolateral aspect of the thigh, right? That's how you give adrenaline. 0.5 milligram, that means 0.5 ml of the constituents in that vial without any dilution, right? You draw it, you give it to the anterolateral aspect of the thigh. IM, intramuscular. Okay, remember that. Now in children, if they are more than 12 years, you will give 0.5 ml, the same as the adult. 6 to 12 years, 0.3 milliliters, and less than that, 0.15 milliliters, right? If you're going to start with pediatrics, you will have to know this. Please remember this, right? Now you give this adrenaline while continuing the other management, right? What is that? You give IV fluids, right? You can give IV fluids, you attach monitors, continue monitoring oxygen, all that should be ongoing. And if the patient does not improve, right? You monitor now after giving adrenaline, you look at the patient and continue staring at the patient. That's actually what you should do. Now, if the patient's breathing improves, if saturation improves, if the blood pressure improves, you are happy. But not all patients respond like that. Some patients might not improve. They might actually deteriorate further. Their blood pressure will even be reduced the next time you check it. Like that, if there is no response, you can repeat the same dose again in 5 minutes. Same dose again in 5 minutes. 0.5 milliliters of that vial IM to anterolateral aspect of the thigh. Okay, you give the second dose also. Right. So never give IV adrenaline. That is off. It is always IM adrenaline, right? And you can give other treatment also. But nowadays, the emphasis on these other drugs are reduced. In new guidelines, they say, okay, you can give it. But the most important thing is to give adrenaline. So what are these other drugs? Antihistamines, chlorpheniramine, right? Adults, you give 10 milligrams. You can give either IM was as slow IV. What other drugs? Steroids, hydrocortisone. For adults, we give 200 milligrams, right? Bronchodilators, like salbutamol for as nebulization. You can use glucagon in patients who were on beta blockers because they will not respond to adrenaline because their receptors are already blocked by the beta blockers, right? So these are the other drugs you can also give. Right. Now, I told you to repeat adrenaline dose now after 5 minutes if they are not responding, right? Once 2 doses are given like that, IM adrenaline, if still the patient is not responding, we call it refractory anaphylaxis, right? 2 IM adrenaline doses you give, you monitor the patient and look at the response, and there is no improvement. They are in refractory anaphylaxis, right? Then what we do? We have to go for intravenous adrenaline infusion, right? So this, you have to do it in your ward. As the intern, you will have to do this. How are you going to do this? Now remember this thing, what I'm telling you again, very carefully, right? You add 1 vial of adrenaline into 100 ml of normal saline, that is the dilution, and you give from that solution 0.5 milliliters per kg per hour. 0.5 milliliters per kg per hour. So say it's a 50 kilos patient, you will give 25 ml per hour of that solution, right? How are you going to give it? Through whatever the IV access you have, right? Intravenous, peripheral line, that's fine. How are you going to give that practically? You will have to use a burette set. There are always burette sets in your wards, right? Now remember this, 1 vial of adrenaline into 100 ml of normal saline and 0.5 ml per kg per hour. That's your infusion dose. You start that, right? And then if the patient still deteriorates or become very like peri-arrest, very low blood pressures, you will have to intubation, something like that, right? Then you can double the dose. So you can increase it to 50 milliliters per hour if the patient is severely compromised. Okay. Now remember that also. What I want you to remember is the adrenaline dose. Normal IM doses, 2 doses. If no response, IV infusion, 1 vial into 100 ml of normal saline, 0.5 ml per kg per hour. Okay, that's how you give. Now, when you reach this refractory anaphylaxis, you can monitor for about some time in the ward, but you have to know that now the ward-based management is not adequate for these patients. So where should we call at this moment? The ICU. You have to call the anesthetist and the ICU because you will have to give more support to these patients. Like you will have to intubate the patient, right? You will have to start other drugs to maintain the blood pressure. That's what we use in the intensive care units, right? So by this time, when the patient is in refractory anaphylaxis, you have to start the IV adrenaline infusion and then call the ICU and the anesthetist. Remember that, okay? Right. Now remember some of the patients. Now, luckily, if the patient is lucky and you have acted quickly, the patients will recover. But some of the patients have a thing called biphasic reactions. About 5% only get this, right? They will become all right after a while. You treat the patients, you continue the infusion, and after a while their blood pressure improves, their breathing improves, and then you stop your adrenaline also. But some of them, after several hours, may develop the same anaphylaxis reaction again. right? That is called the biphasic reaction. Some, only 5%. Therefore, you should not stop your monitoring of the patient, even the patient becomes all right. At least 24 hours, you have to keep the patient in the hospital, right? Remember that. So your patient is not completely all right after the first episode and you're treating with adrenaline, and if the patient becomes okay, that does not necessarily mean the patient will get a biphasic reaction, right? We will not get a biphasic reaction. Therefore, you have to monitor for that. Okay, remember that also. You have to continue monitoring. Now, what are anaphylaxis is a clinical diagnosis. You can't do tests and wait for the test results to come to manage an anaphylaxis. It is an emergency situation. But later you can confirm whether it's an anaphylactic reaction by doing serum mast cell tryptase. So tryptase is just like histamine. Only thing, histamine does not stay in the circulation for a long time, but tryptase does. That's why we use tryptase to identify whether it's a anaphylaxis reaction, right? How are you going to do this? You don't, you only take a blood sample for this after the initial resuscitation is completed. You should not delay your management just for the taking blood for tryptase, but you manage the patient. Once things become smooth in the ward, you take the blood sample, the first one. Then you have to take another second sample after about 1 to 2 hours of the start of the symptoms, and then a third sample at 24 hours, right? And then those are all serum samples. So you can just collect the blood for a plain sample bottle and then keep it in the fridge, right? Ideally, they should be frozen. But these tests are done in Sri Lanka. In private sector, you can do this anytime. Even in MRI, they have this facility, right? So you take blood for the serum mast cell tryptase. Now, before the discharge of the patient, I told you have to keep the patient for 24 hours now. You have to educate the patient. You have to document very well in your BHT what happened, what drugs you gave, how did you manage and everything. And then you have to inform the patient. Tell the patient for which drug, the most possible allergen for which the patient developed the reaction, and ask them to keep it in their mind. Usually our patients, they don't, so we give it in writing. You have to write a very good, clear diagnosis card. Especially we do write in red if there is any allergy, especially if the patient developed an anaphylactic reaction. You have to document it in their diagnosis card saying this patient developed an anaphylactic reaction to this drug, right? And sometimes in other countries, they give patient bracelets, and some of patients, they even tattoo themselves with saying, I'm allergic to this drug, right? That's good, because if you were found collapsed somewhere and no one is to give the history, and if you have tattooed yourself saying you are allergic to peanuts, fine, that all of our doctors, provided they go according to the ABCDE and reach the E where they expose the patient, right? You look at the patient and you see the tattoo, the patient is allergic to this drug. Oh, you are very happy. You know this is probably an anaphylactic reaction, right? Now, especially in your ward setting, we give a lot of drugs to patients, isn't it? So we don't know exactly to which drug the patient may have developed the anaphylaxis. Then you have to refer the patient to an immunologist. They have other techniques to identify exactly to which drug the patient developed the drug, or any allergen, like even a food item, whatever. They know how to, there are methods of identifying, right? Right. Now, if a patient goes into a cardiac arrest, what should you do? Now, the patients will present as a cardiac arrest, okay? in which case you are now managing the patient in the algorithm of the cardiac arrest management, right? I think today you will learn that later on in another lecture, cardiac arrest management. But now, if your patient goes into a cardiac arrest from anaphylaxis, now you have to do your CPR. There comes the question, how are we going to give adrenaline? Now, adrenaline in a cardiac arrest patient, or whether it's from anaphylaxis or other condition, is always given intravenously. And 1 in 10,000 IV stat bolus, right? That is for a cardiac arrest patient. How are you going to make it? You use 1 vial of adrenaline, dilute it into 10 ml of saline, and there you get 1 in 10,000 IV adrenaline. That still there would be only 1 milligram in it, right? You give it IV when the patient is in cardiac arrest. Your cyclical management of cardiac arrest, you know, every other cycle you give adrenaline, right? Remember this. In anaphylaxis, patients who are not in a cardiac arrest will get adrenaline as intramuscularly, right? Intramuscularly and undiluted. 1 in 1,000 from the vial itself, you draw it and give it. No dilution for anaphylaxis, okay? If the patient goes into cardiac arrest, you have to give the diluted 1 in 10,000 adrenaline intravenous. Please do not confuse between these two, right? And never give IV adrenaline to a patient with anaphylaxis who is not in a cardiac arrest. You will kill the patient by giving IV adrenaline to a patient who is not in a cardiac arrest. So that's why we say give IM adrenaline 0.5 ml to thigh, right? If the patient goes into cardiac arrest, you give IV adrenaline as in cardiac arrest algorithm, right? Just remember that. Now I told you this about the discharging of the patient. Right. Yeah, that's about the anaphylaxis. Thank you for listening. Now, are there any questions? Any questions?
Those who wish to ask questions, you can unmute and ask, or you can use the chat box at the same time.
Yusha, there was a question.
There is one. Is there any place for nebulized adrenaline in severe sorry. Yes, there is a place for nebulized adrenaline in severe bronchospasm, especially not for the bronchospasm, for airway problem. Bronchospasm is a breathing problem. In the airway, if the airway edema is there and the airway is obstructed due to that, and the patient is having noisy breathing, then there is a place for adrenaline nebulization. You nebulize without dilution. You use 5 vials of adrenaline. Just break them down into your nebulizing chamber and nebulize. But if the patient is deteriorating, you would want to intubate the patient, because if you just leave the patient like that and allow the airway edema to develop, the patient may lose their airway and lose the ability to breathe. Okay. There's another question. If two systems are as airways and circulatory power, can we take as? Yes, that's what I informed you earlier, right? Not two systems, whatever, airway, breathing, circulation problems, either one, even one is okay. If there's airway problem, then you say it as anaphylaxis. Patient may have airway and breathing all together, or airway, breathing, circulation, all three, or just circulation, hypotension only, but still you call it anaphylaxis. But if there are no airway breathing circulation, any out of all these three, there are no problems, then you don't call it anaphylaxis, right? Another question, if there is no involvement of the cardio but have rashes ongoing, still do we give adrenaline? No, right? If there is no involvement of A, B, C, then don't give adrenaline. You give your antihistamines, your steroids, those things, because still the patient is not in anaphylaxis. Is it okay to give IV infusion as mentioned earlier using a peripheral vein in resistant? Yes, yes. You don't go and get central venous access at this time. It is an emergency. You give it through a peripheral line. Okay. Yes, it is a peripheral vein you have to use to give the IV adrenaline infusion. Right. Okay, those are the only questions I see. Yeah. Okay, then. Thank you very much for listening. And we have Professor Vasanthi Pinto, Dean of the Faculty of Medicine, University of Peradeniya, here with us. And I welcome her to this program, and I ask Madam Pinto to share with us some of your wise wisdom. Thank you.
Thank you very much, Fuchsia. Roshan, am I being heard, Roshan?
Yes, madam, you are loud and clear, madam.
All right. Thank you very much. Yes, you just listened to a wonderful lecture by one of our bright sparks, Fuchsia. Yeah, so this particular discussion, I should have come yesterday morning, but I could not get in. That's why today. Let me, from the outset, thank to the Ministry of Health for organizing this very vital program. And we have done this for about now 6 years. And there's a big live wire behind this drama. That is Dr. Roshan Fernando. Thank you so much, Roshan. You are a real gem for this program, and you have been continually doing it without a fail. And I must thank the DGHS of the Minister of Health, Dr. Asel Gunodana, who has given us all the freedom to continue this. And all the directors right across, starting from Dr. Panapiti, who was with us from the very beginning when we organized this, and Dr. Priyanka Tapatu, Dr. Sunil Vijaysurya, and once Ayanti was there, and all those people have given us tremendous support to continue this for the last couple of years. And this particular section is done by on behalf of the College of Anesthesiologists and Intensivists of Sri Lanka. And from that, there is a Faculty of Critical Care. With that, I've started this, and then Dr. Bimal was there, and then now Dr. Nandita Vanigasekara is there. And this is under the presidency of Dr. Anoma Pereira. So let me just tell you, I'm sorry about my brassy voice because I'm not well today. So let me tell you the importance of these type of programs. Now, you all have been working or rather learning in a medical school all this while. So you were exposed to somebody's teaching. Probably when you take histories and all, you have your own thinking, but it's always shaped by somebody's thinking, somebody's diagnosis, everything. Now, this is a big milestone in your life because you're moving to an era where you take decisions. You understand you have to take decisions. That's why we are very critical in the final MBBS, because we are letting you to the society to take decisions about life and death. So remember, that's a very big responsibility. And as a medical educationist and all the university people, we try our level best to give you the knowledge, and all the extended staff, Ministry of Health staff, everybody involved to give you the knowledge. But for sure, it is like teaching to learn swimming outside the pool. Now you are being put to the pool, and it is you who has to use all this knowledge and swim properly, right? Okay, so but don't worry, that again is being very well monitored and advised by your own consultants. So you are not legally bound to do any problems or anything it occurs, but they will be covering you. This is also considered as some part of a training. That is why SLMC registration is given after the internships. And with a good comments from your intern consultants, only you are being given that. So that is the fail-safe mechanisms in the Sri Lanka, and we are maintaining that. Now, this is an additional boost to you, as you can very well see, because you have done this study some time ago, and I'm 100% sure it's almost going down now from your brain and forgetting. But don't worry, it's there. It's there. It's just being hidden. So this program will bring that up. When you listen to this beautiful lecture, I was listening to Fuchsia. She explained beautifully with her lovely voice. She explained beautifully. So you remember things, and that's why you have questions. That itself shows what we want you to go to that same memory or whatever the place where you stopped your medical education and to work. So because of the other problems, in between there are a couple of months left. So please dig your past, dig your knowledge, and then you can move forward. Remember, you are given the first baton of the medical workforce of this country, right? You and me and all of us and the ministry together is what we call health system in this country. So you are now having a huge milestone, and enjoy that. This is all the religions say. This is a big merit that we are having there in your religion, my religion, every religion. We say, yes, it is true, because you are taking decisions for life and death. Remember, it is a huge responsibility. The whole nation has given to your hand, and you are responsible for that. That is why you need to be sure about what is the decision you are taking. That's why these type of lectures are given. If you see the topics of lectures that we have decided are important for you, like how to give adrenaline, what is anaphylaxis, things like that. So with all these things, we are going to strengthen your hand to go through this. And don't worry, the colleges and your supervisors and everybody there to help you. The other thing is, you have to step stone for your postgraduate studies also during this period. So identify your weaknesses and strength. Some people, like my case, I thought I'll do pediatrics. So then I went for the internship for pediatrics. But when I'm doing the pediatrics, I realized this is not the field for me, because I get very emotionally disturbed with the children. So I decided that's not the field for me. Like that, you will discover yourself. You will discover yourself as a doctor. And that is also some message you have to get during this internship period. So thank you, Roshan, very much, and Nandika, and all the lecturers, my lecturers, they are Piyushan, including everybody. And this program has been going for some time. And thank you so much, Roshan. You are a real gem for this program. Thank you very much, and all the very best to you all. Thank you for joining the family of healthcare in Sri Lanka. Thank you very much. Over to you, Roshan.
Thank you very much, madam, taking time to guide these new interns in terms of their career-wise, giving the wisdom and experience throughout what you gain through your education. So thank you once again, madam. That was Professor Vasanthi Pinto, Dean of Faculty of Peradeniya, and consultant professor in anesthesiologist and intensivist. So thank you very much, madam. So I would like to go thank Dr. Piyusha Jayawardena, consultant anesthetist, for her detailed lecture on anaphylaxis. So next up is shock and inotropes by Dr. Tusita Jayatilaka, consultant anesthetist at LRH. I think sir have joined. We go to the lecture. Over to you, sir.
Thank you very much. So, I'm trying to share my screen with you.
So I think the connection is not very good. I think there's a small delay.
Yeah, can you hear me?
We can hear you, but it's a little bit breaking up.
Oh, really? Is it not clear? Can you hear me, or is it not clear?
Now we can hear you, sir. Yeah.
Okay. Just a minute. I'm still trying to share my screen with you.
Okay, sir. Right.
Can you see my screen?
It's there, so it's not still moving yet. You can see the.
Can you see my screen?
Still, we can see it's not moving. It's not. No, sir. No, it's not moving.
Yeah. Can you hear me now?
Sir, we can hear you, but it's still breaking up. I think there's a small issue with the collection, I suppose.
Okay.
Now it's better, it seems.
All right. So again, I'm trying to share my screen with you.
Now the voice is clear, sir.
Okay. Okay. Can you see my screen now?
Yes, sir. You can go ahead, sir.
Shock and iron drops?
Yes, sir. Please.
Okay, thanks. So, good morning again, everybody. So, my topic today is shock and iron drops. So, as newly selected interns, in a few weeks or few months, you will have to work in an environment where you are dealing with patient with shock and where you have to use iron drops. So, let's have a look. So, I'm Dr. Tusita Jayatilaka from LRH, consultant anesthetist. So I think in your basic medical education, you know what is shock is. The shock is a status, which is obviously a life-threatening status, where the tissue perfusion is inadequate. So we can classify them into four main types. First, the hypovolemic type of shock. That means the volume status inside the vascular system is less. For example, in hemorrhage or else in diarrhea and vomiting, you will get hypovolemic shock. And then the second type is cardiogenic shock. The meaning of that is the pumping action of the heart is not adequate. So as the heart is not pumping enough, the tissue perfusion is less. So for example, in myocardial infarction or myocarditis or cardiomyopathies, or in conditions like acute valve regurgitation, like in acute MR, you can get a cardiogenic shock. Then comes the obstructive type of shock, where there's an obstruction to the flow of blood. Obstruction can be due to a thing like in lungs, due to a pulmonary embolus, or cardiac tamponade, or tension pneumothorax, or in valvular stenosis like mitral stenosis or aortic stenosis. So that is the obstructive type of shock. Then comes the distributive type of shocks. I think you have just listened to a lecture on anaphylaxis. So that's a kind of shock which we call distributive shock type of shock. So it's basically a massive vasodilatation cause low blood pressure and inadequate perfusion. So the examples are the anaphylactic shock as well as septic shock or neurogenic shock. So I hope you can see this slide. So it's about your blood pressure. So it says, so this is something that you have to keep in your mind in your whole medical career. It says something about the blood pressure. So can you see my this slide clearly? Can you see? Can you hear me? Can you hear me?
Yes, sir, we can.
Okay. So the blood pressure is a product of cardiac output and systemic vascular resistance. That means to maintain an adequate blood pressure, you need adequate cardiac output as well as adequate systemic vascular resistance. So keep them in your mind, this important equation. So coming into the inotropes, the meaning of inotrope is a drug that can alter the contractility of the heart is called an inotrope. So inotrope can increase the contractility or reduce the contractility. The inotropes that increase the contractility, we call them positive inotropes. The drugs that reduce the contractility, we call them negative inotropes. So usually when somebody talks inotropes, is usually positive inotropes. So what are the examples of these positive inotropes? Dobutamine, adrenaline, dopamine. So they all increase the contractility of the heart. On opposite, the negative inotropes like beta blockers, like for example, propranolol, will reduce the contraction of the heart. So how these inotropes increase the blood pressure? The inotropes increase the contraction of the myocardium, so it will increase the stroke volume. By increasing the stroke volume, it will increase the cardiac output. So as we seen in this formula, increasing cardiac output means increasing blood pressure. So that's the mechanism. On contrary to that, the vasopressors, sometimes these vasopressors are loosely termed as inotropes. That is wrong. Vasopressors, as the name implies, it will contract the vasculature or reduce the diameter of the blood vessels, or it will increase your systemic vascular resistance. So vasopressor, as the name implies, press or squeeze your blood vessels. So what are the examples? Noradrenaline and vasopressin. So sometimes people can call them inotropes, but scientifically they are not. They are vasopressors. So how do they increase your blood pressure? We'll go back to this equation again. So blood pressure is a product of cardiac output and systemic vascular resistance. So due to vasopressing, the systemic vascular resistance will go up, hence your blood pressure will rise. So that's the mechanism. Okay, so these inotropes, how do they exert their action? So for these inotropes to act, there are specific receptors. These receptors are obviously in the cardiovascular system. Some of these receptors are in the heart itself, and the other receptors are in the blood vessels. And interestingly, some of these receptors are outside the cardiovascular system as well. For example, they are in the brain for different reasons. And we all know that some of them are in lungs, in the bronchi. For the vasodilatation, there are beta-2 receptors for bronchodilation, I'm sorry. So although they are mainly in the cardiovascular system, they can be outside the cardiovascular system as well. So what are these receptors? The alpha-1 in your blood vessels, the alpha-2 in your brain, the beta-1 in your heart, the musculature or the myocardium, and the beta-2 again in your heart as well as blood vessels as well as in your bronchi. There's another receptor which is different to all these four receptors that I have described. It's called V1 receptors. It is for the action of vasopressin, or sometimes we call it ADH. So that's the action in V1 receptors in the blood vessels, which will cause vasoconstriction. Okay, now I think I have given some knowledge to you about the theory part. Some of the theory knowledge is given. Now we'll go into some practical scenarios where you will be encountered in few weeks or in few months. You will have to see these kind of patients in your ward, in the theater, maybe in ICU or in accident service. I think your support is needed in any place that I have mentioned. So we'll go to one of these examples. That is our scenario 1. So this is about a young man, a 25-year-old person without any significant past history, is now admitted to the accident service after road traffic accident. Is having cold and clammy pulses and is tachycardic with a heart rate of 120 per minute, and the blood pressure is low, is about 82/68. So if you look closely, you can see his tachycardic is 120, and if you closely observe the blood pressure, the systolic is 82, which is low, and diastolic is 68, which is not that low, and actually it has come up. And if you see the difference between the systolic and diastolic blood pressure, it's only 14. So that means the pulse pressure is narrow. There's a feature of vasoconstriction, which is a classical thing that is happening in hypovolemic shock. So they have confirmed a liver laceration, which should cause a massive amount of internal bleeding. So after the abdominal scan, they have confirmed this patient is having liver laceration. So these kind of patient you will be dealing. So how to deal in this clinical scenario? So although we are our today's topic is shock and inotropes, we'll go to our basics. So in this kind of scenario, you have to adopt something called ABCDE approach. I think this was discussed in the earlier lecture as well. So any emergency situation as this one, so go for ABCDE approach. You know what it stands for. A is for your airway, B is for your breathing, C is for your circulation, D is for your disability, that is your nervous system, and E is for exposure. So once you go through these patients A, B, C, D, E, at the level of C, you understand the problem with the circulation. So what is the problem in your circulation? It is hypovolemia. How do you know that? Patient is tachycardic, patient is having a cold and clammy pulses and with a narrow pulse pressure. So what should we do? Should we start inotropes? No, the problem is hypovolemia. So replace the lost fluid with some fluids. whatever available fluids at that moment. Until the blood comes to you, you can start normal saline or Hartmann. You can give crystalloids. So we commonly call them as crystalloids until your blood and blood products are available. So if the blood pressure is low, is there a place for inotropes? Yeah, as I mentioned previously, you have to wait until the blood pressure stabilizes to some extent with your fluids, because the blood vessels are already vasoconstricted, so no point of giving vasoconstrictors further. So after your adequate fluid resuscitation only, you can think about starting an inotrope or a vasopressor. So although this patient has bled a lot, there are similar, this patient obviously going into the surgical unit, but in other units where you have to work like in obstetrics, patients can get a antepartum hemorrhage or postpartum hemorrhage, and even in the medical wards, patients can get diarrhea and vomiting and can go into similar scenario. So that is our case number 1. So we'll go to the next clinical scenario where there's a 64-year-old smoker with a past history of hypertension, now presented to the ward or the cardiology unit with tightening left side chest pain, and the pulse rate is 92 and the blood pressure is low. Blood pressure is 74/46, that is quite low, and they have done an ECG which shows non-ST elevation. So when you are working in medical units, you will daily encounter such events in your on-calls or even in your non-on-calls sometimes. So patient is having a low blood pressure, now in a shock status with failing heart. The pumping action is failed. So how to deal? Again, this is an emergency situation, patient's life in danger. So go through your ABCDE approach. You have to call for help, senior help. You call for your SHO. You call for your registrar or senior registrar or consultant. So follow your ABCD approach. When you are following, you find there's nothing wrong with the airway, breathing is okay as per this scenario. And when it comes to the circulation, you find there's a problem. Blood pressure is low, and after the ECG and with the clinical scenario, it matches with the pump failure due to MI. So how to deal? Since the heart is now pumping action is affected, you have to increase the pumping action. So you have to start positive inotropes like dobutamine to support the myocardium, so it can pump more blood out. But mind that despite doing that, you will get a good blood pressure with these inotropes, with dobutamine or a bit of adrenaline. But at the same time, it will exert whatever the available myocardium which is still living. But for the time being, it's good to maintain blood pressure with a kind of inotrope. So would you like to give a fluid bolus before starting inotropes? Because to get ready the inotropes, to prepare the thing, it will take some time. So until that time, sorry, it was some disturbance was there. I'll come back. Can you see my slides? I'm sorry about these disturbances. I hope you can hear me.
Yes, sir.
So we were in this slide where our question was, in a situation where there's MI with a pump failure, is it all right to give fluid bolus? Because it will take some time to prepare the inotrope and start the inotrope. Okay, so you can give a bit of fluids, but be very careful because patient can easily go into fluid overload and pulmonary edema. So with tight monitoring, with good observation, you can give a bit of fluid until the blood pressure stabilizes, but not much, maybe 250 ml. So this is a classic example of pump failure or cardiogenic shock. The other examples would be similar situation can happen in cardiomyopathies and myocarditis as well as acute valvular regurgitation. Okay, so we'll discuss about this particular inotrope, dobutamine, which is a synthetic inotrope. So that is, we are not producing this inotrope in our body. So it will stimulate your beta-1 receptors in your cardiac, in your myocardium. So your vial will look like this. It's a it comes as a 20 it comes as a 250 milligram vial. So you can start the dobutamine and start you can give it up to 20 mics per kilogram per minute. So how to prepare it? You have to use a syringe pump where you can dilute it up to 50 ml with normal saline. And ideally, you have to have a center line, which will take some time for you to organize. So until then, is it all right to start dobutamine through a peripheral cannula? Yes, but only for a short time. You have to use a large bore cannula, and also you have to organize a central venous catheter because we cannot give any inotrope or vasopressors continuously through a peripheral line. So what are the problems? As it causes vasodilatation, although it increases your myocardium contractility, it will increase your stroke volume. On the other hand, it will cause vasodilatation in a way that is good because your afterload will be reduced and heart will find it easy to pump out blood. But due to the vasodilatation, your diastolic blood pressure can again go down. And also you will get a reflex tachycardia due to vasodilatation. Also, dobutamine is arrhythmogenic, so you have to monitor your ECG. So, like many other inotropes, it is metabolized by monoamine oxidase system as well as catecholamine methyltransferase system. So that is your dobutamine. So we'll go for another clinical scenario. Number 3, a 72-year-old lady with a history of diabetes mellitus is now admitted to your medical ward with fever, cough, and altered level of consciousness. And the pulse rate is 104 per minute and blood pressure is quite low. If you look closely at the blood pressure is 76 over 32, you can see the systolic blood pressure is clearly low and diastolic blood pressure is very low. So the low diastolic blood pressure has made the pulse pressure it's not low. The pulse pressure is around 50. So if you feel her pulse, you will feel bound impulse. So this is a classic scenario of sepsis and septic shock. So why we call it sepsis? So they have done a chest X-ray and find a source. They have found a source for this infection, that is pneumonia, that is your lungs. So this patient is in now septic shock. So how to manage? This is again a clinical scenario where we can label it as an emergency. So go through your ABCDE approach, call for help, call for seniors. You go through the airway, you go through the breathing. Breathing may be a bit compromised because of the pneumonia. So you might have to give some oxygen. When you comes to C or circulation, you find the patient is having low blood pressure and pulse pressure is high, bound impulse, having fever, having cough, and pneumonic features in the chest X-ray. So your diagnosis is septic shock. So here the problem is acute vasodilatation causing reduced SVR. So what we can do? So if the vasodilatation is happening now, we have to vasoconstrict to make the vessel caliber back into its original level. But in this kind of septic shock, we have to have some fluids because they are dehydrated, they are having fever. So we need to give fluids, quite a generous amount of fluid. Actually, in sepsis, in septic shock, you have to give like 30 ml per kilogram dose. So it's a normal average person of 70 kilogram. This is well over 2 liters. So you can give plenty of fluids in sepsis. Sometimes, hopefully, if the patient is good enough, then the blood pressure could be resuscitated up to the normal limits only with fluids. But in otherwise, we have to go for a vasopressor. So what is the preferred or drug of choice vasopressor in sepsis? It is your noradrenaline. In case if you can't find noradrenaline or there's any contraindication, you can go for vasopressin. So similar scenario, you can get similar scenario in vasodilatation and shock. You can get in anaphylactic shock, but mind that the drug of choice is not noradrenaline. In that case, it's adrenaline. You are taught about that. And in neurogenic shock, where there's a damage to the spinal cord, you will get low blood pressure. And then we'll discuss about noradrenaline. So unlike dobutamine, it is a endogenous vasopressor. It's an endogenous vasopressor. So it will stimulate alpha-1 receptors in your blood vessels, which will cause vasoconstriction. By means of vasoconstriction, it will increase your SVR. So you have to prepare this drug, noradrenaline, again in a 50 ml syringe. You have to run that through a syringe pump. I know that in some of the wards, you can't find syringe pumps due to various reasons. In that case, you are allowed to use a burette, but be mindful until you have to try and find a syringe pump. So with what we are making the noradrenaline, you can use normal saline. So what is your dose? You can go up to 6 micrograms per kilogram per minute. So what dose what is the limiting dose? Even before you reach this 0.6 mics per kilogram per minute, if the patient's peripheral circulation is compromised, because due to severe vasoconstriction, your peripheries will be looking bit black and your toes can get bit of dusty color and it can cause necrosis. Then it's time not to go up your dose further. So what are the other side effects? It can cause bradycardia due to reflex bradycardia, and it can cause arrhythmias. So like dobutamine, it is again metabolized by monoamine oxidase and catecholamine methyl transferase metabolic systems. So unlike I mean every inotropes or vasopressors should be started with a central line. You are excused for a few minutes or probably 1 hour until you organize a central line through a peripheral line. But noradrenaline, you should. I'll tell you not to start with a peripheral line. You have to have a central line because otherwise your veins can get damaged. So we have to call the ICU. We have to call the anesthetics team and get your support for a central line in the ICU or in the theater. So this is your noradrenaline vial. It comes as an ampule, so amber in color. It is 2 ml, and that 2 ml you get 4 milligrams of noradrenaline tartrate. And when you take out the tartrate part, the absolute amount of noradrenaline that in that ampule is only 2 milligrams. It's an important point because you can get confused. Although it mentioned 4 milligrams, actually it is having 2 milligrams of noradrenaline inside. Okay, when we come to vasopressin, it's also called antidiuretic hormone. It is produced in the hypothalamus in the brain, and it is secreted into the posterior pituitary part, and it is stored there, and it's not a catecholamine. So it's different to other vasopressors and other inotropes. So it's a naturally occurring hormone. It's a potent vasoconstrictor. This is a second line drug to noradrenaline in sepsis. So you can go up to 0.04 units. So it's not coming in milligrams, it's coming in units. So we know that hormones like insulin, like other hormones, we are measuring that in units, not in milligrams. So you can give vasopressin 0.04 units per minute as an IV infusion. You can dilute vasopressin in normal saline. The side effects, it will cause hyponatremia because it is ADH, and it will cause fluid retention in your body so that your sodium levels can go down. And also it can cause bradycardia. So unlike other catecholamines, it is not metabolized in COMT or monoamine oxidase pathways. It is metabolized in protease in the liver. So like noradrenaline, you need a central line to start. So this is your the vial of your vasopressin. It comes in 20 units per ml concentration. So now we are going to the last scenario where there's a 32-year-old lady admitted following dog bite to your let's say to your accident and emergency section. So after a couple of minutes administering this ARS, the patient is now complaining of faintishness, and pulse rate is 92, and blood pressure is 72 or over 36, and now patient is having erythematous generalized rash. Another point I want to mention in this kind of scenario, because this looks like anaphylaxis. So listen to the patient chest, and you may hear some bronchi. So this is obviously your anaphylactic shock. I think you have taught more than enough in the last presentation, so you know how to manage. So again, it's an emergency, call for help, follow the ABCD approach. So you will find that airway is all right, breathe in, there may be a few bronchi, so we have to attend to that. And at C, you find the blood pressure is very low due to acute vasodilatation, reduced SVR. So how to manage? So you have to give fluid again due to the vasodilatation, and drug of choice here is IV adrenaline, OIM adrenaline. So follow everything that the previous lecturer, Dr. Piyusha, has taught you. Follow everything. The drug of choice is adrenaline. You can give it either IM or IV. So adrenaline is a naturally occurring catecholamine in our body. It is being produced in our adrenal medulla. So it's a very popular drug. Everybody knows about adrenaline, and it's cheap as well. So when you have a choice to make between two inotropes, if you can give both of them, then go for adrenaline because it's cheap. So from the adrenal medulla, it is released to the bloodstream in fight scenarios in our evolution. So it will stimulate all those receptors where I have mentioned, alpha-1, alpha-2, beta-1 and beta-2. So you will get a lot of effects as well, a lot of side effects. The only receptors that it will not stimulate will be your V1 receptor that's meant for your vasopressin. So you can go doses up to 1 microgram per kilogram per minute. At lower doses, it will cause vasodilatation. So the action of adrenaline depends on how much you are giving it. So at lower doses, it will cause vasodilatation. That is due to beta 2 action in the blood vessels. But when you increase the dose due to alpha 1 action, it will cause vasoconstriction. So you have to mind about your dose as well. So again, as other inotropes or vasopressors, you have to prepare that in normal saline, in 50 ml syringe. You have to use a syringe pump. The side effects, there's a profile of side effects from tachycardia to any arrhythmia, palpitation, tremors, hypo or kalemia. You can get all of this. It is again metabolized by the monoamine oxidase and catecholamine methyltransferase systems. So that's about adrenaline. So this is your adrenaline. You should be very familiar with that. You should know where your adrenaline ampule in your ward. When you are working in theater, where you should know where it is in your theater. Any place where you are working, you should know where it is. And sometimes for emergency patient, you have to prepare it in case, because anything can happen. Another inotrope which we are using in our clinical setup is dopamine. Dopamine is expensive. It's a positive inotrope. It will increase your cardiac output, and it, in addition to the beta receptors that it will act, it will be acting on the D receptors as well in the splanchnic circulation, which will cause splanchnic vasodilatation. I don't want to confuse much, but just know that there's an inotrope called dopamine, which is never a first-line drug, first-line inotropes. As a second-line inotrope, you can use that. Even we can just keep in your mind there's a drug, there's an inotrope called dobutamine. So finally, I want to go into some general principles when you have to use an inotrope. So first thing, now we have gone through 4 clinical scenarios, and you have, I hope that now you understand that there's a way that you have to use inotrope. You have to match the clinical scenario with your inotrope. You have to choose your inotrope matching to the clinical scenario. And before you start, because sometimes by giving fluids alone, you can settle your blood pressure, especially in hypovolemic shock. You have to give fluids before you're starting inotrope, or you may not, you don't have to start inotrope at all. But in cardiogenic shock, be very careful. Third point I want to raise here is the fact that you need to organize a central venous catheter before you're starting inotrope. Ideally, I know that in clinical scenarios in the ward, you can't do it quickly. It will take some time. So with taking all the cautions and precautions, you can start to inotrope cautiously through a peripheral line. You have to have a large bore cannula, and you have to insert that large bore cannula into large bore vein. So organize your central venous catheter, talk to your anesthetist or anesthetist in the ICU, so they will help you. So once you start an inotrope, you have to monitor. The monitor should be invasive, ideally. So patients who have on inotrope should be ideally in the ICU, where the invasive monitoring takes place. But we know that we cannot provide ICU beds for everybody. So in the ward setup, try to use maximum amount of monitoring in your ward. Make use of the bed 1, where the highest monitoring and highest nursing care is available. So monitor your saturation, monitor your urine output, monitor the ECG, and if blood gases are there, do the blood gases. And ideally, you should have a central venous catheter as well as an invasive arterial line to monitor the arterial blood pressure. Then the other thing is you have to have a syringe pump. You can use a burette where the titration of dose may not be very accurate. So try to find the syringe pump whenever you are using inotrope or a vasopressor. And finally, inotropes comes with a large profile of side effects. So we have to use the inotropes and vasopressors knowing that these are the complications. Some of these complications can be life-threatening, like arrhythmias, myocardial ischemia, peripheral tissue necrosis, and electrolyte imbalance. So with that, I wind up my presentation. If you have any questions, you can ask. Do you have any questions?
So could we have the slides, please, if you don't mind, for our reference?
You want me to have the presentation? Sorry, I didn't get your question. Somebody had a question, but I did not understand. If you want this presentation, I can share it with you through the ministry. Yeah, the question was, could we have the slide, please? Yeah, I can give it to Mr. Roshan. And Roshan, are you there?
Yes, sir.
So if I give this presentation, can you? I don't know. Is there a way of?
Yeah, we will share it later. Yes.
Yes. Okay. So, any more questions? So I wish you all can begin now. Dr. Nandika.
Yes, thank you, Doctor. Yes.
Thank you very much, sir, for the detailed lecture. So next up is a lecture by Dr. Pandula. Dr. Pandula. Sorry. Next lecture is by Dr. Pandula Jatulika, consultant anesthetist joining from UK. Over to you, sir.
Thank you, Roshan. Can you hear me?
Yes, we can hear you, sir.
Right. Yeah, let me share my screen. Can you see the screen now?
Yes, can see, yes.
Right. Good morning, everybody. So thank you very much, Ministry of Sri Lanka and Ministry of Health Sri Lanka and College of Anesthesiologists for giving me this opportunity to do this lecture again. So this lecture, I'm talking about general care of ICU patients. So now when you admit a patient to the ICU, you are admitting for a specific reason, maybe for a ventilator support, maybe for anthropic support, maybe for any other organ support. So while you are treating the main organ failure or multiple organ failure, you have to look after the general well-being or general aspects of the patient as well. So I'm talking through in this lecture about what are the aspects we have to generally look after, specifically in a critically ill patient during your ICU stay. So here I'm going to talk about 5 main areas like nutrition, physiotherapy, DVT prophylaxis, prevention of bed sores, and stress ulcer prophylaxis. Starting with nutrition. So nutrition is important for all the any living being, not only for any critically ill patient, any patient or any person. Nutrition is very important aspect, and we shouldn't forget about when patient admit to the ICU, the nutrition aspect. Why it's important in critically ill patient is there's increased energy utilization and catabolism when you compare with another patient who is not critically ill. And because of this critical illness and increase in energy utilization and catabolism, they are more prone to muscle wasting and weakness, and increased risk of infection and impaired wound healing. And altogether, it contributes to prolonged time for the recovery, prolonged stay in the ICU, also with prolonged mechanical ventilation. And so the patient's mortality morbidity will be high if you don't address the nutritional requirement, specifically in critically ill patient. To avoid these complications, what is recommended is you have to consider the nutrition therapy or start in nutrition in all the patients in the ICU, specifically if they are staying more than 48 hours. So you can assess using a MUST tool for screening of nutritional requirement in ICU stay. Now you have 2 ways of delivering the nutrition. One is through your normal pathway of, from your gut. So what we call is enteral feeding. The other method, I will come into detail, that is parenteral feeding or the nutrition, where you administer parenteral nutrition therapy through an intravenous line. So if patient cannot take orally by patient self, we can think of putting an NG tube or a nasogastric tube or a nasojejunal tube and starting nutrition. And so generally the type of feed would be a continuous feeding rather than intermittent feeding. So if there is contraindication for enteral feeding, the parenteral nutrition should be considered within 3 to 7 days. That is the general guideline. When you consider the nutritional requirements in a critically ill patient, you don't need to remember these numbers, but generally the energy requirement usually it would be 25 kilocalories per kilogram. So you have to take the patient's body weight and get the numbers. And carbohydrate, protein, fat. So you have to consider about all the major nutrition, the nutrients, as well as other trace elements, electrolytes, as well as the water requirement. So the type of and the amount of nutrition feed depends on the state of the patient. So like some patient might be having certain organ failures like renal failure, patient may be with diabetes. So nowadays we have doctors who are specifically trained on nutrition to assess these patients in the ICU and decide on what type of feed is needed for that patient, the energy requirement, the protein, another trace element requirement, and electrolyte requirements, and the tailor-made nutrition therapy will be given to the patient. Then the nutrition, starting nutrition in the ICU is not without its own adverse effects. So there's risk of aspiration, especially if patient has problem with the emptying of the gut. So there may be delay in gastric emptying, as well as patient might not have protective cough gag reflexes, as well as patient sometimes might be with low conscious level, maybe because of the disease itself, or maybe because of your sedative medication. So they are at risk of sometimes more risk of aspiration. So you have to consider that, and if there is risk, you have to think about protecting the RV, maybe sometime with intubation. And shouldn't feed too much, so it can result to overload of maybe water or maybe other nutrients. And there's a special condition called refeeding syndrome, a person or patient who has not been fed for some time. And when you start to feed, they will end up sometime with the refeeding syndrome, where you see the change in the electrolyte levels, change in the potassium, phosphate levels. So they might have some hemodynamic instability with the refeeding syndrome. So in these patients, if you see that starting a normal feed is at risk, you have to always go with the less amount of energy and other nutrients to avoid refeeding syndrome. Hypoglycemia, the level of the glucose level you have to monitor to prevent hypoglycemia. Dehydration, if you don't give enough water, they can have dehydration or inadequate fluid intake. And electrolyte abnormalities may be potassium, sodium, calcium. So all the electrolytes you have to monitor, even phosphate, when you are treating specifically, if you are treating with parenteral nutrition. So the enteral feeding, if there's problem with gastric feeding and intolerance, we can start with some prokinetics such as metoclopramide or erythromycin. So the first line recommended would be actually erythromycin, then the metoclopramide. And certain condition you have to delay enteral feeding, such as if there's a gastric residual volume more than 500 ml. Within 6 hours. So if the NG aspirate is more than 500 ml, you consider there is delay in gastric emptying. And if patient have upper GI bleeding and high output intestinal fistula, bowel ischemia, abdominal compartment syndrome, uncontrolled shocks, where patient is on high dose of vasopressors, this condition you might need to consider delaying enteral feeding, and the option would be parenteral feeding. Now, this is a flow chart which can be used to decide which way you are going to start feeding. When you look at it, it looks like a bit complicated, but we can go by one each. Now, you can see we will start from this left upper corner. Should the patient be fed via stomach? So if patient, now I have mentioned some conditions where you might see, but so if there's no risk of nutritional deficiency and cardiovascular is stable, and you can think about going for enteral feeding. But if there are conditions where a patient has absolute contraindication for enteral feeding or gut feeding, you are straight away going for total parenteral nutrition, where you see on the left side, right? And if patient is cardiovascular stable, and you can wait for some time, and whether you can start with orally or the enterally, Yes, and if they can feed themselves, you allow patient to eat by themselves. And if patient has a relative contraindication for enteral feeding and they are not at high nutritional risk, you can wait for 48 hours before starting feeding. And if patient can start after 48 hours, then you allow patient to eat themselves. If patient cannot eat themselves, we can think about putting an NG tube. And you start with trophic enteral feeding, where you start with less amount of enteral feeding, not the full amount, with prokinetics help, and see whether they are tolerating the enteral feeding, NG feeding. And if they are tolerating, you can start or go for a full enteral feeding with some prokinetics. And during the enteral feeding, if you see that patient is not tolerating enteral feeding, you have seen that there's high gastric residual volume, vomiting, diarrhea, or any other condition which developed, which you cannot give enteral feeding, then option would be going for total parenteral feeding again. And if patient is not tolerating, you can come down on your enteral feeding volume. And you can see if the low volumes are tolerating, you can give some enteral feeding low dose plus supplementary parenteral nutrition if patient is really in need of nutrition therapy. So this is sort of a guideline which we use generally in the ICU to treat the patient with, to start nutrition therapy. Now, I think you have seen and might done sometime as a medical student, the NG tube insertion. So before inserting, you have to get the length from nose to the tragus, and then from there to the level of the CP sternum, over the stomach, the length, and you have to insert up to that length the NG tube, and you have to secure it after inserting. The important thing is you have to confirm the position of the NG tube before starting feeding. Because if it's in a wrong place, for an example, in the lungs, you will cause a disaster. Giving food or anything through the NG tube to the lungs will cause a major problem. So always we need to confirm that the NG tube is in the correct place. It is in the stomach. So the gold standard of confirming the position of the NG tube is using chest X-ray. This is the recommended method, but there are some other methods can be used. But so the one method would be aspiration for the stomach contents. And sometimes we used to do this whoosh test where you inject some air using a large syringe and auscultate it over the stomach. But it's not very well recommended practice, even though you can use. And but the recommended gold standard method would be using a chest X-ray to confirm the position. Also, you can use gastric pH and to monitor or check whether it's in the stomach. Yeah, so safety in NG feeding is you have to confirm the position, keep the patient head up in 30 to 40 degrees during a feed. This will prevent the aspiration to a certain degree. And if patient is intubated on tracheostomy, checking the cuff inflation pressure of the tube will reassure you that it's inflated, and it will prevent the aspiration of gastric content. And you have to aspirate NG feeding every 6 hours, and if it indicates intolerance, this aspirate you have to put it back, rather discarding, because otherwise you will lose some electrolytes and fluids. So nowadays there are continuous drip feeding pumps where you can program the flow rate. And usually we start with, if you are going for low dose enteral feeding, about 10 to 20 ml per hour of NG feeding, continuous feeding. And gradually you will increase when they are tolerating the NG feeding up to the level you want, like maybe 50, 60 ml per hour, the NG feeding. Now, if patients cannot be fed enterally, the option would be go for parenteral nutrition. So the venous access is needed for this. You can use peripheral line or central intravenous line. So it should be a dedicated line, whether it's a central line or a peripheral line, because the infection is a risk which when you using a line for parenteral nutrition. And it has to be kept, the line has to be kept clean, covered, and keep it dedicated for nutrition only. And before connecting, you have to check the preparation is not expired, not discolored. And because if especially the infection risk, you have to be avoided as much as possible. During handling, you have to make sure hand hygiene and sterility is maintained all the time. Moving to the second aspect, the deep vein thrombosis DVT prophylaxis. DVT is formation of clots in deep veins at the site of blood vessels, especially in lower limbs, specifically around trauma and around intravascular catheters, because these are the conditions which can lead to sluggish flow of blood through your deep veins. What happens is, when there's a sluggish flow, there will be clot formation, and these clot can break through and can result embolism, which is called pulmonary embolism, which can lead to life-threatening condition called massive pulmonary embolism and instability and death. So the identification of risk patient need to be done, even in the wards. So not when the patient entered to the ICU, right? So you have to identify who are the patient at risk of developing deep vein thrombosis. So what are the risk factors? So I mentioned the indwelling venous catheters, central lines, and patient who is having major surgeries such as abdominal, pelvic, and orthopedic surgeries, major traumas, especially trauma to lower limbs, patient with malignancies, pregnant mothers, any patient who has history of DVT is at risk of developing DVT again, and also obese patient. So the risk patient can be assessed using a score, which is commonly used one is Wells score. So the same conditions, most of which I have mentioned, is there in this score. And you have to assess whether patient at risk. And if a patient is having one or more points in this Wells score, we consider at risk of developing DVT. So how you can prevent? So prevention is better always. You have to encourage early mobilization and physiotherapy, keep patient well hydrated, and you have methods which are two main methods of prevention: mechanical methods and pharmacological methods. Pharmacological methods, the commonly used agent would be a low molecular weight heparin. So commonly available ones are enoxaparin. Sometimes you might use deltaparin. So the prophylactic dose, you don't need to remember, but usually would be, for an example, if it's enoxaparin, maybe 0.5 milligram per kg of body weight. That's a commonly one available, and treatment dose would be double that dose. And if patient has any contraindication for low molecular weight heparin, we will be going for unfractionated heparin. And certain other patients, if heparin cannot be used, for an example, there's a condition called heparin-induced thrombocytopenia, which is called HIT. It's called those patients, we consider other alternative like rivaroxaban, fondaparinux. These are other anticoagulants which you can use. And there are contraindications for these pharmacological agents. They can increase risk. They can increase the risk of bleeding. So if patient is already on anticoagulation, such as warfarin or any other anticoagulant, you might not use any active major bleeding and recent any clinically significant bleeding that is within last 48 hours, low platelet, any inherited or acquired bleeding disorder. These conditions sometimes may be an absolute contraindication. There are certain relative contraindications, any risk of bleeding related to surgery, specifically surgery in the head, like neurosurgery or any eye surgery, and uncontrolled hypertension. I'm not going to go through all the list here. So the mechanical methods, sometimes we will be using, because specifically if patient are contraindicated for giving any pharmacological agents, you have to always think about using these mechanical methods. So commonly used method would be using stockings, which are called graded compression stockings. So the graded compression stockings, the word itself explains that you have a gradual change in the pressure, or the highest pressure towards the ankle, and it's gradually reducing towards the knee, and which supports the flow of blood towards the heart. And again, it gradually changes along the thigh. So these are available. And so you have to check the patient's the leg length diameter, and you have to check, get the appropriate size stocking, otherwise it won't serve the purpose. The other method is not widely available, but if patient is riskier than normal, developing DVT, the intermittent pneumatic compression pumps be always better. And certain patients, if you cannot use stockings because of some problem like skin integrity, there are wounds. So those patients, you can think of using intermittent pneumatic compression pumps. So you have to use these inflated bladders or the cuffs around the legs, the thighs, and the calves. And you have to connect to the pump, and which will intermittently inflate and deflate alternatively, and which mimic your muscle pump, which supports the flow of venous blood towards the heart. So the problem would be the availability of these cuffs and the pumps. It might not available widely in all the ICUs sometime. But these also DVT mechanical prophylaxis devices, sometimes you cannot use because of severe peripheral arterial disease, skin grafting, peripheral arterial bypass grafting, severe leg edema, and any allergies or any other local skin problems. Moving to physiotherapy. So physiotherapy is a very important aspect in the critical ill patient. So it's mainly, we talk about respiratory physiotherapy, but it's not only respiratory physiotherapy, but the limb physiotherapy also very important, especially in a patient who have some, who has staying in the ICU for a long time. They need very good rehabilitation, especially with the limb physiotherapy as well. So why patient need physiotherapy, especially in the intensive care unit? Because they are prolonged immobile, and especially because of intubation, they are on ventilator, and so they are at risk of developing respiratory and other musculoskeletal complications. So what's the physiotherapy in the objectives of physiotherapy in the ICU, especially respiratory? is prevent respiratory complication and improve oxygenation. Because patients who are very ill, they are not active, not mobile, sometimes intubated and sedated, sometimes they might be paralyzed. So they are normal physiological mechanism which operate in a normal healthy individual won't be there. So the secretion clearance will be not be there. And when you don't take normal breaths, you tend to have collapsed alveoli, which is called atelectasis. And the idea of physiotherapy is to prevent atelectasis and open up the collapsed alveoli, which is called recruitment, and by that improve ventilation. So when you want to wean, or when you gradually when we want to stop the ventilation, or which call the weaning, we really need the help of physiotherapy. And the musculoskeletal, again, if they are on prolonged ventilatory support for maybe weeks, with maybe because of some other neurological condition, so the limb physiotherapy also very important to rehabilitation. And the DVT also prevention would be there with the physiotherapy. So there are various techniques which can be used in an intubated patient, right? So that we have a dedicated team of physiotherapists who will do this job always, usually at least twice a day, sometimes 3 times a day, especially in any ventilated intubated patient, they need regular physiotherapy. So ventilation alone, medication alone won't be helpful to come out from a ventilation. Always good physiotherapy is important. So there are various techniques which they use for in physiotherapy. And in a non-intubated patient, mobilization from bed to chair and deep breathing exercises, incentive spirometry are various methods which we will be using to support physiotherapy. And another important aspect is prevention of bed sore. So what is a bed sore, or a pressure ulcer, in other words? So it's a localized injury to the skin and underlying tissue, usually over a bony prominence, as a result of pressure or pressure in combination with shear. So it's not an uncommon condition in general ward, because in a general ward, if patient is not mobilizing, not moving, and there will be less nursing care, which is acceptable because there is not enough staffing. But in an ICU, usually if there's a good nursing care, usually you have 1-to-1 or 2-to-1 nursing care, where most of the time patient will be looked after and there is less risk of bed sore in the intensive care. But in a ward, they are at risk. So why they develop the bed sore? What's the pathophysiology? What happens is when there's compression of soft tissue over bony prominence, that will interrupt the blood supply to that skin, and there will be tissue ischemia. And so tissue ischemia, as well as when the venous return is interrupted, there will be edema. So there are vulnerable locations such as over sacrum, coccyx, heel, and ear. So what happens is they will end up with tissue death and then the bed sore. So there are various degrees of bed sore. So always, not in the intensive care unit, even in the ward setup, a patient is not mobilizing, maybe because any medical condition, if they have prolonged with wound, they are at risk of developing bed sore, pressure ulcers. So in ICU, what are the implications? So prolonged hospital stay, high cost for treatment, increased mortality, and it's an indicator of quality of nursing and supportive care in a health system. So always when you transfer a patient to the ICU, nurses will look at whether the patient has already bed sores, because if patient develop bed sores in the intensive care during stay of intensive care unit, that's indicate that there was poor quality of care during the stay. So always it will be assessed and documented when patient admit to the intensive care unit, where the patient comes with bed sore already. So you have to always prevent developing of bed sores. How do you do that? You will assess the risk of developing bed sore, the pressure ulcers. You have to assess the skin and how to manage. You have to support the surface. That's by turning, adequate nutrition, repositioning, and try to wean vasopressors, which can compromise cutaneous skin blood flow. And you have to make sure you have adequate hemoglobin and albumin levels, which will prevent, pressure ulcers. The risk assessment, there are various scales, so details are not really necessary in each scale, but I have taken one scale, which is called the Waterloo Pressure Ulcer Prevention Treatment Policy. There's a score. Because I use this score is, you can see what are the risk factors for developing pressure ulcers. So you can see each condition is given a score, starting with the body weight. So if patient has high BMI as well as very low BMI, it is a risk factor. And the type of skin, whether the patient has edematous skin, discolored, already broken, damaged skin, they are at risk. And the age is a risk factor. So elderly patients, they are not very mobile sometimes, so they are having high risk of developing pressure sores. And the weight loss, as well as patient continence. Whether the patient has fecal or urinary incontinence, they are at risk of developing pressure sores. And with the patients bed-bound or chair-bound, again, they are at risk. And patients' nutritional status, anemia, and also any organ failure, smoking, and diabetes, any neurological conditions with the patient is having paraplegia, all are contributing. So you can add as a score and see whether the patient is at risk, high risk or very high risk of developing pressure ulcers. So you can assess the skin, and we have 4 grades of pressure ulcers. So you can see in the grade 1, there is non-blanchable erythema and skin is intact, but there is discoloration, skin warmth, edema. So this is the grade 1 of pressure ulcer. In grade 2, there is partial thickness of skin loss involving the epidermis and dermis, and it will appear as an abrasion or a blister. So when it comes to grade 3, there is full thickness skin loss involving damage to skin and necrosis, and necrosis in the subcutaneous tissue, and maybe not extended to underlying fascia. But when it comes to grade 4, there is extensive destruction and damage to muscle up to bone. So how to support the surface? So you have to avoid hard surface, any wires, bed railings, which has prolonged contact with the patient. So you have to make sure patient doesn't have any prolonged contact. And you have to avoid creases in bed linen, and especially if patient having some neurological condition, always you have to use air or water mattresses. And you have to avoid skin soiling with stool, loss, urine. So you need to catheterize the patient, and you can use diapers. And also you have to reposition the patient every 2 hours, side to side, and side to supine, and prolonged pressure over bony prominence is the high risk factor for developing pressure ulcers. And if patient already having pressure ulcers, they need surgical debridement, wound cleaning regularly. The last topic I'm going to talk about is peptic ulcer prevention. Sorry. Why these patients are at risk of developing stress-related mucosal injury? Because these patients are in a stressful situation because of their critical illness. And most of the time they will be superficial or asymptomatic ulcers, but rarely it can develop into a large upper GI bleeding. So the reasons to develop peptic or gastric ulcers would be a decreased mucosal blood flow, loss of mucosal integrity, and then it will erode into the submucosa and lead to erosion and bleeding. What are the risk factors? Prolonged mechanical ventilation. If patients on ventilator for more than 48 hours, you have to always think of starting treatment, the prophylactic treatment for peptic ulcers. And patients who are having sepsis after major surgery, severe burns, any major organ failure, maybe myocardial infarction, renal failure, and patients who are on high-dose corticosteroids, all in major trauma, low blood pressure, all contribute to developing peptic ulcers. So what are the options we have? We have H2 receptor blockers such as ranitidine, famotidine, proton pump inhibitors, omeprazole, pantoprazole. So these are the two commonly used prophylactic medication for peptic ulcer development. You can use either of these, but studies found there's, no superior each other is there's no superiority. So you can use either omeprazole or pantoprazole, any proton pump inhibitors or H2 receptor blockers. In addition to these two, you can use a patient is a very high risk of developing peptic ulcers. In addition, you can use sucralfate as well. And for symptomatic treatment, you can use antacids. So enteral feeding is a protective against peptic ulcer formation. That's another advantage of enteral feeding, which I have mentioned earlier as well. It will prevent peptic ulcer development. So that's all for this presentation, which I had to tell. Because going into detail of each section is beyond the scope of this lecture. What I have done here is giving introduction and also brief detail into each section rather than going into detail in each section. If you have any questions, I'm happy to answer here. If not, I think we can move to the next lecture, or I think we have a tea break.
Yes, sir. Thank you very much for that detailed lecture, sir. That was Dr. Pandula Jayatilaka, consultant anesthetist, joining from UK. Thank you for your time contributing for this program, sir. So we can take few minutes to answer the questions if you all are having any. So the meantime, there's a tea break. So we'll take a 10 minutes tea break and join after 10 minutes. Thank you so once again.
Right. Welcome back after the tea break. So next lecture is by Dr. Danushka Liana Gunawardana, consultant anesthetist joining from UK on communication. So are you there, sir?
Can you hear me?
Yes.
Let me share the slides. Can you see the slides, Dr. Roshan?
Yes, sir. We can see you. You are good to go, sir.
Right. Thank you very much. So good morning, everyone. I must thank the College of Anesthesiologists and Intensivists, as well as the Ministry of Health, for giving me this opportunity to speak few words at the very beginning of your career. And hopefully some of these aspects may be helpful along your journey as medical professionals. So communication is a very broad topic, which involves several aspects. I may not be able to give you a comprehensive lecture on that. What I thought of doing is give some important practical tips maybe that is going to be helpful. So what it means, it's a process. It's a process of sending and receiving information by verbal or non-verbal means. So with whom you have to get involved in terms of communication? Obviously, there will be a patient and patient family and staff, or in between staff, you need to communicate. And those involve subtle differences. And we will see as we go along. So let's see why communication in healthcare is important. One important aspect is you can minimize delay, you can minimize errors, you can allay the anxiety of patient and relatives. And it is important to improve patient safety and outcome. Further to that, patient may disclose more important information when they feel confident about yourself. And that enhances patient satisfaction. And it builds a better rapport with the patient and the health professional, and the life becomes much easier for you. Patient is more involved in decision making and may lead to more accurate diagnosis, leads to more realistic patient expectations, and better patient adherence to treatment. And patient have patient will be more open to seeking further health care because they have confidence in you. So when you look at the different types of communication, you can look at it based on the communication channel or based on the style and purpose. When you look at the communication channel, it could be verbal or non-verbal. Verbal communication, again, you could think of in terms of oral communication or written communication. Oral communication, again, could be face-to-face, like you are encountering a patient when they come to ward or clinic, or it could be a distant communication where you are communicating with your seniors over the phone, for example. Based on the style and purpose, sometimes the communication can be very formal communication or informal communication. So you could see different scenarios where communication is taking place. Some of them are very, looks like formal conversation. Some of them are very informal, that tells in their facial expressions, body language, the posture, and things like that. Interestingly, when it comes to communication, you may not appreciate that most of the communication taking place non-verbally, and it's about 2/3. Verbal communication is about 1/3. When it comes to non-verbal communication that involve the facial expressions, the tone of voice, the movements, the way you appear, maintenance of eye contact, the gestures, postures, appropriate silence, and so on. And some of these pictures you can see express, various emotions like, someone's surprise, sadness, anger, frustration, and so on. And that tells a lot. And when it merged together, so you're trying to tell something, and when you have appropriate facial expressions, body language, that will add to the message you are trying to communicate. And various signs like, you can say your victory, your strength, keep your shut, various, none of these things involve any verbal communication, but it's non-verbal. So when you look at the process of communication, it involves several elements. So obviously, it's basically getting a message across. In that process, there's a sender, there's a message to be communicated, there has to be a medium, and there has to be a receiver. And ultimately, if the message is communicated properly, you should get a feedback as well. In this complicated process, things can go wrong very easily. And this is also a similar thing. You could see message, you encode it through a channel, you send it to the recipient, decode, and you get a feedback. There can be several interferences along this process. So if you look at this sort of staircase of communication, so you mean something, and sometimes what is meant is not what is said. What is said may not be what is heard. What is heard may not be what is understood. What is understood may not be what is done. I'll tell you an example. When I started my career as a post-intern doctor in one of the ICUs, I asked the bedside nurse who was looking after the patient to give amiodarone bolus because patient was running a narrow complex tachycardia. So amiodarone, as you may all know, you initially load it with about 5 milligram per kilogram or 300 milligram bolus. Bolus means you run it over 20 to 30 minutes and then followed it by infusion for another 24 hours. So the nurse heard the word bolus, but in his mind, it was a rapid bolus, not the bolus I meant. So he gave bolus like one go, and then patient next moment went into severe bradycardia and asystole, and we ended up in resuscitating the patient. So likewise, what is meant, so you have to make sure what is meant is being communicated and you get the feedback properly. So in this process, for you to communicate effectively, listening, active listening is also an important aspect. Listening can take place in different, levels. So sometimes you may just ignore. So physically you are in the same space, but you are mentally, in your mindset, you are engaging in an entirely different thing. So sometimes you may pretend to listen, but you want to speak up your thoughts. So that's also not good. Selective listening, well, in your own sort of, frame of reference, you accept things, but otherwise, so you are waiting to disagree. Attentive listening, yes, you pay attention and you try to listen to understand what this patient is taking. So there's some engagement there. And empathic listening or active listening is the best form, right? So there you listen from the other person's frame of reference. You sort of pay undivided attention to the person, and you provide verbal acknowledgement. Maybe you come out with insightful, thoughts. So more engagement is there. And that is a very important skill in your communication. So A message is considered only communicated if it is both sent and received. So I already highlighted meant is not what is said is not heard, heard may not be what is understood, and understood may not be what is done. So there can be a gap in this communication. So you always mind that gap. Right. So I'll tell you two scenarios which were my first-hand experience, and that gives some insight to you why this is important. So the first scenario is when I was anesthetic registrar, I got a call from my relative saying one of my aunt, who was in mid-70s at that time, got admitted to accident service following a fall, sustaining a fracture neck of femur. And her concern was, patient was there in the ward for some time, but nothing being done. So it was in the middle of a theatre list. So after completion of the theatre list, I went there. And as I entered the cubicle, she looks comfortable with the traction in place. And when I spoke to her, she didn't have any major concerns, went through the BHT, analgesics being prescribed, basic investigations done, echo was planned, and it was a Friday, and patient was fixed for a theatre list on Monday. So even if I was the medical officer there, I couldn't think of anything else that can be added to the management. But despite that, the relatives were not very happy about it. So probably the medical team was either too busy to communicate what's being done and what's happening, or despite they're trying to, educate or communicate, the relatives may not have understood. So there can always be a gap. So take, despite all your hard work, it may not lead to patient relative satisfaction unless you take, a little time to emphasize what is being done. The second scenario is something opposite to that. Again, during my internship in one of the tertiary care obstetric unit, a young lady in her mid-20s admitted for confinement at 40 weeks POA. She was a primate. She didn't have any antenatal issues. So unit policy was to induce at 40 plus 5 days. At 40 plus 2, one of the evenings, she has complained of non-specific abdominal pain. So examine, no contractions, fetal heart sounds was there, CTG was reassuring, so she was reassured. That was around 6 p.m. or so. The following day, early morning, around 4 o'clock, she has complained of abdominal discomfort again. At that time, unfortunately, fetal heart sounds was not there. CTG was, concerning, and she was basically flat, and taken to a ultrasound room and found no fetal heartbeat. And it was a IUD. So it was a very difficult scenario. We didn't have any explanation as to why. So patient was educated, and she following day, she delivered a fresh stillbirth. She was given good pain relief. The comfort care was given. And when we asked whether she wanted to see the baby, but she didn't want to. So later on, she was discharged. And to our surprise, actually, so she, walked down on discharge to the doctor's room with the husband and relatives to thank the team for what we have done. Actually, it was a disastrous outcome. Not that we could have done anything differently, but probably the way we engage, makes the difference. So you could avoid, potential conflicts, patient dissatisfaction if you communicate properly. So those two examples, I just want to share with you to emphasize the fact that the importance of communication. So just to, avoid this gap. You can be loud enough in communication, and you can always complete the communication loop. So this is also another important thing I want to share with you. So it says there are 4 people: everybody, somebody, anybody, and nobody. So one important job to be done. So everybody was sure somebody would do it. Anybody could have done it, but nobody did it. Somebody got angry about that because it was everybody's job. Everybody thought anybody could do it, but nobody realized that everybody wouldn't do it. It ended up that everybody blamed somebody. Nobody did that. When nobody did that, anybody could have done. So this can happen often. So in communication, you have to be specific. If you want to, get a job done, you need to, especially in, when you're managing emergencies or even routine ward care, you have to delegate the tasks whom you are referring to. Then that patient should do the task and give a feedback. For example, if you are resuscitating a patient, if you want a particular nurse to give adrenaline, you say, give IV adrenaline, 1 in 10,000, 10 ml with a 20 ml flush, saline flush. So once that is being done, you specifically ask a person, and once that is done, that person should give you feedback saying adrenaline given. So that is how you complete the communication loop. And sometimes you may have to involve in challenging communication scenarios like breaking bad news, end of life care, and things like that. Usually more senior people should, engage in this sort of scenario, but good to have some insight and initial conversations you may have to start off. So if you haven't had any previous encounters, you can introduce yourself with, name and role. You assess what the patient or relatives already know of and see whether they are receptive to have more information, whether they would like to have. So be empathic, understand their concerns, try to, put yourself in their shoes. You need to slow down. Sometimes you have to, keep silent, appropriate silence that add a lot of meaning to your conversation in this type of scenario. Keep it simple, avoid medical jargons, and use simple language, and be truthful. And sometimes you have to say, like, we have done everything possible. We are very concerned about your, loved ones' condition, and despite everything possible is being done, patient is dying. So at some point you have to say that. And we have to be hopeful to see how they, going to tolerate that information. And you can watch for visual cues and what's going to happen from the other end. Be prepared for reactions, unexpected. And that way, we call it chunk and check. You give a bit of information, chunk, and you check whether they have understood, whether they are receptive, whether they want more information, and how the direction of this conversation goes. You can make a judgment. So effective communication is an important aspect for good team function, which will ultimately lead to a better outcome. So impact of poor communication, on the other hand, can lead to disastrous events like wrong site procedures, wrong procedures, incorrect implants, missing equipment, mislabeling of specimen, delay surgery, and so on. And this is like, so far we have discussed about face-to-face communication. Sometimes you may have to engage in distant communication. And studies have shown adhering to distant communication tools can improve the content as well as the clarity of information being exchanged. So it's good to have some sort of structured communication tools. in your practice. I mean, there are various tools like ISBA, SBA, and I would like to introduce the ISBA communication tool. You may have had inputs already, where I stands for introduction, S is for situation, P for background, A analysis, and R for recommendation. Let's take an example. So suppose you are working in a, say, surgical ward, a young lady who had a laparotomy couple of days back, now having deterioration in oxygenation or desaturating, or the oxygen requirement is going up, and you would like to communicate this during evening ward round to your seniors. So you could say, I'm Dr. Danushka, intern house officer, speaking from surgical ward, right? So it's important to introduce you, because especially at the beginning of your career, people may not familiar with you, and tell where you are speaking from, because speaking from accident service, speaking from labor ward, speaking from theater, speaking from your medical ward have different implications. And straight away you can draw the attention of the recipient to what sort of information they are going to get. And you can say situation straight away. Now, I'm concerned about a patient, or this, say, 30-year-old lady who had a laparotomy 2 days back, now having deterioration in oxygenation. And before that, actually make sure you are speaking to the correct person. So you introduce yourself and make sure you are speaking to the correct person. So on a previous institution I worked, I had 2 Prabhats. One is dermatologist and one is a surgeon. So I wanted to have a conversation with my surgeon. So without double checking, I sort of, went on telling my concern. And halfway through, he said, I think you have speaking to the wrong person. I'm Prabhat, the dermatologist. You need to speak to the other Prabhat. So that these things could happen, and it's embarrassing as well. So make sure you introduce yourself and clarify whether you are speaking to the right person at the receiving end. And then you can say, look, this lady is having deterioration in oxygenation. And could I, discuss about this patient? So background, she's previously healthy, came with, say, intestinal obstruction, had a laparotomy, midline laparotomy 2 days back. Now, patient's oxygen level is going up. She's with a 15-liter non-rebreathing mask, for example, and you could say now she's febrile, her inflammatory markers are going up, and she's having bibasal reduced air entry, and I did a chest X-ray, and there's, basal haziness, suggestive of consolidation. So I think she's developing hospital-acquired pneumonia. That is your analysis. And I think this patient needs some critical care inputs, critical care review, or maybe admission to critical care for further escalation, something like that. So you give what your interpretation and your recommendation in the conversation, and or you can ask him, do you think this patient, this is what I feel, are you in agreement? So, and sometimes you may have to communicate in the middle of the night, and that's not a good time to process this information. So try to tell a story so that the recipient can grasp very easily. Right. So I'm referring to this chart again. So based on the communication channels, we talked something about non-verbal things. Verbal things, mostly the oral communication with face-to-face and distance. And written communication is also an important part here, where that is your documentation. When it comes to documentation, where you have to document things. One important thing is your bedhead ticket, where patient information is documented. The thing is, you may have to order investigations as house officers. And it could be, things like blood picture through the radiological department for imaging, pathological, microbiological specimens. So provide adequate information and try to tell them a story so that they can give you valuable feedback. Blood and blood products to the blood bank, referrals to other specialties, transfer forms, patient summary, diagnosis card for future reference. So all these things you will get involved, some of the important aspects of documentation. And make sure eligible handwriting, it's clear. Put your date and time where it's appropriate to be, especially bedhead ticket, and written by whom. The name, signature, and designation is important. And information or instruction received and given. And it has to be methodical. So always try to tell a story where the recipient could follow. Adequate details, important, and standard abbreviation only. So once this, I encountered this NKDFA, and patient has meant that for no known drug or food allergies, not standard abbreviation. But for example, say STEMI for ST elevation myocardial infarction, that is a standard abbreviation. And you should not alter one and should not leave gaps. So those are some of the important things I would like to highlight when it comes to written communication. And one other important aspect I just want to add to this is the consent, because you will be involved in getting consent. That is all where you have to communicate once again. So it could be, of different forms. So it could be implied consent, it could be a verbal consent, or it could be written consent. What is meant by implied consent? Say a patient comes to your, say, medical or surgical clinic. So attending the clinic, it's implied that you are allowed to take a history and maybe to do appropriate examination. So medical consultation, it is implied. But sometimes if you have to do sort of more intimate type of examination, say, for example, digital rectal examination, pervaginal examination and things like that, then you explain and take a verbal consent. Look, for this purpose, I'm going to do this, right? And then for more invasive procedures, you need to have a written consent. For example, a surgery, you need to have a written consent. So what to be included in the consent? Patient should be well informed about what is being done. So sometimes patient and family may have to be involved, especially in pediatric. You explain the procedure in detail, the risk and benefit of the procedure. What happens if it's not being done? What are the alternative options available for them? So those things should be included. And you have to consider the capacity of the patient when it comes to consent. So in our context, it has to be someone more than 18 years of age. If the patient cannot give consent, sometimes we have to make decisions for the best interest of the patient. In children, usually parents or guardians get involved. Maturity of the child is a concern, but it's not a clear-cut area. Sometimes in a difficult scenario, senior clinicians can make a decision, say when there's a conflict, especially someone, say teenager below 18 years wants to get something done, or parents or guardians against it, or vice versa. Then sometimes, especially in Western world, they consider maturity of the child. But I think for practical point of view, in our setup, it's 18 years is the cutoff of age. In a conflicting situation, what to do? So we want to do something for the best for the patient, but patient is not in agreement. Say, especially for a kid, we want to do some procedure, a surgery, but parents are not happy or something like that. In an emergency, sometimes decisions can be made for the best interest. In elective procedures, you can always escalate. You can get, legal advice, or you can escalate it to the administration, and then decisions can be made. So in this sort of scenario, usually your seniors will get involved. So I think that's all I thought of sharing with you. If you have any questions, I would like to answer. I think we have finished a bit early. Dr. Roshan, are you there?
Yes, I'm here. Sir. Right. Thank you very much, sir, for that wonderful lecture on communication. So if you all have questions, we can take a few minutes to answer. So at the meantime, next lecture is by Dr. Visakha Karna, consultant anesthetist at PH Anuradhapura on cardiopulmonary resuscitation. So,
Okay, in the absence of any questions, then I'll stop sharing my slides. We can proceed with the next lecture, I guess. So once again, thank you very much for the opportunity to speak to the pre-interns.
yeah, thank you, sir, for joining from UK and waking up in the early mornings, I suppose. Right.
Pleasure. Thank you.
Thank you.
Okay, good morning, everyone. I'm Dr. Vishaka, consultant anesthetist from Teaching Hospital Anuradhapura. So I would like to congratulate all of you who starting the house officer period from this month. So I hope that you will have a great time during that. So can you all hear me clearly? And also I have shared my
can see-
screen. I hope.
Yeah,
Yeah,
we can
yeah,
hear
you
you,
can
madam.
see. Yeah. So just
I'm going
let
to
me
make it
know.
full screen.
Yes. Okay, right. Can you see the slide moving? Is the slides moving? Okay.
You
Right.
can make it full screen, madam. Yeah.
No, I actually, yeah, let me
Okay,
see.
fine. So right.
Yeah,
This
moving,
is
no?
the
Right.
slide.
Yeah, okay, right. So, so during this lecture, we are going to discuss about the cardiopulmonary resuscitation. So we will discuss the basics of the CPR and recognizing cardiac arrest, recognizing the deteriorating patient, and then the technique of CPR. I mean, you know that this is something that you have to learn hands-on. However, since we don't have a hands-on training this time, so we'll just give you a brief idea about the basics. Okay, and then we'll go through the advanced life support algorithm along with the peri-arrest arrhythmias. Okay, right. So let's discuss why CPR is so important. So and the most important thing is cardiac arrest is quite common. It's actually much commoner than what we think. They believe that there's about 900,000 cardiac arrest in Europe per year. So that's quite a lot. Maybe we don't know our numbers. So that's why we are actually, relaxing and not promoting this important learning for all the doctors and all the healthcare workers. And the survival to discharge is less than 10%. I'm sure this number is quite low in our countries because of the limited facilities available. And on the other hand, survival can be improved to 50% if we give a good quality resuscitation. So that's, I think slides are not moving. Are you? Yeah. So are you still in the first slide? Right, let me share it again. So is it moving now? Okay, I hope it's moving.
Yes, ma'am.
Right, thank you. Right, so it's important that we all know it because the survival can be improved by 40%, which is quite big number. So that's why it is important that we all know this very important thing. And as a house officer, you will be the first responder for most of the cardiac arrest. So I think it's very crucial for the population of Sri Lanka that you know this important learning, which is the cardiopulmonary resuscitation and advanced life support algorithm. Okay, so what is the definition of cardiac arrest? So it is when someone is unresponsive and not breathing normally, we define them as having a cardiac arrest. As you all can see, there is no pulse or blood pressure or any other signs there. It's just the unresponsive and whether the patient is breathing or not. That's all which is there. So that shows that it says that it can be recognized by anyone, including a nursing officer, attendant, any layperson can recognize cardiac arrest. So they can start basic life support immediately. Okay, why do we have to emphasize on cardiopulmonary resuscitation? So the moment, so as you all know, your heart does not stop even for 1 second. I mean, it's going to be continuously beating from the time that you were born, and it's going to be continuous until your death. So that's the normal thing. So if in a cardiac arrest, what happens is the cardiac pumping capacity is going to stop. So in the moment that it stopped, there will be no perfusion to all the organs in the body, including heart, kidney, liver, and all the organs. But most of these organs going to get ischemic damage. But what is the most crucial thing? The most crucial organ is the brain, because this permanent irreversible brain damage can happen within 3 minutes. So that's why we are emphasizing a lot on the brain surviving, improvement of the brain survival, because that's what going to ultimately decide your outcomes. If there is a patient who has returned to the spontaneous circulation but having a permanent brain damage, that patient might get a lifetime being bedridden, and it's not going to be a good outcome. And the other important thing is, in each minute that you pass, the survival can be reduced by 10%. That's very crucial, because you can't waste even a minute. And the most important thing here is that you have to start, or someone has to start. Maybe it's a lay person, or like a bystander or nurse or attendant has to start CPR because of this importance of the early start of the good quality chest compressions. Okay, so this is called chain of cervical. This is one of the most important slide in my lecture. So that's about the chain of survival. Okay, so that will tell you, if you have a patient who is critically ill or who might get a cardiac arrest, how are we going to make this patient survive? So this chain of survival is interconnected, and all has to be very strong for someone to be survived. So the first chain of survival is the chain of this survival chain is the early recognition and call up for help. So how do we recognize a patient who might get a cardiac arrest? That's what you are going to learn. Okay, so in this you should know how to recognize these patients. So maybe this patient has a tachycardia, tachypnea, bradypnea, or bradycardia. So most of these vital signs that you actually measure during your clinical practice will be deranged. If someone is going to get a cardiac arrest within next few hours or like next few minutes, so you will sense these things. So there is a special system in other countries, and in some hospitals it's available, which is called MuScore, which is actually done by a special chart called Muse chart. So in that Muse chart, so that has a early warning score. That means when there is a tachycardia, when there is a hypotension or bradycardia, when there's abnormalities in the vital sign, that that chart will give a color coding, and then from that you can recognize that. So there is a problem in this patient. This patient is a critical ill patient. Then you can start assessment and management then and there. So that's the early recognition. And how do we assess this type of patient? So that we'll go through in detail. The technique of assessment of a patient who has a potential for cardiac arrest or critical ill patient is called ABCD approach. So you are going to use airway, breathing, circulation, disability, and exposure. These 5 letters. So we'll tell you in detail what are the components of this assessment later on. So if you recognize this patient with the news chart or without a news chart, and or if you do the ABC assessment quickly and manage life-threatening conditions then and there, and also you call for help. You can call your SHO, your registrar, or whoever available, and ask for some opinion, and you can get some help from ICU and in the hospital, and that can use to prevent cardiac arrest. So that will be one of the most important thing to prevent. So I think this chain is crucial and very important, because it's important that you to learn to prevent cardiac arrest rather than just doing the CPR after arrest. Okay, that's very important loop of the chain. Okay, second loop of the chain is the early CPR to buy time. Okay, so so to give early CPR, so you should first recognize this patient is having a cardiac arrest. To recognize, you can use look, listen, feel technique that we'll talk to you later, and then you have to give chest compression in the correct technique. So that correct technique means the chest compression rate should be 100 to 120 beats per minute. And if you are giving the CPR along with the ambu ventilation, you can give 30 compression and 2 breaths. So that is the sequence that you are supposed to give. And when you are giving the compression, you should give the compression in the lower half of the sternum and compress 4 to 5 centimeters in an adult. Okay. And so that will continue this continuation of the uninterrupted chest compression will make sure that there is a blood flow to the brain and all the other vital organs, and you have to allow the chest to recoil when you give the chest compression. Okay, so that will allow there is a very good venous return to the heart, which is again very crucial to have a good perfusion to all the organs in the body. And then let's move on to the third loop of the survival chain, that is early defibrillation. Again, crucial point. Okay, so early defibrillation means that you have to get down a defibrillator as early as possible. The moment you have the defibrillation ready, then you can quickly, stop the compression and look at, look at the rhythm and make sure that it is a shockable or non-shockable rhythm. And then you start, if it is a shockable rhythm, you can give the defibrillation or shocks. Okay, so that will allow you to restart the heart. And then the third point, the fourth point is the post-resuscitation care. Okay, so before that, so you can see in the second and third loop, we are discussing two main things in this survival chain. After a cardiac arrest, early CPR, early good quality uninterrupted CPR, and early defibrillation. Why there is no oxygen, why there is no ventilation? So according to evidence, these 2 points has strong evidence that it will improve the survival of the patient. So that's why those 2 points are highly emphasized. So please make a note of these 2. You must give early uninterrupted good quality chest compression and go for defibrillation as early as possible. Okay, and the fourth point is the post-resuscitation care. So here, once you have the return of spontaneous circulation, there you have to, start compressions immediately. Stop the compressions immediately, and then you have to assume this is a critical ill patient, and during that period, you have to do a ABCD assessment to find if there is any reason which is causing the cardiac arrest, and then treat it immediately, and also maybe contact ICU and get some help, and maybe patient need ICU care, and so send the patient to ICU. And sometimes in the ICU, we continue the post-resuscitation care with cooling of the patient to preserve the brain cells. Okay, so most of the post-resuscitation care will do in the ICU, but you can still start the resuscitation, post-resuscitation care with starting of the ABCD assessment. So these are the main 4 points that you have to remember. These 4 chains are very important. This will emphasize, and also this will ensure the patient's survival after a cardiac arrest and even before a cardiac arrest, for prevention of cardiac arrest. Okay, right. So just make sure that you remember this slide. Okay, so we'll move on to the first chain of survival. So I told you earlier, so we can use a special chart called news score, which you might not encounter in your ward setting, but if there is any critical ill patient, I told you that we can use a specific approach to assess and manage these patients. Okay, this is that specific approach. Okay, that's called ABCD approach: airway, breathing, circulation, disability, and exposure. Okay, we'll go through one by one. Okay, so in the airway assessment, the first thing that we do is we try to speak to the patient. And if the patient can speak, usually that patient's airway reflexes are normal, and also patient's airway is normal. So in such situation, you might not need to do anything. You can just give some oxygen and leave the patient to breathe on its own. But if there is any obstruction, partial or complete, there you have to immediately intervene, because this can lead to a cardiac arrest. So you have to specifically identify these different noises which can come from airway. So stridor is usually coming from the larynx. So that's a specific sound which is coming from the larynx. And snoring, something that you might have heard. So some people snore when they are sleeping. So that's the same sound that you get when the patient is partially conscious and also having a obstructed upper airway. That is due to collapse of the tongue into the posterior pharynx. And the gurgling sound. Usually, if there is a liquids or semi-solids in the upper airway, you get this sound. And then, if there is a complete airway obstruction, you might not hear any sound, but you might see some paradoxical chest and abdominal movements, like seesaw type of respiration. So that's quite crucial for you to understand that, because these patients, if you leave them like that, they might go into a cardiac arrest because of the hypoxia, right? So it's important that you understand these specific sounds and patterns that they get in a airway obstruction. So in the airway assessment, you can speak to the patient, as I said. If they are talking, no problem. You can straight away think, okay, this patient is all right. But if the patient is not breathing or not talking, they are if there is no sound coming out, if there is a stridor, then you know that there's air movement in the larynx and there's some narrowing there. If there is a snoring, you know that there's an air movement in the throat, but there's some narrowing from the tongue. So like that, you know, depending on the sound. But if there is no sound at all, if the patient is not breathing, unresponsive, there you have to do this look, listen, feel maneuver like this to find if the patient is breathing. Look at the chest movement, listen for breath sounds, and feel for expired air on your cheek. Okay. And then if it is so, if the patient is not breathing, there we have to open the airway. Okay, so this is how you open the airway. So this is called triple maneuver, head tilt, chin lift, and the jaw thrust. Okay, these are specific maneuver. Ideally, you have to practice on mannequin to understand, but just look at these things so that you can have a rough guide. So let's move on to the next point, which is the breathing. Okay, in the breathing assessment, you are going to follow the adequacy and the depth of the breathing, and if there is any other added sounds in the breathing. Okay, so you will be using basically your technique which you used in your medical school, which is called inspection, palpation, percussion, and auscultation during this airway assessment. Okay, so you are going to assess the effort of breathing, efficacy of breathing, and the effect of the breathing. Okay, so so in the inspection, you will look at the any nasal flaring, and if there is any use of accessory muscles, intercostal recession, respiratory rate, and if there is a cyanosis. So all these things you look at when you are doing an inspection. Okay, and then you go for palpation. In the palpation, you can keep your fingers in the trachea and see whether the trachea is midline. Then check for chest expansion, and then percuss and see whether there is any problem, difference in the percussion note, and then look for any auscultate for any inspiratory or expiratory noises, where you will find any wheezing, creps, or any other reduced air entry on one side or something like that. Okay, so these are the things that you look for in a breathing assessment. So if there is any problem that you see in any part of your assessment, you have to intervene immediately. Okay, so that is called airway, breathing, circulation, disability, and exposure assessment. Okay, so it's not only the assessment, it's the management while you are doing the assessment. Okay, right. So if you find any problem, while you are intervening, you have to keep the patient. If there is a breathing problem, you would usually like the patient to be kept slightly propped up position. Okay, and also so if the patient is not adequately breathing, we have to support them. I'm not talking about a cardiac arrest. These are patients who are having a respiratory inadequacy. There you can support the breathing with ambu ventilation. And then If there is a specific problem like wheezing, then you can give treatment like as for asthma, and then if there is a pneumothorax, you can treat then and there depending on the circumstances. So these are the intervention that you do in the breathing. Okay. So the next letter is a circulation assessment. So in the circulation assessment, you have to do a comprehensive assessment starting from peripheries. So you examine the peripheries, look at the color of the peripheries and see whether there is any whether the peripheries are warm or cold, because if depending on the vasodilation or vasoconstriction the patient is having, there will be change of the peripheries, whether they are warm or cold. So that is a very important finding when assessment of the type of the shock the patient is having. And then you can check for capillary filling time, and then check for the pulse, blood pressure, and then check for the blood pressure, and then if there is any hypotension or any tachycardia, anything that you find abnormal, you can manage then and there. So at the end of the circulation assessment, you can put a cannula and then take, so it's important that when you are putting a cannula, please take blood for all the relevant investigation at the same time. You don't have to poke them again. So that will make them, the patient also comfortable. So you can take blood for relevant investigation. If this patient is coming for sepsis, I think it's very important that you take cultures first, because most of the time that we see is that cultures are not taken, and sometimes the doctors have started on high-fi antibiotics like meropenem, and when the patient comes to ICU, it's very difficult for us to find the organism. Even if we do the culture, it's usually negative. So these patients are unwantedly on meropenem for a long time because we can't de-escalate because of the absence of positive culture. So, and also if the patient is having a MI, then you can do a troponin I and ECG during this last part of the circulation assessment. And again, at the end of the circulation assessment, if there is any need for insertion of a urine catheter, you can put the urine catheter and see whether the patient is passing urine. That's part of the circulation system because it will tell you whether there is a perfusion to the kidney. Right. So interventions wise, usually if there is a circulation problem and if there is a hypotension, we would prefer them to have the legs raised. And in a pregnant patient, we prefer them to have a left lateral tilt. And so IV access wise, I mean, if there is any emergency, we usually go for large bore cannula when we are putting a cannula for these patients. Okay. So fluid challenges. So I mean, usually we go up to like 250 or 500 ml in each fluid bolus, and depending on the condition, the amount of fluid that we give is different. And also it's important, it depends on the patient. So you have to reassess then and there continuously while you do the resuscitation. So in a septic patient, usually you can go up to 30 ml per kg. And so depending on the condition, we can decide what fluid to give. If it is a hemorrhage, so don't go much about with the crystalloid. Please move on to the blood as early as possible. And you can go for even O negative blood. And then you have to go for ECG monitoring whenever the monitors are available. And also, depending on the specific condition that you have, you can start the management then and there. If you are suspecting a MI, you can give the stat doses with aspirin, clopid, and atorvastatin then and there during this part of the resuscitation. Okay, so the next letter is the disability assessment. Okay, so even though it's starting from the D, so what we do is the neurological assessment of the patient. Okay, right. So in this quick assessment of the disability in a critical ill patient, you can either go for GCS or AVPU. If you have time, you can go for GCS. But if it is a quick assessment, there it's okay to go for AVPU. Okay, AVPU is a very comprehensive small assessment where you check for patient for whether the patient is alert or responding to voice, responding to pain or unresponsive. And then From that, you can get an assessment of the alertness of the patient. And then you go for to assess the pupils and see whether the pupils are equal and also whether the pupils are reactive. And then you need to go for lateralizing signs if it is clinically relevant. And at the end of the disability assessment, you can check for the blood sugar, because these patients might be semi-conscious from this very reversible cause, which is the hypoglycemia. So you can reverse most of the problem. If it is hypoglycemia, you can quickly reverse it by giving dextrose. So just check the sugar. Don't forget to check the sugar at the disability assessment. And interventions wise, so these are the things that we do. So if the patient is having a low GCS or semi-conscious, we have to optimize the airway and breathing circulations. And so if you have a specific underlying cause like toxicity of opioid, there you can consider a specific antagonist for that. And you can treat hypoglycemia. And if it is a seizure, there you can control the seizures with the medication. And if the patient is having a CVA or conditions where there is increased intracranial pressure, there you have to start the management accordingly. And things like 3% saline and mannitol. So depending on the condition, you have to start if those are suspected. And then let's move on to the last letter, which is the exposure. Okay, so in the exposure assessment, so you have to do a comprehensive assessment of the whole body of the patient. It's very crucial because that will tell you whether there is any other injuries which can actually potentially cause a cardiac arrest soon. Like there can be a valve like the injuries over the chest, and there can be surgical scar, AV fistula, or any other things like rashes in anaphylaxis. So in trauma, so you have to do a exposure assessment and look at the back and check for the anal tone during the first log roll. So everything comes under the exposure assessment. So do a comprehensive assessment. Depending on the case, you have to decide what needs to be done. And then at the end of the exposure assessment, you have to check for the temperature. So hypothermia is not very common in our countries, but hyperthermia, and sometimes in a drowning people, you might encounter hypothermia. So please keep these patients warm to prevent arrhythmia and cardiac arrest. And also during this assessment, please ensure that you give adequate respect to the patient by ensuring the privacy of the patient. So we have gone through a lot. So if you have any question from this first part of the lecture, which is, we have not come to the CPR yet. So this up to now, that what we have discussed is recognition of a patient who might get a cardiac arrest, patient who has a potential critical ill patient, and how to assess these patients and how to manage. So any questions up to now, you can ask. So we are still at the first part of the chain of survival. Okay, so if there are no questions, so we'll move on to the next part, which is from the second part of the chain of survival. Okay, so before we go into the cardiac arrest management, so it's important so you are going to be the house officer, and who you might be the most likely the person who is there most of the time in the ward, and there might not be your house officer, your SHO, senior house officer, and others might not be there all the time. So you should recognize these arrhythmias. So I told you there are very important two things during cardiac arrest which has proven to improve survival of the patient. Number one is the uninterrupted good quality chest compression. Number two is the defibrillation. To do correct defibrillation, you should understand the peri-arrest arrhythmias. Okay. So we'll go through 4 rhythms during this part. So first of all, so you know this normal sinus rhythm, you have a P wave, QRS complex, and the T. So this is the normal sinus rhythm, okay? And then anyone can tell me what is this? Any volunteers to tell me what is this one? Okay, so I mean, yeah, good. So its answer is there. So it's a VT. Excellent. So why do we call it a VT? So there is a broad complex, and there is a tachycardia. So as you can see, the heart rate is around 300 because one big box is 300. So it's about 300. And then you can see that it's the height of the complexes are the same, and it's look uniform. This is a ventricular tachycardia. When you see this rhythm, it can be either VT with pulse or without pulse. Okay, so because of that, it's important that you check for pulse in this type of patient. Unless this is the first rhythm, you have to check for pulse whenever you have this rhythm in a cardiac arrest patient. So this rhythm can come in a non-arrested patient, like patient is talking and patient presented with shortness of breath and chest pain, and you can get this rhythm, and then you call it VT with pulse. The management is different. And if the patient is already diagnosed to have cardiac arrest, this can be VT without pulse. Okay, so let's see. What is this? So I'm just looking at the chat. You can put it in the chat. Since you are shy to talk. Yes, good. Dharanyagala, Lakshmi, and Sevmi, Chandrasena. So all correct. So well done. It's a VF. Excellent. So it's a broad complex, irregular, bizarre, and it's quite bizarre, and it can be there's no pattern in it. So it's like a very abnormal and lethal rhythm. So always when you have it, there is definitely no pulse. Okay, and the other point is both VT and VF are shockable rhythms. So just remember that as well. So what is this? Let's see who's first. What is this? Yeah, excellent. Dharanyagala. Okay, so you have become first in the both session. Lakshi and Nayanika Sevandi. Yeah, excellent. So it's no, it's not a PA. It's a asystole. Okay, so that's a flat line. And you might see a very, very flat line, which is like some line which is drawn with a ruler. That's when you have a disconnection or problem in the electrical, the circuit or something, something wrong with the machine. But this type of rhythm, you get it in a asystole. Okay, it's not a PEA, right? So what is this? In a cardiac arrest, you see this. And there's no pulse. You just checked it, there's no pulse, and you see this one. Let's see who's first. Yeah, excellent. Who is this? Yeah, so it's Dilshan, Lakshi, Chandrasena. It's a PA. Excellent. So it's a pulseless electrical activity. So pulseless electrical activity can be anything. It can be any kind of a sinus rhythm, any junctional rhythm, or anything like that. So it can be anything which is not asystole, which is not VT, which is not VF, VT, or asystole. So it can be like it can look like a complete heart block. It can look like a junctional rhythm. It can look like a sinus rhythm. So in a cardiac arrest without patient who is having not having pulse, this is a PEA. If the patient has pulse, this is a sinus rhythm. Right. So, a short description about the tachycardia algorithm. When there is a pulse. So, since I touched upon about the VT, I'll just go through this algorithm as well. So if it is a broad complex, so just look at the broad complex arm on the left side. So if it is a regular broad complex, you know it is a VT, right? So here in such situation, if the patient is having, so I told you this patient is talking and there is pulse, and but if the patient is unstable, in such situation, you have to go for synchronized cardioversion. If it is stable, there you can give IV amiodarone 300 milligram over 60 minutes, and then 900 milligram over 24 hours. Okay, so that's the main thing that I want to highlight, because since we have gone through the peri-arrest arrhythmia, and if it is unstable patient, like if the patient's blood, the pulse is there, patient is talking, patient is saying that I'm dizzy and I can't breathe, and you see the VT on the monitor, there is pulse, the blood pressure is 70/50. So these patients are unstable. So there you can't go for amiodarone, because amiodarone can cause hypotension and asystole. Okay, so you have to be very careful when you are giving amiodarone. You can't bolus amiodarone unless the patient is already having a cardiac arrest. You have to give it with the infusion. So in this situation, if the patient is unstable, you have to go for DC cardioversion with synchronized DC cardioversion. Okay. Right. So we have gone through 5,000. Sorry, there's a bit of a noise. Okay. Right. So so we have gone through the period. Can you please mute your mics, please? Okay, right. Thank you. So we have now gone through assessment and management of a deteriorating patient, and then after that we have gone through the the peri-arrest rhythms. Okay, so let's move on to the ALS algorithm and see what we can understand. Okay. So in this, we are going to go through the BLS as well as the ALS. So when I told you how to check for breathing, right? So we look at the chest for movement and look for breath sounds, listen for breath sounds, and feel for expired air. Look, listen, feel. If there is no pulse or no breathing, so since you all are healthcare workers, since you all are going to be doctors, you have to check for pulse at the same time when you are doing it. Okay, so when you do it, so just make sure that you do not spend more than 10 seconds. Okay, because if there is any doubt whether the pulse is there or not, whenever you have doubt, the recommendation is to start CPR. Okay, that will reduce the lag time at the beginning. Okay, so the starting of the CPR, I went through again. So I would like to go through again this again and again and again. Okay, so because this is very important, right? So this is one of the crucial slides in this lecture, because without good quality chest compression, even with the best team, you can't achieve the good outcome. This is one of the things that has been proven to have improved the outcome in large randomized control trials and meta-analysis. This is very important. So you have to give a good quality uninterrupted chest compression. In the lower half of the sternum, compress 5 to 6 centimeters, and the rate is 100 to 120 beats per minute. And make sure that you allow the chest to recoil. If not, the venous return will not happen properly. And if you are giving the compression with the ambu ventilation, 30 compression and 2 breaths. That's the adult algorithm. Okay. And so this is the rate. And if you have, if it is a CPR which is started outside the hospital, there you can go for this mouth-to-mouth breathing. And if you don't like to go for mouth-to-mouth breathing, you can just continue the compression continuously without giving it even that can improve the outcome of the patient. And also you have to give the 2 breaths within less than 5 seconds. I told you earlier, during the chest compression, during the CPR, the maximum interruption that you can get is 5 seconds. That's quite crucial. So that's a very short time. So that during that time, you have to continue the, make sure that you give the breaths. Right. So this is the algorithm. Okay, so so this will tell you what to do during a CPR session. Okay, so I told you, so whenever you, so first of all, what you do is whenever you have a patient who is unresponsive, you are going to go and check for do the look, listen, feel, and assess the rhythm. And if that is, look, listen, feel, and assess for breathing. And if the patient is not breathing and there is no pulse, you would start the CPR. That's the basic life support part of it. But the most important thing is you have to get the defibrillator ready as early as possible. Okay, so the moment you have the defibrillator, you can come to the advanced life support algorithm. This is here. So when you have the defibrillator, you analyze the rhythm. Okay, so you have to stop the compression and analyze the rhythm. And when you analyze the rhythm, if it is, you know how to recognize whether it's a shockable or non-shockable. If it is a VT or VF, it is a shockable rhythm. And if it is a it's a PEA or asystole, it's a non-shockable rhythm. Okay, so you what you do is, the moment you have connected the patient to a defibrillator and you have done all the lead changes and everything, you ask the person who is doing the CPR to start. So during that less than 5 second period, you have to assess the rhythm. You have to ensure that you interrupt the compression minimally. So you have to continuously give the compression while getting ready for the next shock. Okay. So let's say that it was a VF, then you quickly get ready for the shock. You dial to 200 or 150. So it depends, because there are 2 numbers here, because there are 2 types of defibrillators available in hospital. So you must be familiar with whatever the defibrillator available in your ward. So if it is a monophasic defibrillator, which is the old version, the first shock has to be 200 joules. If it is a biphasic defibrillator, the first shock has to be 150 joules. And after the first shock, all the subsequent shock has to be the maximum joules available in the machine. Okay, so usually in the biphasic defibrillator, you have up to 270 joules, and in monophasic you have up to 360 joules. So you get ready for the shock. So that what you do is you charge the defibrillator, and then you have to give the shock with 1 pedal at a time. You have to ensure that everyone stay clear during this, and also ensure that you have asked the person who is giving ambu ventilation to stay clear, because it can cause sparks if you give the shock while the oxygen is being delivered to the patient. And then, so you immediately give, so the interruption of chest compression for the shock has to be less than 5 seconds. And you have to immediately start the compressions. And then resume the compression 30 to 2. Okay. And then, so you spend for 2 minutes and then come back to the analyzed rhythm again. So you stop, start, and then check for rhythm. If it is a VF again, you can deliver the next shock. So that's kind of a cycle that you go. Okay. So if it is a shockable rhythm in the first cycle, you do not give adrenaline at the beginning. Okay. So after the 3rd shock, you give the IV adrenaline 1 milligram, 1 in 10,000, drawn into 10 ml. And after that, followed by IV amiodarone 300 milligram as a bolus. This is the only circumstance where you use amiodarone as a bolus. And then this is only given after the 3rd shock. Here, when you give it, you give the adrenaline first and amiodarone second. In a cardiac arrest, whenever you are giving drug, you must give the drugs with a fluid, with a saline or distilled water bolus, because Otherwise, the drug will not deliver up to the heart because there is no circulation during the cardiac arrest. So after you, while you do these things, you should continue the chest compressions at this rate as per the BLS algorithm. Okay. So let's see what is if it is a PEAO asystole. Okay. If it is a PEAO asystole, you know that's a non-shockable rhythm. So from the beginning, if that is the case, you don't go for a shock. So you go for non-shockable algorithm. Here, immediately as early as you have the cannula available, or IV access or IO access available, you have to deliver IV adrenaline 1 in 10,000 1 milligram. Okay, and it is given in a 10 ml syringe. So you have to give it immediately as early as possible. And then, and the other rule in this algorithm is whenever you start adrenaline in the ALS algorithm, you must repeat it every other cycle, that is every 4 to 5 minutes. Okay. So you will do it that while you go through this cycle. So if it is a PEAO asystole, you don't have to do anything, just continue compression, 2 minutes, go back, 2 minutes, go back and recheck again PEA, go back. And if it is if it is looking like a sinus rhythm PEA, there you can quickly check for the pulse at the same time. Okay, right. So as you can see, so there are things that you do after the 2 minutes. So what do we do during this 2 minutes? So that's a 2 minutes gap. Okay. So during this 2 minutes, you have to ensure that you secure the airway. So in our setting, what we do is we get down a person who can intubate the patient. Or if not, you might have to intubate the patient. But the recommendation in the ALS algorithm is to go for LMA. I'm not sure whether it will be available in the setting that you are going to. So if it is available, that is what is recommended in the algorithm. But if it is not available, you can intubate the patient. And the other thing is you can also go for exclusion of reversible causes, 4HS and 4T, which will go through later. Okay. And the other thing is, let's say that you see something like pulseless electrical activity and you check the pulse. And if the pulse is there, what you do? What is that? That's called ROSC, return of spontaneous circulation. Okay. So here you have to immediately stop the CPR and go through the ABC assessment. So now this is a critical ill patient, not an arrested patient. So you go through the ABCD approach. And you have to ensure you protect the brain with, adequate oxygen, clear CO2 correctly, and also you do relevant investigation. You can do ECG, chest X-ray, and depending on the condition, you do the investigation and find the reason why did this patient arrest. If that was a patient who had a high potassium in the morning and you haven't treated yet, maybe that's the reason. There you can actually start on treatment, even looking at the potassium, because you already know that this patient is already a end-stage renal failure patient. So like that, you know about the patient. From that, you can decide some of the things. The others you can decide after a blood gas or any other investigation. Okay. And the rest of the post-resuscitation management happens in the ICU. Here, sometimes we cool some of the patients to improve the outcome of the brain. Okay. Right. So again, and we are telling you again, right? So ensure high quality, uninterrupted chest compression and allow the chest to recoil. Okay. And also don't interrupt the chest compression to put a ET tube. Okay. So you have to either, if you can just do it quickly, then you intubate. If not, you can go for LMA. Okay. So when you have secured the airway with LMA or tube, don't stop the compression. It's not 32 after that. Continuous compression and then give the breaths around 10 breaths per minute. Okay. Right. So 4HS and 4T, I told you that during that 2 minutes interval, we have to exclude these 8 things. Okay. 4HS and 4Ts. Right. So that's a small question. When should we give the first adrenaline in a non-shockable rhythm? Is it after 2 minutes? No, it's not after 2 minutes. It's whenever, as early as possible, you have to give it. So that is whenever you have the IV access available, you can start giving it. Okay. And then after you give it, you continue every other cycle. The moment you stop, start, and check for the rhythm, you know it's a PEA or asystolic, give the adrenaline. When you are giving the adrenaline, you should ensure that there is an ongoing CPR. If there is no ongoing CPR, the adrenaline will stay in the hand or vein, wherever it is. It will not be pumped into the heart. Okay, so you have to flush it with 20 ml of saline to push it towards the heart. Okay. However, I just want to highlight that whether the adrenaline improve the survival of the patient is a question, because so far the evidence has not proven it, but we don't have evidence to remove it in the algorithm. So all the algorithms still use adrenaline in there as a part because of that. Okay. And also correct the reversible causes. For hypoxia, I mean, it can be like a pneumonia, ARDS, or any other reason which is causing hypoxia. Maybe patient had an obstructed airway and you were not able to recognize that. And the next is hypothermia. I mean, it can happen in like places like Norelia, or like when there's a drowning patient. And hypovolemia in a RTA, or if there is a bleeding, or if there is a diarrhea or vomiting or any kind of dehydration. And hyperkalemia. So maybe the patient had a tall tented VT waves before arrest. Maybe you know the potassium was 7 in the morning. Maybe the patient is already CKD. So anything. So during this CPR, you think of these things. Just prophylactically start treating them, because if the potassium in the morning was 7, you don't have to do another potassium. Just give the calcium gluconate, 30 millimoles, 30 ml, and start correction with insulin dextrose. Okay. And then tamponade. So how to check for tamponade? So as a doctor who's working in 2023, you have to slowly adapt to the system of focused ultrasound, which is actually recommended for all the doctors. So if you keep the probe in the apex of the heart, and if there is a very large black color fluid collection around the heart, that's a massive pericardial effusion. Okay. And if it is collapsing the atrium or right atrium or right ventricle in the diastole, that's a tamponade. Okay. So if you still need help, you can get some help from someone who can do this scan. It doesn't have to be a cardiologist. It can be anyone, who can create the probe and just look at the heart, because these are like kind of obvious things, because you are not going to diagnose a MS or MR. So it's just simple thing. Okay. There are 2 thrombosis which can be there. That would include MI and the other thing is pulmonary embolism. Okay, just treat then and there if you're suspecting that with thrombolysis. And the next thing is tension pneumothorax. You can exclude from looking at the trachea and chest expansion and all that. So you have to do the needle decompression while you are doing the CPR. Okay. And look for toxin, like maybe patient has ingested a toxin or you have accidentally given a toxin. So treat it accordingly. Right. There are specific circumstances. In a maternal cardiac arrest, call for help early from the top hierarchy. You have to have the consultant anesthetist, consultant VOG, and neonatologist called upon early, because you have to go for a delivery of the baby early. That's why, within 5 minutes of the start of the CPR. Okay. And remove the IVC compression with this kind of a maneuver, where you can allocate one person to push the uterus towards the left side, or you can tilt the bed with some pillow or something. Okay, the pushing is usually much more easier because this will interrupt the compressions. Okay, and in drowning, there's a bit of an alteration to the algorithm. So you have to start rescue breaths before you actually give the compressions. That's a bit of a difference in the algorithm. So you give 5 initial breaths, and then you have to ensure that you intubate these patients early if there is a drowning, and go for IPPV, and also give a high PEEP when you are setting the ventilator, because that will push all the water, increase the pressure in the alveoli, that will push the water out of the alveoli. Okay, that's what we need. And also before defibrillation, make sure that you dry the skin. Right. Post-resuscitation care. So after the ROSC, what do we do? Okay. So, I mean, I hope you understood that we have gone through the chains of survival. So we went through the first chain of survival, which is the assessment of a deterioration patient with the ABC approach. And then we went through the CPR, defibrillation, and the overall algorithm. And then after that, post-resuscitation care, 4th chain of survival. Okay. So whenever you have the ROSC, immediately assess the ABCD assessment, stabilize the patient. If there is an immediate life-threatening condition, treat it immediately. You can't wait for a senior to do a needle decompression or something like that. Give fluid boluses, start vasopressor support, and go for a definitive airway, intubate there. Okay. And do relevant investigation according to the condition of the patient. And if it is a cardiac problem, you can talk to the cardiac team, and early ICU care. Okay. And something that we actually quite lagging behind, team briefing. Talk to everyone and ask how we can improve more, and complete notes. Okay. So ensure that you complete all the notes and talk to the relatives as well, which is very important. Okay. Any questions? So you can put that on the chat box as well if you have any questions. So if you, it's quite crucial that you understand this concept of resuscitation, because it will actually ultimately affect the outcome of all your patient. Okay. So I want to highlight again. Okay, so the most important part of the evidence-based part is to give good quality uninterrupted chest compressions, and also to ensure that these patients are having early defibrillation. They should get early defibrillation whenever the defibrillator is available. You have to go for defibrillation. Okay, and ensure the post-resuscitation is correct. Post-resuscitation care is given correctly. Any questions? Let me see if there is anything in the chat box. How to decide stopping CPR? Okay, right. Okay, very good question. I think that's quite crucial. How to stop the CPR? Okay, so so there is no definite guideline to say, okay, after 20 minutes or after this many minutes you stop the CPR. Okay, so depending on if the patient is not responding, if there is a continuous poor rhythm, which is like asystole or PEA, in such situation, and if the patient is already having a background conditions like cancer, or patient is like 60 or 70 year old, not 60 like maybe 7 to 8-year-olds. So in such situation, you might go for a early discussion on stopping CPR. Okay, and so here you have to consider the medical futility. Okay, and on the other side, you have to again consider points like if the patient had a cardiac arrest due to hypothermia, or if there is a condition like local anesthetic toxicity, what evidence says is even CPR or resuscitation duration of more than 1 hour has instances where it improves the outcome. So in such situation, you can continue compression. It is acceptable. Okay, but it is a balance between the benefits of the patient, and also you should ensure that you are not making the team tired and working on a irreversible or like medically futile patient. So usually what we personally do is like we go for like 20 minutes to like 1 hour, but there's no hard and fast rule. It's a team decision. Sometimes there are instances where we go beyond 1 hour, and there are instances we are getting the family into the discussion. So in such situation, we can ask from the family, okay, is there any advance directive? These things are not common in Sri Lanka, but maybe there is an advance directive from the patient. That means it's like a living will where they have written inside in front of a lawyer that I do not like to be resuscitated. If you start CPR in such patient, and the moment you have these documents available, you have to immediately go for stopping of the compressions, okay, and stop the resuscitation. But if it is these things are very, very rare in this country. I have not encountered a single case like that. But in the future, you might encounter this type of advanced directives. And the other one is DNA CPR orders. Okay, so that is usually a medical decision. So it's a medical decision where if you think that this is medically futile and patient is terminally ill and will not recover, the consultants can decide that not to resuscitate. Okay, but please bear in mind, this is still not legal in this country. You can't be covered legally if you do not resuscitate the order in this country still, because we don't have the legal backup like circular or any act yet. It is still in process. It will come soon. Okay. And I hope that answer your question, Dilan. And the next question is from Malindu. How do we give adrenaline in pair with shock when there's this conversion of non-shockable rhythm to shockable rhythm? Because we are already started. Yeah. So whenever the rule is that if you start the adrenaline, you continue the adrenaline every 4 to 5 minutes. Okay. So just ensure that you don't give that, that moment of giving adrenaline should happen during the CPR. Okay. It should not happen when the CPR is stopped for like rhythm check or during the defib. That's the only point. So if it turn into a shockable, non-shockable to shockable, still after 4 to 5 minutes, you give it continuously. Right. Any more questions? There are 2 more minutes for us to discuss if there is any more questions. So I think we discussed about and the other thing is there are a lot of non-technical skills as well that is involved, which is very important. That means leadership, communication between the team, and having global perspective. So all these matters in a resuscitation attempt. So please work as a team whenever you have a cardiac arrest. That will help you to have a good outcome. Okay. So I think could you kindly share the slides? Yeah, we can share the slides. Yeah, sure. I mean, depending on the rules of the workshop, we may or may not. Okay, right. So thank you, everyone. So I'm just coming to the end. So that's less than 1 minute more now. Thank you, everyone, for listening. I congratulate all of you who's becoming the most junior, most doctors in this country. I hope that you will enjoy your 1 year of this intensive training, and good luck for all of you. I hope that you will do a very good quality resuscitation during to your patients during your period. Thank you.
Right. Thank you, madam, for that comprehensive lecture on cardiopulmonary resuscitation. If you all have questions, we can take a few minutes to answer. In the meantime, next lecture is by Dr. Anjali De Silva, consultant anesthetist at Base Hospital, Parnadura, on sepsis. She's logged in, so if you all have any questions, you can take time to ask. So we will take attendance in between, so it will be activated for a few minutes. Those only for accommodating for those are logged in. So there is 80% attendance we need to obtain the certificate. So make sure that you all convey to your friends to join either from Zoom or by live YouTube. Right. Over to you, madam. Thank you. Madam, you can start.
Yeah, let me share my screen. Yes. Can you see my screen?
Can see your screen, madam. The voice is a little bit it's not breaking up.
Hello?
Yeah. Voice is not continuous.
Can
you increase the volume, please?
Can you see my screen? Can you hear me and can you see me now?
Yes, yeah, we can see you. Not the slide.
Okay. I think there was some problem with the connection, I think. Right. Okay. Good afternoon, everyone. And I would like to congratulate you all for your new appointments and welcome to this side of the medical life. So I will talk about sepsis. So I think you all know that we celebrated the World Sepsis Day on
You
September
need to share the
13th.
slides, madam. It's not sharing.
Ah, it's not sharing. Oh. Oh.
Yes, now better, yes. Full screen.
I think it's giving some troubleshoot. Yeah.
We don't get the full screen, but if it's okay, we go by this, by slash minimize screen. Yeah.
Is that okay?
Yeah.
If it's not,
No, it's not moving.
but in my screen it's full screen. Do you
Yeah.
get full screen?
We are getting its screen. We are getting it at normal minimize screen. But if it's okay, madam, we'll go by minimize screen. It's
Okay,
easier. There's a problem with the connection.
so let's talk about sepsis. So we celebrated the World Day on September 3rd. Sorry, what's I think so, yeah. So far it has been okay. I don't know. Once you start sharing, it's giving trouble, I think. Right, okay. Shall I start then?
Yes, madam, can start. Can we? Hello. The slides went off again. Plus your mic. Now, don't make it full screen. Just go by as it is, and just can you select one of the sides below? Few slides below. Yes, done. Yeah, we'll go by this as in moving.
Yeah.
Okay, madam. We can start, madam. Second slide.
All right, okay. Right, okay. So why sepsis is important? Because yeah. All right. Okay. So we celebrated the World Sepsis Day on September 13th, and we conducted by our college several programs to increase the awareness among public. And so why sepsis is important? Because it's preventable care. And also awareness of the seriousness of this condition is like it's very low. So it's
Madam, can we do this? Will you be able to join by your mobile, what do you call, the voice, and move the slides from the computer? I think that will be, if it's okay with you.
How can I like
Yeah, we can hear you. I think
do that with 2 devices?
Yeah. What happens is, I think with the same device, it's not enough the connectivity.
Okay. So how can I like share and?
Now, you have the computer with you, or which?
No, I have the computer with me. I'm like,
Yeah, you go to the computer, madam,
login.
go the slides with the computer. If you have the if you have
Okay.
mobile, connect the mobile to the to voice. I mean, to talk. No.
So then how can I share the slides?
Look, use the computer to share the slides. From the phone, you join again. From that, you speak, madam.
Okay.
Shall I send you the Zoom link?
No, I have the Zoom link.
Yeah.
So
click on the Zoom link. You join the computer, this thing. Then you tell me the name, what is it is. Then I will co-host you.
Anjali.
Anjali, right?
It's Anjali De Silva. Yeah.
Okay,
now
I
I
got
have logged through from my laptop and from my mobile.
Right.
Both.
I made a co-host there. So
Okay.
then okay. Make it mute karna, madam. Computer ke mute karna.
All right.
Okay. Now then, all right. Then phone ke phone voice settings in audio settings ek accept karan. All right. Now you can unmute.
Okay. Then.
Yes. Madam, okay. Can you speak a bit?
Hi.
Right. Madam, one more thing. Computer ke sound minimize karan.
Yeah. Hari.
Going right. By chance you don't have earphones, no, madam?
Oh, nah, not here. Yeah.
Okay,
Then
okay.
how?
Now
then
it's okay.
shall I?
Yeah,
Can I share this?
Yes, yes.
I don't. Will it stuck again?
No, let's see, madam. Should work. Yeah, perfect.
Yeah.
Screen, yes.
Oh.
Okay, madam.
Oh, I learned something new.
Yeah.
Okay, right. So let's start from the beginning. Okay. Okay, congratulate to all of you, and sorry for the disturbance. And so let's talk about sepsis. So why sepsis is important? Because now the slides are not moving. Yeah, because it's a preventable killer. So awareness of the seriousness of this condition remains very low. Severe sepsis is frequently underdiagnosed at an early stage when it is potentially reversible. So I'll take you through a story from Sri Lanka. So Miss Sita is a 35-year-old lady living in a remote village surrounded by the beautiful hills of Sri Lanka. So she is a dedicated mother of 3 lovely kids. Youngest child is just 2 years. One day, when Sita woke up in the morning, she was not feeling right, felt feverish, body was aching, and had no appetite. So she took native treatment as a remedy. I hope the slides are moving, right?
Madam, can you know?
Are they moving?
No.
I think one has got logged off.
From the laptop. No, I think it's. Can I share the presentation through my mobile?
Yeah, madam. Can you email me? Is it okay?
Yeah, sure. To which email address?
Shall I text you, madam? 1 second.
Yeah, sure.
I'm calling you now, so I'll send. Hello.
Hello.
Yeah, madam, I've texted you.
Okay. Yes, please tell me your email address. I didn't get the text.
Text kara, madam. You should get it by now. rcfernando5@hotmail.com.
Can you tell me RC?
rcfernando5@hotmail.com.
RC Fernando 5
Hotmail.com.
@hotmail.com. Yeah, sent. Did you get it?
Can you see?
Yes.
Okay.
Yeah.
Second slide.
Okay. Right. Okay. So I'm really sorry for the trouble. And okay, let's start again. So I'm going to talk about sepsis. So we celebrated the World Sepsis Day on September 13th. So we conducted several awareness programs to increase the awareness among public. And why sepsis is important? Because sepsis kills, and it's like a time bomb. Sepsis is a preventable killer. Yeah. The next slide, please. Yeah. Next one, please. And the next. So the awareness of the seriousness of this condition remains very low. And severe sepsis is frequently underdiagnosed at an early stage when it is still potentially reversible. So I'll take you through a story from Sri Lanka. So let's call this lady as Mrs. Sita. She's a 35-year-old lady living in a remote village surrounded by the beautiful hills of Sri Lanka. So she is a dedicated mother of 3 lovely kids. Youngest child is just 2 years. The next slides, please. Yeah. So the one day when Sita woke up in the morning, she was not feeling right. She felt feverish, body was aching, and had no appetite. She took native treatment as remedy. So the next morning, she started coughing, shivering with high fever, found it difficult to breathe at times. In spite of her illness, Sita had to continue with the household activities, just like our moms. So she did all the sweeping, washing, and after 3 days, symptoms worsened. Fever was rising, and she felt lifeless, extremely tired, and could not concentrate. So her mother took her to the closest hospital, which is a peripheral unit. The doctor examined her and prescribed antibiotics and nebulization. Yeah. The doctor insisted on getting admitted to the ward as she was very sick. Yeah. But she remembered the 3 hungry birds waiting for her at home. So she decided to go home against medical advice. So on the same day, night at home, she fainted twice and she did not pass urine the whole night. And the children got scared since their mother appeared to be extremely confused. Sita was taken back to the hospital early morning on the following day. On admission to the peripheral unit, she was very ill. So on examination, she was in distress, she was febrile, pulse rate was 110 per minute, blood pressure was low, 70/50, and respiratory was 25 per minute. And oxygen saturation on air was 90%. So IV fluids and antibiotics were given immediately, and urgent transfer was arranged to the closest teaching hospital. She lost consciousness several times during transfer. Next slide, please. And she was brought to the ETU in a critical condition. So in the ETU, she was resuscitated with IV fluids, inotropes, and oxygen. End of spectrum antibiotics was prescribed. So after initial resuscitation, she was transferred to the medical ICU for further care. So in the ICU, she was given optimum care with advanced organ support, guided by multiple lab tests. She was treated by a team of experienced consultants. Multidisciplinary team meetings were held to discuss on her management. Despite all the care and treatment, Sita did not improve. She died on the third day at ICU. So she died under the tragic circumstances from sepsis because of her acute, severe community-acquired pneumonia leading to sepsis and then leading to multi-organ dysfunction. So what can we learn from this case? So irrespective of how sophisticated the healthcare delivery system, next slide, please. How developed you are, how rich you are, how poor you are. So given the opportunity, sepsis can kill and will kill. And she's not the first patient who died of sepsis and will not be the last, and many more will follow. So in our ICU, so the 80% of the admissions are due to sepsis and septic shock. So let's see what's the impact of sepsis. So somewhere in the world, someone dies of sepsis every 3.5 seconds. So that's a lot. Every 3.5 seconds, someone dies because of sepsis. So 48.9 million cases, 11 million deaths. 1 in every 5 deaths worldwide are associated with sepsis. 85% occur in low or middle income countries, and 2 out of every 5 cases are in children under 5. And many of these deaths are preventable. I told you it's like a time bomb. So every second matters. So you call it time critical nature of sepsis. So this is like, as I said, every second counts. So once you delay treatment of sepsis, patient go towards the more critical situation. And once you pass a certain point, there's no return. Yeah, next slide, please. So is there any standard therapy for sepsis? So far, all therapies formulated to treat sepsis has failed. So only option left for us is early detection and early therapy. So what exactly is sepsis? So there was like several definitions, but the most recent guidelines are from the Surviving Sepsis Campaign, International Guidelines for the Management of Sepsis and Septic Shock from 2021. So let's see what's the definition of sepsis. So it's life-threatening organ dysfunction caused by dysregulated host response to infection. I know it's a bit of a complicated definition. So if I say it's in this way, it is frequently the final common pathway to death from many infectious diseases worldwide. So this host response in sepsis is characterized by dysregulation of immune response. So in other words, immune system plays havoc in sepsis. So as I said, sepsis is a life-threatening organ dysfunction caused by dysregulated host response to infection. What is septic shock? So it's persisting hypotension requiring vasopressors to maintain mean arterial pressure more than 65 millimeter mercury and blood lactate levels more than 2 millimoles per liter despite adequate volume resuscitation. I will explain this in my next slides. This increases mortality. So what are the patterns of sepsis in Sri Lanka? So most of the time we see patients with pneumonia or neutropenic sepsis, leptospirosis, meningitis, urosepsis, dengue, and TB. So what really happens here? So I'll talk about a bit of pathophysiology here. So once you get an infection or an injury, so our immune system start responding. So they will make different cytokines. So once there is adequate immune response, you recover. But when there is dysregulated immune response, it can lead to organ failure and death. Next slide, please. And the next one. Yeah, so the cytokines, they have three major impacts on small blood vessels. So cytokines can dilate your blood vessels, which will cause low blood pressure, that is hypotension. And also it causes leaking. It will give rise to edema and hypovolemia. And also it activates this thrombotic pathway and it can make small clots. It can cause microinfarction. Yeah. So the initially pro-inflammatory response overrides and later the anti-inflammatory or the immune suppression predominates. And the poor outcome in sepsis are associated with abnormal pro and anti-inflammatory cytokine response produced by the host's own cells in response to infection. So in sepsis, deaths can occur either in the early phase or in the later phase. So if the death occurs in the early phase, it's due to the pro-inflammatory cytokines. It's known as cytokine storm. And the late effects are due to immune suppression mediated by death of B and T lymphocytes by apoptosis, leading to excessive immune suppression. So once the chain reaction initiates, there's no way of stopping it. That's why we need to act early. As I said, once sepsis go beyond a certain point, there's no recovery. So we need to do early detection and timely intervention. So why it is so difficult to diagnose sepsis? Because it can have number of phases. In some patients, it's very obvious. They become febrile, hypotensive, tachypneic, but in some patients that are not so obvious. And early recognition can lead to potentially reversible sepsis. So how are we going to recognize it? So there are several criteria. There are several criteria to diagnose sepsis. So what we used earlier was the previous one, the Q-SOFA one. Please, slide. No, the previous one. No, after that. The next one. Okay, that's fine. Yeah. So there was, we used Q-SOFA. So Q-SOFA was, we see the respiratory rate, altered mental status, and systolic blood pressure. But now what we use is the news score. Can you please go back to that, the news slide? No, the previous one.
This one, madam, or the one before?
No, there's a chart with multicolor chart, the news for identifying sepsis. Yeah, this one, yes.
Sorry, this one?
No, there's a chart with multicolor.
Okay. This one? News?
No, next one. Yeah, this one.
Okay.
Correct, yeah. So as the Dr. Visakha told you that once you get a really ill patients, that you assess the patients according to A, B, C, D, E. So once you assess according to A, B, C, D, E, you can get an idea how bad patient is. So what that we use in the national early warning score is what you see in a patient like every day. Next slide, please. Yeah. So what we use here is respiratory rate, oxygen saturation, supplemental oxygen, temperature, systolic blood pressure, heart rate, level of consciousness. So you can see that we have given marks. So more the patient deviates from the norm, the patient gets more marks. So according to the marks the patient gets, that we have to increase our treatment. So you see patient can have higher respiratory rate or lower respiratory rate. So that means patient is ill. Whether the patient oxygen saturations are low, and whether the patient needs any supplemental oxygen. And patient can be either hyperthermic or hypothermic. But most of the time we see patients are hyperthermic, that they have like high temperature. Rarely patients come with hypothermia as well. And what's the patient's blood pressure? And whether the patient is tachycardic, and what's the level of consciousness? Like you can use either GCS, but in an acute situation, you can use ABPU. Yes. The next slide, please. So if you think that your patient has more points and the patient is really ill, you have to act fast. So what are we going to do? Because the sepsis and septic shock are medical emergencies. So how are we going to diagnose sepsis and septic shock? Whether the patient has low blood pressure, with what's the patient history? Hello, can you hear me? Did I lose my connection?
Next slide, madam.
No, I thought I lost my connection. So how are we going to diagnose it? As I said, you have to use the new score. And with that, you have to take a good clinical history and examination with the new score. And then I want to tell you that there's a bundle care. Next slide, please. Yeah. So when you think of bundles, what do you think about it? It's a collection of things. So bundle, it's a group of interventions implemented together to achieve predefined goals in a specified time frame. So it gives a better outcome than when implemented individually. So they all are evidence-based interventions. So once you suspect sepsis, what are we going to do? So you start acting from time zero. So what is time zero? Yeah, next slide, please. So what is time zero? So there's no absolute time zero, because patient might be at home when he or she gets sick. So it's the time of presentation, or the time of presentation to either to the emergency department or to the ward. So the management should start as soon as you diagnosed hypoperfusion or hypotension. And you should not delay the starting treatment pending ICU admission. Yeah. Next slide, please. So what we have to do, it's called the golden hour. Within the first hour, we have to do several things. Hour one. Next slide, please. So you can measure lactate. How are we going to measure lactate? You can take a venous blood gas. It should not be an arterial blood gas, definitely, but you can use a venous blood gas. So you can see the lactate levels. And if the patient is hypotensive, mean arterial pressure less than 65, and the lactate levels are high, you can start IV fluid resuscitation. I go through each and every steps in my next slides. And then we have to start vasopressors and then obtain blood cultures, administer broad spectrum antibiotics, and don't forget oxygen and urine. So next, remember 3 in or 3 out. Like what in, you give oxygen, you give fluid, and you give antibiotics. What if out? Take lactate out to see like a venous blood gas and take blood culture and urine. So it's like a, you can remember things in a simplified way, like 3. Yeah. So why measure lactate? Lactate is produced with the anaerobic metabolism. So why anaerobic metabolism? Because when there is inadequate tissue perfusion, our tissues will produce lactate. So that indicates there is tissue hypoperfusion. So trigger for the quantitative resuscitation if lactate is more than 4 millimoles per liter. Okay, so we have taken venous blood gas and see lactate is high and the patient will next start fluid resuscitation. How much? 30 mils per kg, not at once, but within the first 3 hours. So you give 30 ml per kg as a maximum, but as boluses, like you can give first bolus, like 500 mils fast. And if the patient's blood pressure is still on the lower side, you give the second bolus. So what fluid? Crystalloids are preferred. What are the crystalloids? They are the 0.9%, so no, like sodium chloride. What do you call it? The normal saline or the Hartmann's. So continue fluid administration as long as needed, like 30 ml per kg. So even after you have achieved this 30 ml per kg, if it's still refractory hypotension, you can use albumin, like we have 5% albumin. But I'm not quite sure whether you have it in the ward. So, but avoid giving any starches because it will lead to poorer outcome. What if the patient is a cardiac disease patient, like has heart failure and low ejection fraction? Then you have to use a fluid very cautiously. You can't like use 30 ml per kg, like full amount of fluid, because it might lead to heart failure. Okay, right. So now you have given like fluid resuscitation. But if the patient's blood pressure is still on the lower side, like mean arterial pressure is less than 65, what is next? So we can add vasopressors. Okay, let's see what vasopressors and what site and how are we going to titrate it. So what are the pressure targets and what else we can add? So the drug of choice, vasopressor of choice is noradrenaline. How can you start noradrenaline? If you have a peripheral line, you can start the noradrenaline peripheral as an infusion, but preferably via central line. If the patient does not have a central line, what can we do? So you can insert a cannula, like a neck cannula, external jugular vein cannula, like, and then you can start noradrenaline. But if you like are not very competent on inserting a neck cannula, you can start with the peripheral line. And how much? You can start with 0.1 mics per kg per minute. One noradrenaline vial has 4 milligrams. So what we usually do is we dilute 4 milligram in 50 mils of saline, and then we run as an infusion. I think most of the wards has a chart that according to patient's weight and according to patient's like blood pressure that you titrate it. If you don't have that sort of a chart, you can always ask from the ICU, like how to dilute the noradrenaline. Okay. And you can like increase gradually like till you get the desired blood pressure. So once you achieve like somewhere around 0.5 mics per kg per minute, so we need to add some more vasopressors. So what's the second line? Vasopressor in a septic patient, septic shock patient. You can add vasopressin. How much? 3 units per minute. Okay. And if the patient has some sort of cardiac issues, cardiac dysfunction, and persistent hypotension, despite adequate volume status and despite starting noradrenaline, you can add dobutamine or you can switch to adrenaline. Yeah. So some of the bundles we have done. So we have taken lactate and we have done the fluid resuscitation. We have added vasopressors to achieve the map of 65. Yeah. Now, what's like all these things should go hand in hand, not one after the other. So time of blood culture collection as soon as you can before you give the first dose of antibiotics. So you need to collect at least 2 sets of blood cultures for aerobic and anaerobic. If you don't have like blood culture bottles for anaerobic, you can use the blood culture, like aerobic blood culture bottles that we have in the wards. But if there's any delay of taking blood cultures, don't delay antibiotics. Assume that you don't have blood culture bottles in the ward and you need to get it down from the lab. It will take another 1 hour. But don't wait till you get the blood cultures, but give the antibiotic dose. Because as I said, so every single second delayed, like increase the mortality rate of the patient. Yeah. So what other samples you can take? Not only blood cultures, depending on the source that you suspect. Assume that patient came with renal angle tenderness and dysuria and you suspect pyelonephritis. So you can take urine culture. And if the patient came with pneumonia, signs and symptoms of pneumonia, chest pain, then you intubated already, we take tracheal aspirates. And any sterile samples from the site of infection, like peritoneal aspirates. So you need to take all these cultures. Like, why do we need all these cultures and ABST? Like to treat, to guide the antibiotic therapy. Okay, so I said you have to start antibiotic therapy as soon as possible. So what antibiotic? Again, depending on the source that you suspect. It should be a broad spectrum empiric antibiotic, preferably within the first hour of diagnosing the hypotension and the suspecting sepsis. So you can start the antibiotics according to your hospital protocol or according to the microbiology protocol. So initial broad spectrum therapy to cover the most likely pathogens when the potential pathogen is still not known, including bacterial, potentially fungal or viral coverage. So once you start antibiotics, you have to reassess the antibiotic regime daily for de-escalation. This administered for more than days, de-escalate according to the culture and ABST. Otherwise, like once we start on meropenem, like even though like we receive the culture and ABST that is like sensitive to something like a low antibiotic, maybe like a ceftriaxone or paramoxiclav, we just continue to give meropenem rather than de-escalating. So we should not do that. Like it's called antibiotic stewardship, like that to prevent the antibiotic resistance. Okay, as I told you, don't forget supplemental oxygen and measure urine output always. Why we give supplemental oxygen? Because the patient is already has like increased work of breathing and increased oxygen requirements, so give supplemental oxygen. So what's the big issue? So we do like simple, like 6 things here. So the problem is, what is the true time zero? As I said earlier also, it may be the patient, the time that patient like come to the emergency department or come to the ward, or once you like start clerking the patient, seeing the patient. So that's a problem. So is there any place for steroids? Yes, but not at the beginning. So once the patient is not improving, even after 2-3 vasopressors, we can like give hydrocortisone. It's the dose is 200 milligram for 24 hours. Like we give 50 milligram 6 hourly, or as a continuous 200 milligram over 24 hours. Right. So we start resuscitating. So what's the end point? So you have to reassess the volume status and tissue perfusion with your clinical evaluation of vital signs. But you can use capillary refill. I hope you all know how to check for the capillary refill, that you press for like 5 seconds, like 1 in 1000, 2 in 1000, 3 in 1000, 4 in 1000, 5 in 1000, 5 seconds. And then count like how many seconds it will take to refill the nail beds. Like 1 in 1000, 2 in 1000, 3 in 1000. So it should be less than 3 seconds if the patient has a good perfusion. And also you can check the heart rate, blood pressure, oxygen saturation, respiratory rate, temperature, and urine output. So what are our targets, goals? As I said, mean arterial pressure more than 65 millimeter mercury, urine output more than 0.5 mils per kg per hour. So if the patient is around 50 kilos, if the patient has more than 25 mils per hour of urine output, so that's good. That's a good sign of perfusion of kidneys. And the other thing is, in patients with elevated lactate levels, target resuscitation to normalize the lactate level, but it will take some time. Yeah. So the other important thing is, if the patient has an abscess and that has led to sepsis, so we need to do the source control. So we need to do an IND, or if the patient came with like necrotizing fasciitis, we need to do the wound debridement. Or if the patient has a infected cannula, and that is the most probable cause of infection, we have to remove the infected device. Sound scan or X-rays to see what is the potential source of infection. Okay. So I'm coming to the end of my presentation. So if you remember the news, the one I showed, heart rate, blood pressure, respiratory rate, oxygen saturation, supplemental oxygen, and the patient's conscious level, and then the 3 in and 3 out, that will save your life and also your patient's life. So no one will scold you if you have done the 3 in and 3 out. Just like remember that. I want to tell you again and again, do those. Give oxygen, give fluid, give antibiotics, take lactate out, do a blood gas, cultures, and measure urine output. So once the patient, like whenever you ask whether we have any ICU beds, the first most things that we ask are these things. How's the patient's lactate level? How many fluids have you given? What are the vasopressors patients on? How's the oxygen saturation and whether the patient is on oxygen? Yeah. And what's the urine output? And have you taken the blood cultures before you give antibiotics? Yeah. So, sepsis, it's about time. So the clock is ticking and you have to act really fast to save your patient.
So if you all have any questions, we can take a few minutes to answer those questions. So in the meantime, we'll take a lunch break. So we'll start at 2:10. Right. Thank you, madam, for that comprehensive lecture on sepsis. That was Dr. Anjali De Silva, consultant anesthetist at BH Pandra. Thank you, madam.
Yeah. Okay, and thank you very much for giving me the opportunity. And I'm really sorry for this interrupted talk because of the technology.
That's okay. It happens most of the time.
And thank you very much for helping me out with
No
this.
worries, madam. Right. So lunch break. Come back at 2:10. Thank you. Thank you, madam.
Thank you.
So we'll come back after the lunch break. So next lecture is by Dr. Aival Habo, consultant anesthetist, joining us from UK on the topic of fluid management. Over to you, sir.
Thank you, Dr. Rashan. Good afternoon. Let me share my screen with you all.
Good morning in UK, I suppose.
Good morning and good afternoon to everybody in Sri Lanka. Right. I hope you can see my screen in the presentation in full screen. Is that right, Dr. Rashan? Hello. Can you all see my presentation?
Yes, I can see. Can you move on and let's see if it's moving? Yeah, it's moving. Yes.
Okay. Okay. So, good afternoon, and thank you for giving me this opportunity to speak to you all about fluid management. So, in this 40 minutes, I'll be talking to you. Let me put the timer on. I'll be talking to you about the body fluid composition, how our body is composed of with regards to water, how to assess the fluid balance in our body, and what fluids are available for therapy, and how much fluid do we need to give, and what are the goals. So if time permits, we'll go through a small scenario as well. Right, let's talk. These are all things that you know from your undergraduate times. So most of our weight is what actually, if you dry a person to be like a dry fish, more than 50% of your body weight will be reduced, as you all figure out. So newborns will have 80% of their body weight composed of water. And as we grow old, when our proteins and adipose tissues build up, our water content reduces. But in average, an adult male will have 60% of his weight as water, and a female will have about 50% of her weight in water. So how is it distributed? So, body fluids, about the body fluid compartments, the intracellular fluid compartment, extracellular fluid compartment, and then the extracellular fluid compartment is subdivided into the interstitial and plasma components. If we take an average built male who is 70 kilos, so 60% or 42 liters of it will be fluids, the total body water. And 2/3 of it will be intracellular, which is 28 liters, and 1/3, which is 14 liters, will be extracellular. So this extracellular fluid further subdivides into 75% of interstitial fluid and 25% of plasma. So it's mainly this interstitial and plasma volumes that mainly contribute in our body fluid homeostasis. So generally in health, what we take goes out. So we generally don't put on weight with regards to water. We build our weight with proteins and lipids, but we don't, our body weight doesn't increase just because of the content of water, which means the water balance is constant. If we drink or if we take 2 liters per day of fluid, somehow the body will manage to get rid of the 2 liters so that what the body water content is constant. So how do we take water? Maybe food and drink with metabolism, and if in disease states we'll have IV fluids. And how do we lose body water? Through the skin, through the lungs, which is the insensible loss, and through urine, and feces. And also if there are in other ways, other losses, just like diarrhea, vomiting, blood loss, and that is the additional ways that we lose body water. So in health, we know that body can maintain its fluid balance. But if we become diseased, if we fall ill, if we become critically ill, this homeostatic ability is lost. And what happens is, because of various mechanisms being overactivated, sometimes underactivated, water tends to retain in body, or sometimes water will be removed from the body in excess, ultimately leading to a risk of death. So we encounter people who are sick. So most of them will have problems with their water homeostasis. So it's our duty to make sure that they are not overfilled or underfilled, but evenly filled. So we just need to understand a few definitions, definitions about this volume status. So you have hypovolemia. So the volume status wise, we say it's hypovolemia, hypervolemia, or euvolemia. So hypovolemia, when you say hypovolemia, it mainly considers the intravascular volume. So if the blood volume, intravascular volume is reduced or increased, say if you transfuse 2 liters of Hartmann's fluids to a patient, that will increase the intravascular volume, and we call it hypervolemia. If you lose 1.5 liters of blood, the intravascular volume will reduce, and we call it hypovolemia. On the other hand, dehydration is called to a state where total body water is decreased. So your intracellular fluid, extracellular fluid, which includes the interstitial and intravascular fluid, all will be depleted. May not be in the same ratios, but at different ratios. So hypovolemia directly can lead to shock because of the intravascular volume is less. And dehydration also ultimately will lead to shock or hypovolemia if it succeeds to get rid of a significant amount of intravascular volume. Right. So when you call a patient dehydrated, you need to know to categorize or say give a degree of dehydration. So as you all know, we can categorize dehydration as mild, moderate, and severe. You sometimes call it no dehydration, mild dehydration, some dehydration, and severe dehydration. So how do we categorize that? We use these clinical signs: pulse, blood pressure, respiratory rate, behavior, thirst, mucous membranes, in tears, fontanelles, the JVP, skin, and also if you can measure the urine specific gravity. So some or more of these parameters, if it falls into one category, then we label that patient as belonging to that category. So for example, if pulse, blood pressure, and thirst fall into moderate category, we'll say the patient has moderate dehydration. On the other hand, you have to know how to categorize hypovolemia as well. So as we previously said, hypovolemia is a state when you lose intravascular volume. That could be due to blood loss, that could be due to sepsis or any kind of shock, such as hypovolemic shock, septic shock, distributive shock, neurogenic shock, etc. So again, you class the patient according to the category of hypovolemia or the hemorrhage. So you can use this same category for hypovolemia or in trauma situations to categorize the patient into a hemorrhagic classification as well. Say, for example, if a patient comes to you for some reason, you know that the patient has had diarrhea and vomiting, and comes with a heart rate of more than 100, a respiratory rate of more than 20, urine output is less, and the patient is pale and anxious, then you will put those parameters to match one single category, and then you will label this patient as either class 1 to class 2 or class 3 hypovolemia, or in a hemorrhagic situation as shock. So hypovolemic shock, as you see in this picture, can be due to hemorrhage, can be due to burns, can be due to decreased body fluids, GI losses, diabetes insipidus, or pure and simple diuresis with your furosemide that you give. So what is the problem with the patient not being either hypervolemic, not being in the normal volume state? So if you see in between these two vertical green lines, that is the euvolemic state, where you will have least amount of complications. But if the patient progresses to either side, if the patient becomes either hypervolemic or hypovolemic, both tends to increase the chances of complications that could be mainly organ damage and so forth. Right. So how do we recognize hypovolemia? There are three main windows that we can look into. Windows are anything, we just look at the patient without using any monitors, any investigations. By just looking and feeling the exterior of the patient, we can get an idea. So these three windows are: one is brain. So when there is hypovolemia, brain is not perfused, patient will have altered mental status. And then if the patient's skin is not perfused, the skin turgor will reduce and the capillary refill time will increase, and then the urine output will reduce. So these three windows are very good indicators. That doesn't use any equipment, that doesn't use any investigation. Those three questions simply will give you a reasonable explanation of a patient's hydration status. On the other side, how do you recognize hypervolemia? The JVP will increase, the patient will have basal crepitations in the lungs, the patient will have generalized edema, and the urine output may increase. Right. So afterwards, how do we clinically assess fluid status? We can use our clinical parameters, we can use a few equipment, and also we can use some biochemical tests as well. So the simple tests are more important and more reliable. So you have to know the clinical tests where we use to assess the fluid status or hydration status. If the patient says patient is thirsty, the capillary refill time is more than 2 seconds, skin turgor is increased. When you fold the skin with your 2 fingers, it doesn't go back to its normal state. Peripheral cold line, which means you will, when you, from the center of the body, if you feel peripherally along your arm, at one point you will feel the warmth is transforming into cold. So that is what we call the peripheral cold line. Pulse volume will be reduced. If you do a passive leg raising test, it will be positive. Your urine output, blood pressure, pulse rate, fluid balance charts all will indicate what is the fluid status of the patient. To supplement that, if you are skilled enough, you can use your central venous pressure. If you have an arterial line, you will use an arterial pulse pressure variation or ultrasound scan to scan your inferior vena cava to see whether it's collapsing or distending, which gives an idea. Probably not as a house officer level, but probably as a little bit senior doctor level. And also, if you have the facilities to do an arterial blood gas or a venous blood gas, the lactate level, the base deficit, and the central venous oxygen saturation will give an idea how the fluid status is. Right. A little bit about the passive leg raising test, because it's important, it's very reliable, and also simple to perform. So the objective of this is, um, our legs carry a lot of blood volume. So if we can direct this blood to the central compartment, that will change the hemodynamic parameters of the patient. So the more change the parameters, the more change it happens to the parameters, that means we say the more the patient is responsive to fluids, which means the patient can have fluids. How do you do this? You sit the patient at 45 degrees head up in semi-recumbent position, and then you take a measurement of the blood pressure, heart rate. If you have a CVP, you measure the central venous pressure. If you have the mean arterial pressure, you measure the mean arterial pressure as well. And then you lower the patient's upper body to the horizontal level and raise the leg end to 45 degrees. You keep it like that for 30 to 90 seconds, So that is the intention, is to get the blood in the peripheral pools in the leg to the central compartment. So if you see a 10% increase in mean arterial pressure, 10% increase or more in systolic blood pressure, or 10% or more reduction in the heart rate, that means whatever the fluid, that the blood that has gone into the central compartment has improved the circulation. Generally, it's about 150 to 200 milliliters. So if that 200 milliliters can give a significant effect in improvement in hemodynamic status, that means the patient is very fluid depleted. He will appreciate even the little amount of volume. So the patient needs fluids. So this is an easy, simple test to do, but very reliable and very helpful in settings where you don't have very sophisticated equipment. And then fluid balance charts, intakes, outputs, the balances. Mainly, this is a ICU fluid balance chart, but in your wards, you will have the nurses maintaining input-output charts. That will give a good idea of how much fluid patient has taken, how much fluid patient has lost. Numbers there will give a good idea of how much, whether the patient is a hypovolemic or hypovolemic status, which you can compare with other clinical findings. If you have a central venous catheter inserted, a CVP line, this is not gold standard. This is not the best test. So just don't say you can't guide your fluid management just by looking at the CVP, because for various reasons your CVP can increase even in a dehydrated or hypovolemic patient. So if the patient is hypovolemic, but if the patient has some cardiac problem, right, like right-sided heart failure, pericarditis, pulmonary hypertension, a tricuspid stenosis or regurgitation, then the readings that you get from the CVP is unreliable. So if you feel the patient is hypovolemic, you have a central venous pressure and you're enthusiastic and you measure the central venous pressure and it says, oh, central venous pressure is 15. So the patient is normovolemic. No, that is wrong. So a normal CVP will not, high or normal CVP may not tell us anything regarding the fluid status. But if the CVP is low, it always will mean hypovolemia. So a low CVP is a good indicator of the volume status, but not high CVP. Especially if you are measuring the CVP, reading a CVP in intubated patients, you should make a correction for what we call the PEEP that the patient has been given with the ventilator. So it's not very, so if you see a patient in ITU, just don't take the CVP reading as it is. You have to find what the PEEP the patient is having, reduce the PEEP from the CVP reading, and that will be the true value. And if you have ultrasound scan facilities and you know how to scan the inferior vena cava, that will give a good idea about the patient's volume status. The principle behind this is with each respiratory motion, the caliber of the IVC changes. If the patient is adequately filled, the change between inspiration and expiration is less. But if the patient is underfilled and you do an ultrasound scan of the inferior vena cava, you will see that there is a significant variation in the diameter of the inferior vena cava between inspiration and expiration. As you see on this right hand, there's a photo in the right hand screen. If you can see the mouse pointer, so there is the caliber of this IVC during inspiration, during expiration, there is a significant change. So we say if there is a 50% or more increased variability, respiratory variability in the caliber of the inferior vena cava, then you can give fluids to the patient. But again, that may be beyond your scope. Another piece of equipment is the arterial blood gas or venous blood gas, if you can do. We have the arterial blood gas will give two important parameters. One thing is the serum lactate and one thing is the base deficit. So when the patient is hypovolemic, tissues, muscles will get inadequate perfusion and oxygen. Therefore, they tend to produce anaerobic metabolism. The end product is lactate. So when if you do a blood gas and see that lactate is high, that means probably the patient is having anaerobic respiration due to hypoperfusion and hypovolemia. Again, normal lactate is normal 1 or less than 1 millimole per liter. So high lactate will be in hypovolemia. Plus you have to not forget when there is liver failure, lactate increases. When the patient is having a gut ischemia, the lactate increases. So those are two instances where other than hypovolemia, you will have a high serum lactate. So you have to read the lactate in the context of the patient to exclude other causes of high lactate. Base deficit, again, you have to have a normal base deficit of -2 to +2, but you see in this arterial blood gas report, the base deficit is -10. So any increase in base deficit, so the more minus it is, the more hypovolemic, and as a result, the patient is having metabolic acidosis. Right. So those are the ways that we assess the fluid status of the patient. You will not use all, but you may use few in combination to come to a conclusion. Right. What are the fluids that are available? Broadly, it can be categorized as crystalloids and colloids. Crystalloids can be categorized further as isotonic, hypotonic, and hypertonic. The isotonic fluids are normal saline, Hartmann's, and dextrose. Hypotonic fluids are the half normal or 1/5 normal saline. And there are also hypertonic fluids called like 3% normal saline, 7.5% sodium chloride, or 10, 20, 50% dextrose. Those are all hypertonic fluids. On the right-hand side, colloids can be further divided into blood products, or plasma expanders. We will not be talking about the blood and blood products, but we'll talk a little bit about plasma expanders where we can use until blood is available. And you have to note 5% dextrose. You see 5% dextrose is given here in the column of isotonic fluids, but it's never an isotonic fluid once it goes to the plasma, because once it reaches the plasma, the carbohydrate portion. Can we have some silence in the audience, please? Right, there's some distraction. Sorry about that. Once this 5% dextrose reaches the plasma, the glucose component will be metabolized and ultimately you will be left with just water. So it's basically just infusing water. So you never consider 5% dextrose as an isotonic fluid, and we very, very rarely use 5% dextrose in our clinical practice. Right. So we'll talk a little bit about crystalloids. We have our normal saline, 5% dextrose, Hartmann solution, and gelifusins. Can we have the microphones muted, please? Administrator, if you could mute, that would be great. MLM peers, that is causing a distraction. Right. So, normal saline, it consists only of sodium and chloride, and has a concentration of 154 milliequivalents each. Will have an osmolality of 308 and a pH of 5.7. So in the topmost row is the parameters of the normal plasma. You know, plasma will have a sodium of 135 to 145, chloride of up to 110, normal potassium bicarbonate, and a pH of 7.4. So normal saline has a pH of 5.7. And the other thing I need to consider is glucose. So glucose has osmolality of 5%. Glucose has osmolality of 277, and it is even more acidotic. Hartmann solution has got sodium, potassium, calcium bicarbonate, and osmolality of 270 and a pH of 6.5. So out of all these, you may appreciate that if I say the more physiological solution is Hartmann solution, and whenever possible, if the availability is there, you would use Hartmann's instead of any other crystalloids. Two things about saline. As we saw, the pH is 5.7 and the chloride content is very high. Therefore, if you infuse too much normal saline, you probably will end up in what we call a hyperchloremic metabolic acidosis. And you will see even after fluid resuscitation, still there will be an acidotic pH in a patient who has been infused with a lot of saline. Hartmann solution, on the other hand, we said it's more physiological. The only drawback is that it contains lactate. So if you are measuring, we transfuse a fluid containing lactate and we measure the lactate levels of the patient, that the measured lactate might not be very accurate in a patient who has received Ringer's lactate or Hartmann solution. And also, never use Hartmann solution to dilute blood products because it contains calcium, and the calcium in the Hartmann solution might precipitate clotting of blood. 5% dextrose, we said it again, can cause hyperglycemia. Research and studies have shown that it can increase the risk of infection, can aggravate ischemic brain injury, increase mortality, and also when the carbon dioxide is metabolized, the end product of carbon dioxide will interfere with ventilation in patients who are ventilated. So never use 5% dextrose as a maintenance or resuscitation fluid unless there are specific indications for that. Plasmolite is a new crystalloid that we know has been brought to the market. It is the closest physiologically to plasma, but it's very expensive. It has a pH of 7.4, a sodium of 140, but no calcium. So that is more physiological and will cause less complications when we transfuse. So might take some time, but it will be available in sometime in the near future in Sri Lankan market as well, and you'll be able to use it. Colloids, on the other hand. So what are the colloids we know? These are all synthetic colloids. The first, albumin is not a synthetic colloid, but it's an extract. You have albumin, you have dextrans, you have starches, and you have gelatins. We'll talk a little bit about them. Albumin. So albumin comes in preparations of 5% and 20%, and it is very effective in volume expansion, especially in patients who are hypoalbuminemic, especially secondary to liver disease. The oncotic effect will last for 12 to 18 hours, and it is not very effective in elevating serum albumin levels in septic patients with hypoalbuminemia. So in sepsis, you might use albumin as a resuscitation fluid for the pure and simple reason, because if you give crystalloids, because of the leakiness of the capillaries in sepsis, the fluid will not retain. But albumin able to retain in the plasma for a certain period of time, but not necessarily. You will not transfuse albumin to septic patients just because their albumin is low. It will never increase your albumin levels to a complex carbohydrates. Dextran 40 and Dextran 70 are the available commercial preparations. They are more powerful oncotic effect than albumin. Therefore, increase in plasma volume is more than the volume you give. So if you give 1000 ml of dextrans, the plasma volume will increase by about 1100 or 1200 milliliters. Dextran 40 will last in the circulation for about 6 hours, and Dextran 70 will last for 12 hours. The disadvantages are it can cause anaphylaxis, it can cause bleeding, and it can interfere with blood cross-matching. So if you intended to transfuse a starch, please take your blood for cross-matching and sampling before you give the dextrans. And also studies have found that it can worsen already established acute kidney injury. The other colloid is hydroxyethyl starch. So they come in present concentrations of 3%, 6%, and 10% preparations. And also, according to what a property called the molar substitution, these starches are called in different names. So if you see this 0.7, 6, 5, and 4, according to that number, this starch name will change. The product with a molar substitution of 0.7 is called hetastarch. With 0.6, it's called hexastarch, pentastarch, and tetrastarch respectively. So important thing again, the higher the molar substitution, the longer it stays in plasma. So at the moment, the clinical use preparation is hetastarch, and other starches are not used. Again, the disadvantages of using them are they can increase serum amylase levels, it can cause anaphylaxis, coagulopathy, and also because of they are starches, they can cause pruritus if they deposited in the subcutaneous tissues by extravasating from the plasma component. Right. Let's now see how these IV fluids are distributed among the body fluid compartment. So, say this IV fluid, if we give water or dextrose, so this box is our total body fluid compartments, the ICF, interstitial fluid, and IVF. If you give just water or dextrose, it will be distributed evenly in all these three compartments. If you give a crystalloid like Hartmann's or normal saline, it will mainly be distributed in these two compartments, the interstitial fluid and intravascular compartment, in their respective ratios. So the ratio here is 3:1. We said there is out of the ECF volume, 75% was interstitial fluid, 25% was intravascular fluid. So the ratio is 3:1. If you give 1 liter of crystalloids, you will have 250 milliliters in the intravascular volume, and rest of the 750 will be in the interstitial space. On the other hand, if you give blood or colloid, all of them will retain in the intravascular compartment. Therefore, the best fluid for volume expansion is either blood products or synthetic colloids. How much to give? Right. How do we calculate fluid requirements? So there are again like 3 or 4 definitions. One is called maintenance. So maintenance is how much fluid a person requires to overcome its like unavoidable losses. So the patient will evaporate, you can't control that. Patient will somehow produce some urine, you can't prevent that. Patient will have respiratory, with the respiratory breaths, the patient will lose fluid. So those are insensible losses and uncontrollable losses. The fluids that are required to overcome those uncontrollable losses is the maintenance. For the first 10 kilos of a person, you give 4 milliliters per kg per hour. 11 to 20 kgs, you give 2 milliliters per kg per hour. And if the person, for any of the remaining 20 kilogram, anything above 20, you give 1 milliliters per kg per hour. So roughly, if the person is 60 kilos, if you calculate, the fluid maintenance requirement will be up to 100 ml per hour. So if you cumulate it to 24 hours, the requirement is 2.5 liters per day. That's why we say drink 2.5 liters per day. Simple as that. So that's maintenance fluid. So there is another concept called deficit. The deficit is the maintenance into the duration of that duration of not taking the maintenance. So say for an operation, the patient is fasted for 10 hours. If this patient is 60 kilos, you know that the maintenance is 100 milliliters per hour. So if the patient is fasted for 10 hours, then 100 into 10, the deficit is 1000 ml. The other concept is ongoing losses, the diarrhea, vomiting, and blood losses. You have to calculate according to the estimation or visual estimation of the diarrheal, vomiting, or blood loss and add to the fluid requirement. And lastly, the third space loss. The third space loss is the loss of fluids from the intravascular space into the body itself, but to a separate tissue compartment. We commonly think it moves to the interstitial space where it generates edema, but it's in the body, but it's not in circulate the intravascular compartment. Therefore, it is not, that fluid is not helping with our hemodynamic status. So this could be edema, this could be third space loss, this could be bowel edema, this could be facial or sacral edema. Wherever this fluid will go and retain there. So in certain instances, when we give fluid, we have to take that third space loss also into consideration when we are giving maintenance. Unfortunately, there's no way to calculate that. Right. So now, when assessing the fluid requirements and how much patients are needed for fluids, you also come into a consensus into a concept called ROS-D. ROS-D stands for rescue, optimization, stabilization, and de-escalation. These are 4 phases any person will come present to you with. So rescue phase is when the patient is unstable or hemodynamically unstable, comes decompensated in hypovolemic state. The patient may come with following a road traffic accident with a significant blood loss, or a mother will have a PPH and have lost 1000 ml of fluid and comes unstable, or the patient may have septic shock and present with septic shock needing fluid. So in the rescue phase, you will need to give a lot of fluid. So accumulative fluid balance will increase rapidly during rescue phase, which means we need to give a lot of fluids. In optimization phase, you reduce that amount of fluids, but you still give more fluids to maintain the patient's hemodynamic stability. The patient is not as unstable as in rescue phase, but you know, with your parameters, with your assessing means of fluid status, that the patient needs more fluids. Stabilization is a phase when you don't anymore need to give additional fluids. The only amount of fluid you need to give is for the maintenance of the patient. And in de-escalation phase, this happens when the patient is recovering from an illness. So, for example, during illness, when patient is hypotensive, we give a lot of fluids. Part of these fluids, I said, they move into the third space, in interstitial spaces, or the lungs, or anywhere else in the body. But when the patient is recovering, all those extravascular fluid tend to come back into the intravascular space and tend to overload. So, and then you will encounter hypervolemic status, where you will actively need to either stop fluids or promote removal of fluids from the body. Right. So that is called de-escalation phase. So in rescue phase, you will give fluid boluses. In optimization, you will give fluid challenges. In stabilization, you will give the maintenance fluid. And de-escalation phase, you will give you will offload the patient. A few definitions again. A fluid bolus. So when you tell, I'm giving a fluid bolus, what does it mean? So that is a rapid infusion to correct hypotensive shock. So in shock patients, you give fluid boluses. The amount of fluid you give is minimum of 500 ml over maximum of 15 minutes. That is how fast you need to give. There are definitions of boluses for certain clinical situations. For example, in sepsis, you call a bolus 20-30 milliliters per kg. In dengue fever, you give or dengue shock, the bolus you give is 10 ml per kilogram. Fluid challenge is a volume of about 100 to 200 milliliters. You give over 5 to 10 minutes to reassess the improvement in hemodynamic stability. In maintenance, you just give your maintenance of 1 to 2 milliliters per kg per hour, and that you can either give oral or IV. Right. So, because I'm short of time, I'm almost over time, I'm not moving on to this scenario. From here, I stop my presentation, and if there are any questions, you can put it into the chat. I will be available. I'll chat you back the answers. And thank you very much for giving me this opportunity. It's back to Dr. Roshan Fernando.
Thank you very much, sir, for that comprehensive lecture on fluid management. That was Dr. Ival Hakon, consultant anesthetist, joining us from UK. So, if you have questions, please type in the chat box. At the meantime, we are going to the next acute kidney injury by Dr. Shamila Gayatri, consultant anesthetist at GH Neurology. Over to you, madam.
Thank you very much, Dr. Roshan. So my topic is acute kidney injury. Before that, I think you can hear me clearly.
Yes, yes.
Okay. So first, we will go through the objectives. As the other topics, it is also important. So we have to know why it is important. Then about the definition, risk factors and causes of AKI, and how you are going to identify and classify the severity. And lastly, we are going to discuss about the management. Firstly, why it is important? Because it increases hospital mortality and morbidity. That means so hospital admissions due to AKI is common. And out of all ICU admissions, about 30 to 60% of patients are having AKI. So indirectly, it will increases hospital cost. So it is a burden to the government. So that's why we have to know about acute kidney injury. There are various definitions. So we stick to, there's an international body called KDIGO. So it defines it as a syndrome where there's a reduction in renal excretion and homeostatic functions. As a result of that, there will be accumulation of waste products, especially nitrogenous waste. And at the same time, there's a failure of regulation of body fluids. There will be fluid overload, electrolyte imbalances, and acid base.
Is there just still on the definition slide? Are we going?
Yeah, so
Okay.
explaining that.
Okay.
And there will be imbalances in acid-base balance. So that is a broad definition, but it is simple. Right? So so how do you actually define it by numbers? So we can go by either serum creatinine level or urine output. So creatinine, if it is increased by 0.3 than the normal value, which is within 48 hours, that means within 2 days, you can define as AKI. Or else, so if the patient's creatinine value increased by 1.5 times of his baseline, that is also, you can again say AKI. When considering the urine output, if it is less than 0.5 ml per kg per hour for 6 hours, so then that is also alarming. So as you know, like creatinine value, so it start to rise when a patient start to rise when there's a clinical manifestation. If the patient is in a subclinical phase, so creatinine will be normal. So that is the disadvantage of creatinine. That is the reason there are novel biomarkers, but those are not available in Sri Lanka. So urine output, so you have to keep eye on urine output. And if it is increasing, that is alarming. And so you have to think that patient is going into AKI. So then we'll move to risk factors. So there are a lot of risk factors. Those what I have mentioned are common risk factors. So male, gender, and elderly patients, they are high risk. Common comorbidities like malignancies, hypertension, and diabetes, they are more prone to get AKI. Infection and emergency or major surgeries, and blood transfusion, blood and blood products, especially if there's massive blood transfusion, then that is a risk factor. Considering drugs, especially well-known kind of fusamide, aminoglycosides, and some more drugs are there. So you have non-steroid anti-inflammatory drugs. So those are common drugs which can damage the kidney. So when you are when you have a patient, so you will feel that patient is going for AKI. So you have to get the history examination and find any risk factors for AKI. So any disease has cause or causes. So then you have to know what are the causes for AKI. We can broadly divide them as pre-renal, renal, and post-renal. So just consider about this figure. So pre-renal means it is the mainly circulation to the kidney can get affected. And then the parenchyma, those are the renal causes. So as you know, renal parenchyma contain glomeruli, tubules, interstitium, and vasculature. So if any pathology related to those parenchyma that can lead to renal AKI. So it's the beyond the kidney, that means the outflow tract. If there's an external or internal obstructions or any pathology, can lead to post-renal AKI. So we'll consider about the pre-renal causes. Those are common causes for AKI. Mainly if there's a reduction in systemic circulation. For example, hypovolemia. It can be due to bleeding, dehydration, extravasation, any reason lead to hypertension, and sepsis. There may be cardiac causes. Obviously, if the heart gets affected, then the so the renal blood flow also indirectly affect. So there will be acute or chronic heart failure or any heart condition which lead to low urine output. And there will be impairment of the renal circulation itself, which is not the just general circulation, systemic circulation. If like renal artery stenosis, so only the kidney get affected. Some medications also lead to kind of hypotension and reduce the blood flow. Other things like chronic liver disease, abdominal compartment syndrome, those things also reduce the blood flow to kidney. Then some examples of renal AKI, acute tubular injuries, common things like contrast-induced nephropathy, infection, or rhabdomyolysis. Metabolic syndromes like diabetes mellitus, it is a common renal cause for AKI. Then autoimmune or inflammatory conditions which can affect the parenchyma. So glomerular nephritis and vasculitis are common causes. Then lastly, the post-renal causes. It is mainly due to obstruction. It can be external or internal obstruction. So common things like calculi, which lead to nephrolithiasis, and bladder tumors, prostatic hyperplasia, and external compression from usually from pelvic masses. So those are the post-renal causes. It is mainly due to obstruction, which lead to AKI. So then how you are going to classify AKI and assess the severity. So the KDIGO has explained rifle criteria. So they are serum creatinine level or urine output you can use. And so I'm not going to go through all the details. I just want to highlight you that when the severity goes down, so so the recovery rate also reduce. Therefore, you have to know which stage patient is in, and you have to act quickly and manage patient as soon as possible, because otherwise our outcome will be poor. So this is a complex figure. I just want to highlight that if the patient progress, so initial stage, the patient will be revised back to normal. If you delay the diagnosis and the treatment, then the patient's recovery will be poor. So that is the only thing I wanted to highlight. You don't need to by heart this. So how you are going to identify AKI? So as I mentioned previously, you have to get thorough history and do examination. So I'm going to discuss some of the investigations and complication of the AKI. So during your medical school period, I think you have gone through history and examination. So you have to follow those things when you are doing your internship. So investigations depend on, so from the history and examination, you have found probable risk factors and causes for AKI. Then so to identify or confirm your diagnosis, then you have to do certain investigations, depend on the patient. So blood urea, so blood investigation like blood urea, serum creatinine, you have to do all the patients. And then urine protein, serum electrolytes, because with the AKI, patient can go into sodium imbalances and hyperkalemia. So it is a life-threatening condition as well. So those things you have to keep in mind. If bedside blood gas is available, you have to do, because it can lead to metabolic acidosis. Images to actually, that is to, if there's a cardiac pathology or features of fluid overload is there, then you have to do chest X-ray. So ultrasound scan, again, to find out the cause for AKI. ECG, again, there will be like hyperkalemic changes. So that is why it is important. Other specific investigation, again, depend on the cause, like ANCA and ANA electrophoresis. So those are specific investigation. You don't need to do those things in each and every patient. So then complications of AKI, obviously there will be reduced urine output with the overload and the poor excretion. There will be metabolic acidosis. Fluid overload is there, obviously, and keep in mind that patient can get hyperkalemia. So severe hyperkalemia leads to life-threatening conditions. So you have to remember to check high potassium level, and if it is high, treat then and there. Other complications like uremic encephalopathy, pericarditis, with the history and examination, you can find some signs and symptoms, and then you have to do relevant investigations. Obviously, it will increase the mortality and morbidity. So the last part of the presentation, that is about the management. The first thing is, from history examination and investigation, you have to identify the underlying cause. If you don't treat the cause or causes, sometimes it will be like multifactorial. So you have to address each cause and treat it. Otherwise, patient won't recover, right? The other thing is pre-renal AKI is common. So the best thing is to hydrate the patient well. So it is with our experience. So most of the patients, they are kind of dehydrated. So with the assessment, you have to give adequate fluids. You have to avoid the starches. I've also mentioned it can lead to AKI. But you can use crystalloid or albumin with your available facilities. So fluid resuscitation is very important. After that, still blood pressure is low. So at least you have to maintain the MAP around 65 to 70. If the patient is hypertensive, you can go for higher MAP value as well. It is about 80 millimeters of mercury. And if there's a single fluctuation of blood pressure, that can damage the kidney. So you have to like hyper-enthusiastically don't increase the inotropes also. Just maintain the MAP which is required for the patient. Then, then you have to go through the drug chart and check whether the patient is on any nephrotoxic drugs. Most commonly, they can be on non-steroid anti-inflammatory drugs or antibiotics. So those things, if you can avoid, you have to avoid. Sometimes antibiotic we have to give. Then you have to adjust it to renal doses. Contrast, again, the contrast-induced nephropathy also a common problem. The staff has to discuss whether patient get benefit of doing contrast images versus developing AKI. If it is really indicated, you have to get adequate precautions, like before giving contrast, you can give a normal saline or sodium bicarbonate. And after contrast also, so you have to give adequate fluid to flush contrast from the system. So the other thing is glycemic control. So if the patient is having AKI, you have to use the fundamental thing. So what cells require? So the kidney is already damaged, but those cells require adequate energy from glucose, and oxygen has to be carried there. So avoid anemia. HB has to be at least 10. Adequate nutrition has to be given to get the energy. So there are myths about the protein, but adequate protein is required. The other things, like you have to correct the potassium. If you have done everything and patient is not producing enough urine and creatinine is rising, then you have to consider about the renal replacement therapy. There are few myths about the AKI. Furosemide, it is a nephrotoxic drug. So to improve urine output, it doesn't reassure you that patient is improving. So, and initially, in the past, dopamine is used to improve the renal perfusion, but there are more side effects and it won't improve AKI. As I mentioned earlier, protein has to be given, right? It is not, but you have to get, you have to be precautious when you give him protein. If the patient is on dialysis or continuous renal replacement therapy, then you can go for normal protein level. So what are the indications for renal replacement therapy? Obviously, if there's a fluid overload and hyperkalemia, which you can't correct with the medical management, or any features of uremia. And if there's a metabolic acidosis, again, refractory metabolic acidosis with the pH less than 7.1, then you have to consider about the renal replacement therapy. Another indication is if there's a drug overdose, again, you can use it. So those are the commonly available renal replacement therapy in Sri Lanka. Still, we are using peritoneal dialysis in some patients. The other things, hemodialysis and continuous renal replacement therapy. So as interns, so how do you are going to prepare the patient for renal replacement therapy? Usually decision is coming from the physician. Then, so you have to, as an intern, you have to communicate with the dialysis unit. And so they may ask you to, ask your team to insert invasive lines. So you have to get ready them. And so it is an invasive line, then you have to consider about the bleeding. So check the platelet, INR, APTT values. And if the patient is on any anticoagulants, antiplatelet drugs, so that is also you have to consider and inform to the relevant staff members, like maybe your seniors. Then you have to take the patient to dialysis unit if patient is in the ward. So you communicate well and arrange adequate monitoring before you sending it. Sometimes patient can get hemodynamic instability during hemodialysis. So, so whether the drugs are available, whether you need to do anything. So those things you have to communicate and inform and arrange it. I'm not going to go into like details. So the renal replacement therapy, again, just act like renal vessels. So one tube is acting like renal vein, the other one is renal artery. And so the kidney function of the kidney is taken by a machine. So that is simply what happened. And considering continuous renal replacement therapy usually available in ICU setup, so there are some advantage over hemodialysis. So it is more, blood pressure will be stable, and the fluid balance also better with CRRT. And if the patient is septic, those inflammatory markers also, mediators also taken out with the CRRT. And head injury patient, it is better than hemodialysis. So the reduced chance of going to long-term dialysis with the CRRT. Post-dialysis also, you have to do needful investigations and consider about the disequilibrium syndrome, especially with hemodialysis. So there will be invasive lines, so you have to take care about the line also to prevent line-related infections. So when inserting line, you have to take these precautions. I'm not going to go into details. Main concern is I want to again and again want to highlight, so the early detection and early treatment are the key points. There are various ways to detect the patient early. So out of that, I'm going to, this is my last slide, talk about the care pathway. There are various care pathways, so I consider this as a good one. So this is a summary of all my presentation. So things you have to check if you have an alarm that this patient is going into AKI or already having AKI. So then assess the patient. So all the factors I have discussed. So it is called Beat AKI, so assessment and then confirm and staging, treat the cause and complications of AKI, that is T, and then B, blood investigations, examine the urine, so urine protein, drugs, nephrotoxic drugs, treat with IV fluids, avoid contrast, kidney screening, that is so relevant investigations and images. And then you have to refer the patient to a relevant unit. So the take-home message, AKI increases the hospital mortality and morbidity. So you have to identify the underlying cause and risk factors, and then assess the severity and identify the complication. And then you have to treat the underlying causes. Always you have to prevent the patient exposing to risk factors. And then we have discussed how you prepare and manage with renal replacement therapy if indicated. So, so those are my referrals. Thank you very much. If you have any questions that you can ask it or message it. Thank you very much.
Right. Thank you very much, Peter, for that detailed lecture on acute kidney injuries. That
Thank
was
you.
Dr. Shamila Gayatri, consultant anesthetist, DG neurology. So we can have some few minutes to ask any questions you are having, or you can type on chat box. So in the meantime, the next lecture is by Dr. Dushani Atapattu, consultant anesthetist, DGH Chilau, on the management of massive hemorrhage. Right.
Yeah. Can you hear me?
Yes, madam, can hear you. Yes.
Okay, then I'll share my screen.
Yeah, please.
Oops, sorry. Can you see it?
Not sharing it, madam.
Sorry? Can you see it?
We don't see you as sharing it. Well, have you opened the presentation?
Hang on. Can you see it now?
We can see it, yes. You need to make it full screen, that's all.
Yeah, you can hear me, right? I'll put it full screen.
Yes, we can hear you. Need to make it full screen, madam. That's all.
So it's now in full screen, right?
Yes.
It's full screen, right?
Yes,
Okay.
moving. It's moving. Yes, yes. Yeah.
Can I start?
Yes, madam, please.
Okay, right. Good afternoon. I'm Dr. Dushani. Sorry? Yeah, okay. I'm Dr. Dushani Atapattu, consultant anesthetist at District General Hospital, Chilao. So I'm going to talk about this management of massive hemorrhage. Stop. Okay, so when you are classifying the as hemorrhage, it could be based on the source of hemorrhage and several other ways. So we'll talk about this based on the source of hemorrhage. So it could be arterial bleeding, venous bleeding, or could be capillary bleeding. So if it is an arterial bleeding, the blood will be bright red in color, spurting along with the pulse, right? And then in venous
Hello,
Can see, madam.
can you hear me? Can,
Yeah.
can you see?
Yes. Only thing.
Sorry, my internet is not working, so
Yeah.
I'll do it on my phone. Okay.
Fine, madam. Yes.
Can you all see it clearly?
Yeah, we can see that only that your you have to put yourself close your video.
Yeah. Mm.
It's blocking the view. Yeah.
I don't know. Okay.
Yes, madam. Yes.
Yeah.
Madam, what? Yes.
I don't know.
Video. Can
Yeah,
you just close the video? That's all.
Yeah. So it's based on the source of bleeding, arterial, venous, or capillary bleeding. And if it is, as I said, if it is capillary bleeding, it will be rapid and often torrential due to continuous use. And if it is based on the time of onset of bleeding, it could be classified as primary hemorrhage, reactionary hemorrhage, or secondary hemorrhage. Primary hemorrhage is occurring immediately due to an injury or trauma, whereas secondary hemorrhage, which is sort of a delayed hemorrhage, usually within 24 hours, and is usually due to a dislodgement of a clot by resuscitation or normalization of the blood pressure. So that is reactionary hemorrhage. And secondary hemorrhage, it is due to sloughing of the wall of a vessel, usually which occurs about 7 to 14 days after the injury, and it is precipitated by factors such as infection, pressure necrosis, or malignancy. And if it is based on the type of the hemorrhage, it could be reveal hemorrhage, where you can see the external bleeding, which is obvious external hemorrhage. Whereas concealed hemorrhage, usually it contains within the blood cavity, and you have to suspect the concealed hemorrhage. You can't see the blood or the bleeding source, but you have to suspect with the clinical parameters and the history itself. So you have to suspect that the patient is bleeding inside. So it is, and you have to actively investigate and control it. So which is the most nastiest one, because liver hemorrhage, intra-abdominal, intracavity, internal hemorrhage, you can't see from outside, right? So that is example like in trauma, polytrauma, in a situation like that. So the liver injury, spleen injury, and fracture femur, ruptured ectopic pregnancy, cerebral hemorrhage. So these are all concealed hemorrhage where you can't see the bleeding outside, from outside. And then there are another type of where initially it was concealed, but later it will be revealed like hematuria, hematemesis, or melena. And then the other classification is based on the duration of the hemorrhage, which is acute bleeding, where there's a sudden severe hemorrhage, usually after a surgery or trauma. And in chronic hemorrhage, where the chronic repeated bleeding for a longer period, like in hemorrhoids and bleeding peptic ulcers. So, and then based on the possible interventions, so that is in surgical interventions during surgeries due to direct injury to a blood vessel. It could be an artery or a vein. So there will be hemorrhage. And then non-surgical hemorrhage, where general ooze from all surfaces or raw surfaces due to which is usually due to coagulation abnormalities and in a disseminated intravascular coagulation, and it cannot be stopped by surgical means. And then as interns, you all definitely will come across these bleeding patients. I mean, it's very common because at your surgical appointment, it could be your surgical or gynae appointment, medicine appointment. So anywhere, I mean, this bleeding is very important. So as an intern, you should know to manage it, to take the primary actions to manage this bleeding, I mean, hemorrhage, to control this and to manage this massive hemorrhage then and there, right? So if you talk about this pathophysiology, so what will happen, I'll talk it very briefly. So the patient is bleeding, they will go into a hypovolemia, so that ultimately your cardiac output will be reduced. So that as a physiological response, the body will try to compensate this by by having tachycardia and shunting of blood from the splanchnic circulation by vasoconstriction and direct to the vital organs to maintain the vital organ perfusion. So what are your vital organs? Your brain, heart, and the kidney especially. And then with these things, the patient will have tissue hypoxia. So they will go into, with the tissue hypoxia, they'll go into anaerobic metabolism. So that will lead to electrolyte imbalances and metabolic acidosis. And on the other hand, it can activate the platelets and coagulants, which will lead to DIC and further bleeding. So the progressive hemodilution leads to a total circulatory failure. So this will it work as it's like a vicious cycle if you don't treat quickly, right? You know this lethal triad of trauma or death. So our management should, you should start your resuscitation and management as early as possible. So to prevent the patient going to this lethal triad of trauma. What are the three factors? That is coagulopathy, metabolic acidosis, and then hypothermia. So these are the your sorry. Okay, so these are your lethal triad of trauma. According to this advanced trauma life support ATLS guidelines, so you can categorize or classify the hemorrhagic shock into 4 classes. That is your class 1, 2, 3, and 4, which is mild, moderate, and severe, and dying. So what is class 1 is mild, where the blood loss is up to about 15%, where you will lose about 750 ml of blood, and then 15 to 30% in moderate bleeding, moderate hemorrhagic shock, class 2 shock. So that you can, the patient can lose about 15 to 30%. So that is about your 750 to 1.5 liters of blood has lost by that time. And then class 3, where severe hemorrhage, 30 to 40% blood has lost. That is nearly 2 liters lost by this time. And then in class 4, where dying patients, where the blood loss, about 40% of the blood has lost by this time, and that is about more than 2 liters. Okay. And so that is how you classify. So how will you can't just by looking at the patients, you can't say just this Okay, can you all see?
Yes, madam, can see.
Awesome. Okay, so it's so how we will how to identify these bleeding patients, the patients in hemorrhagic shock. So that is by going through your that is by identify these patients according to the clinical parameters, right? So that is your vital organs, the vital system, that is cardiovascular, respiratory, central nervous system, right? So in class 1, as you can see, all these parameters, all your clinical parameters are normal. So your blood pressure, the pulse rate, capillary filling, respiratory rate, urine output, central nervous system, the patient is alert and conscious, rational. So that is even 15% of blood loss, even with the 750 blood loss, still the patients usually they are stable, right? But in class 2 hemorrhagic shock, you can see that their pulse rate, they are tachycardic, but still mild tachycardia, more than 100. Blood pressures could still be normal, and the capillary refilling is more than, say, 2 seconds. And the respiratory rate is now they are having mild to moderate sort of tachypnea. And then urine output is about 20 to 30 ml per hour. And central nervous systems, they are a bit anxious now. And then class 3, where about 32, I mean about, nearly 30% of blood has lost. So that the pulse rate is around, is about 20, more than 120. They are having severe tachycardia. So moderate to severe tachycardia with a low blood pressure, and capillary filling is prolonged now with more than 2 seconds. And respiratory rate, again, they are having severe tachypnea with a rate of nearly 40 per minute. And urine output is now gradually dropping 20, so less than 20. And they are in a confused comatose state. And in class 4 classification, where the patient's blood, they are severely tachycardic. The heart rate is more than 140 with the blood pressure. I mean, most of the time the blood pressure is unrecordable with a very, with absent capillary filling. So, and very severe tachypnea with more than 40, 45, and urine output is again very low. I mean, less than 5 ml, and they are in a very comatose state. So this is rough guide of to assess the bleeding. If you can see, as you can see, if the full kidney tray, it's about 500 ml, and in a small swab. So it's that is about saturated small swab is about 60 ml, but in a big towel it will be somewhere around 100-120 ml blood loss. But the best thing is you have to when you are in the theater setup, you have to measure the dry swabs, and then later the soap swab has to be measured separately, so that you can calculate the blood loss, right? So the size of a clot, the clot size of a clenched fist is about 500 ml. So sometimes you can see that the blood, especially this concealed hemorrhage, the liver and the splenic hemorrhage, there are blood clots that already formed. So that's a huge blood clot. So the size of a clenched fist, it's about 500 ml, and in a closed tibial fracture, again a very place where they can bleed a lot, in a long bone fractures, tibia fracture. So that is about 500 to 1.5 liters had lost by that time. So, and a fractured femur, again 751 liter, more than sometimes nearly 2 liters blood can be lost in a fractured femur. And then, as I said, the weighing the swabs before and after use is an important method of on-table assessment of the blood loss. And then keep that in mind that hemoglobin is not a good indicator to assess the degree of hemorrhage. And so the management should based on the degree of the patient's hypovolemic shock and according to those vital signs, according to your vital organs, the vital systems, and then the preload assessment, the base deficit. So you invariably you have to do an arterial blood gas and see what is the base deficit, and then the dynamic response to fluid therapy. So the degree or the amount of hypovolemic shock should be assessed by all these measures, right? And then the patients who are non-responders or the patient who are transient responders are still bleeding and must have the site of hemorrhage identified and controlled then and there. So the management of massive bleeding, hemorrhage must be recognized and managed aggressively to reduce the severity and duration of shock and to avoid the death and to avoid death and then or the patient going into a multi-organ failure. And the hemorrhage is treated by arresting the bleeding and not by fluid resuscitation and blood transfusion. But keep that in mind. But you have to give fluids and blood. That is the blood is the fluid of choice in a bleeding patient. But there's no point of giving or pumping blood unless you control or unless you find the identify and arrest the source of the bleeding, right? And then the fluid resuscitation is necessary, and it is used as a supportive measures to maintain the vital organ perfusion. And attempting to resuscitate patients who are ongoing hemorrhage will lead to physiological exhaustion and subsequent death. So you have to control and identify and control the patient hemorrhage, but at the same time you have to give fluids and blood and other fluids, right? So the principles of management, so identify the hemorrhage, immediate resuscitative maneuvers, and control the hemorrhage and damage control resuscitation. So these are the principles of management in a massively bleeding patient. So identify hemorrhage is important, as I said. External hemorrhage is, of course, it's more obvious, and but the diagnosis of concealed hemorrhage is the challenging and the more difficult one for us. But you have to suspect with your clinical parameters and manage it, right? In hypovolemic shock, assume hemorrhage until proven otherwise. So if you have come across a patient with PPH, or if it is in a polytrauma patient, so always if the patient is in a hypovolemic shock, it's always due to hemorrhage unless proven otherwise. So immediate resuscitative maneuver. So again, as usual, in a immediate management emergency, how you manage that emergency situation. So your airway, breathing, circulation, your ABC, and then call for help. So you can't manage these patients alone or with 2 or 3, but you have to have a team when you are managing these massive bleeding patients, right? So inform your seniors. So direct pressure should be placed over the site of the external hemorrhage. So if it is obvious hemorrhage, so keep pressure on the external hemorrhage site. and then you can elevate the lower limbs and you give oxygen. So the airway and breathing should be assessed and controlled. And if the patient is in a severe shock or like in a class 4 hemorrhage, if the patient is an impending arrest, the patient may need intubation, endotracheal intubation. So give until that such time you have to give oxygen and then insert large. So you have other measures, so circulation. So how will you manage your bleeding patients? So that you have to insert 2 large flow cannulas. So large flow in the sense 14 or 16 gauge. And at the same time, you can, when you are cannulating, you get blood for basic investigations, your full blood count, serum electrolytes, creatinine and clotting profile, and grouping and DT and all these things. And then infuse, and at the same, so once you have taken these blood for these investigations, you give, you start your fluid resuscitation. So start with, so if blood is, so the fluid of choice is blood in a bleeding patient, but the blood will not be available. I mean, it's not, it will take some time so to get the blood. But until the blood is arrived, you can start giving crystalloids rapidly. So that is, give initial fluid challenges about 20 to 30 ml per kg within 10 minutes. And then, so by that time, hopefully the blood will be available. So you give blood as soon as possible. So until the cross-match group specific cross-match blood is available, you can give group specific or group O blood. So it's not necessary to be group O negative unless the patient is a female of childbearing age. Others, of course, you can give O positive blood until the group specific blood is available. And when you are giving blood, make sure that you use these blood warming devices. These are not sophisticated equipments. These are available in almost all the theaters now. Even in a base hospital setup, you have blood warming devices. So you have to ask for these things. So get down the blood warming devices and then give blood through this warming device. And then tranexamic acid. So that is, you give 1 gram stat and reassess. So once you are doing this, your resuscitation, you have to reassess the patient. That your assessment and resuscitation should be done simultaneously. It should go hand in hand. So once the parameters are, if the vital parameters are normalized, so that means about 20% of blood has lost. So they have come back to the normal parameters. Okay, you can observe these patients. You can't just be happy with that. You still have to be alert and observe the patient throughout. But if the patients had the improved vital signs and they deteriorate again, so that means the patient may be in a state of a class 2 or 3 shock. So that these patients need more blood and other blood products. And if the patient is further deteriorated, so that means the patient is bleeding, and whatever the blood products you give, if they are still their parameters are not improving, so that means the patient is in a state of a class 4 shock. So you have to immediately open or go for a surgery. Right. So, so that is the management. But I will talk few words about this practical aspect of blood transfusion, which is very important when you for you as intern medical officers, right? So blood transfusion in massive hemorrhage, as I said, it's a teamwork which is consists of relevant medical team. It could be a surgical patient or it could be an obs-origin patient. And so that particular team has to be involved, where you are managing, where the HO is there, and then the hematologist, the transfusion physician, anesthetist, blood bank staff, the laboratory staff and the other supportive staff should be there, right? So that to manage these patients. So a senior person can coordinate, and so there are some protocols and guidelines, but in massive transfusion protocols is available, but you have to adhere to whatever your hospital protocol. So that is very necessary. So, and also it is the communication is very important when you are managing these patients. So when you are when you inform, so there are separate forms to get down blood and blood products. So you have to fill it correctly, those boxes. And then when you are informing the blood bag, you introduce yourself. So I'm Dr. So I'm the HO of this ward, and but now we need blood for this patient. We need blood to send to the theater or to the labor room or to the PCU. So that you have to specifically inform, right? So where you are now, and then the patient's BHT, the number, name of the patient, BHT, where the ward, and where the blood should be sent, where you want the blood to be sent. So that you have to specifically tell them when you are informing or when you are communicating with the blood bank staff. Because why I'm telling this, why I'm highlighting this is those are very smaller things. You may think these are small things, but these are in practical setup. These are very important because most of this delaying of getting blood is due to this communication errors, right? So active and massive blood transfusion protocol. So activate the massive blood transfusion. So as I said, you almost all the hospitals, they have their own massive blood transfusion protocols, so that they have the issue when you say, okay, activate the massive blood transfusion protocol, they will start issuing blood. So they will send as boxes. So the box one, they will send first, and then if until you say to stop, they will keep on sending, right? So they will send the blood RBC or the other blood products, platelet, FFP, cryoprecipitation, whatever you ask, I mean, they will send, right? And then once the adequate hemostasis is achieved, inform the blood bank to stop issuing blood. So which is also really necessary because, you know, these days all island-wide, the Sri Lanka is finding difficulty in almost all the blood banks in the country. Is difficult to find out donors and blood and other blood product storage. So their storage is getting less and less. So the unnecessary transfusion is, or when avoid waste of blood and blood products. So when you think, okay, my patient is adequately transfused, so that she or he does not need any more blood to be transfused, okay, you tell them, okay, you stop the massive transfusion protocol. We have achieved our target, so stop it now, right? So they will stop. Otherwise, they will keep on sending, especially this platelet and FFP. The platelet, of course, they have to put unfreeze. They have to thaw it before issuing. So once it's thawed, they can't be freezed again. They can't use again. So so you have to inform that, so that the unnecessary or the waste of blood and products would be minimized, right? And then so you have to always balance between the hemostasis and the thrombosis. So adequacy should be assessed with your investigations. Therefore, when you send the investigations, so you have to trace them back. You have to check whether the patient has their this blood and your investigations clinically, not only the clinically, but even the biochemistry side also, whether the patient has achieved the targets, right? So the further management, so hemorrhage should be controlled rapidly to prevent patient entering into that lethal triad, which we talked few minutes ago, and then avoid unnecessary investigations and procedures prior to hemorrhage control. So controlling of hemorrhage is your is the goal. It should be your goal first, that you have to do it first, and then only you will go for these other further investigations and procedures, right? And surgical interventions may need to limit to the minimum necessary to stop bleeding and control sepsis. So they will do that something called damage control surgery. So they will do, the surgeons will do the minimum necessary procedures. So they will quickly come out of the surgery. They will stop the bleeding and quickly come out. And they may further reopen or redo the procedure once the patient has come to a certain stable state, right? So the more definitive repairs can be delayed until the patient is hemodynamically stable and physiologically capable of sustaining the procedures. So your goals should be reduction of the respiratory rate. So if the patient is now if the patient is breathing on his own, then the patient's the tachypnea should come down. So it should be less than 20 per minute. And then the reduction of the tachycardia, where the blood heart rate should come less than 100 per minute. And increasing of the systolic blood pressure, 100 would be fine with warm, dry skin, right? So you don't have to target for high blood pressures when you are resuscitating. So the systolic around 100 would be fine in a bleeding patient. And then the urine output should be improved by this time with a point of 0.5 ml per kg per hour, and HB of target HB say around more than 8 grams per deciliters. And then the post-resuscitation, post-operatively or post-resuscitation, the patient should be ideally managed in an HDU or ICU setup, but in a ward setup again in these GIN OBS patients. So they may prefer to keep their patients in the ward setup, but with adequate monitoring and observing the patient. And continuous monitoring of vital parameters, and then you have to continually monitor these, and then again you have to inform your seniors and observe for further bleeding, which is very important. And as I said, you send some for investigations, and then once the patient is stable, you may not trace them back, but you have to trace these investigations. And then early mobilization, that is to avoid any DVT or pulmonary embolism risk, right? And then look for the complications of massive blood. That's also very important. You have to look for, once the patient has received massive blood transfusion, they can have various complications. So you have to look for these complications of massive blood transfusion. So that's all about the massive blood transfusion, massive hemorrhage, how to control a massive hemorrhagic patient. So do you all have any questions? Hello. Any questions?
Right. We come to the last lecture. Thank you, Dr. Dushan Athapatha, for that lecture. So next last lecture is by Dr. Prasadini Karmaratna, consultant anesthesia at Apeksha Hospital, Maharagama, on acute pain management. Over to you, madam.
Thank you. Good evening, everybody. I think you are after 2 hectic days. This is the last lecture, and but I think it is important as well as the other lectures. You will realize it once you start your clinicals or your internship, how important the acute pain management is. Can you hear me all?
Yes, can hear.
And you can all see the screen as well?
Yes, yes.
Okay, so during these 40 minutes, I'll try to finish it as soon as possible, if possible. I'm going to talk about what is the pain and just recall the pain pathway very briefly and why pain management is important, and assessment of pain and pain management barriers. Currently, I'm working as the pain management unit in Apeksha Hospital, where you see most of the time chronic and cancer pain. But today I'm going to talk about acute pain management, mainly because you are going to be house officers. And I want to talk a little bit about barriers as well, because then you can overcome barriers and it will be helpful to continue as a good pain service. So according to IASP, International Association of Study of Pain 2020, the pain has defined as unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. I think all of you know this thing from the medical school, and they have added another 6 unit components as well. So it is a long definition, but in working conditions, our definition is very short. That is, if patient says hurts, it's pain. Okay, so forget your long definition. Forget means that it is for your theory purposes, but when you're working, if patient says hurts, it's pain. So that is our working definition. So if I recall the pain pathway, you know, if there's a tissue or injury, there's a free nerve endings. It will be stimulated and it will go along your dorsal horn up to the dorsal column, right? Dorsal horn. And there's a second order neuron, and it is called transmission, and it will go up to the thalamus. And from thalamus, that it will go several places: sensory cortex, limbic nuclei, and reticular formation, so parietic ganglia. And so there are several places it will be transmitted. So finally, you will perceive from the sensory cortex. And this is your ascending pathway. And there's another pathway descending. It will cause pain modulation. So you can remember your gait control and all that. So ultimately, balanced sensory input will be gone to the sensory cortex. So what is pain sensation and what is pain perception? Are they different or one thing or a similar thing? No. Nociception, or what you get the stimuli at free nerve endings, is pain sensation. But what ultimately your brain reads is pain perception. So what is the difference? So this nociception will be modulated by several other things. One thing is your beliefs, patient's beliefs. They may be religious or cultural. Then the psychological factors, anxiety and depression. You know, if you are depressed, you will be very low mood and you will feel pain more. and cultural issues like your expectations, right? And other illnesses. If you are having some other problem like cancer, you will feel more pain. And the personality, that also very individualized. So some people react very seriously for a minute pain, and some will tolerate it. So that is your personality. And social factors, family and work, everything matters. So ultimately, what you reflect or what you put out is your pain perception. So what the patient says hurts, and that's what we should treat. Okay? Right. Why pain management is important? First, it is humane and it is a fundamental right. So everybody has a right to be pain-free. And it is psychologically and physiologically affecting the patient. So if you see the harmful effects for the patient, you can divide into physiological and psychological effects. Physiologically, it affects your sleep, appetite, and everything. And it can cause so many medical complications as well. Like, if you are in pain, your sympathetic nervous system is activated and you will get hypertension, tachycardia. So if the patient is prone to get myocardial infarction, so if the patient's oxygen demand goes up because of hypertension and tachycardia, so he may end up in myocardial infarction. So the patient has come for a surgery or something else, and patient die of myocardial infarction. So if sometimes we see this is happening post-operative period. And if the patient is ventilating during post-op period, the patient can end up with atelectasis and the secretions can accumulate and end up in pneumonia. And if the patient doesn't move, he can get deep vein thrombosis and can get pulmonary embolism. So patient ends up in catastrophic event, right? Sometimes the ultimate result is death, right? And paralytic ileus, poor wound healing, and some conditions can lead to chronic pain, which is very, very difficult to treat, and it is a big health cost to the country. And psychologically, patient suffering and depression, anxiety, post-traumatic stress disorders can be seen. Especially pediatric patients, they will never come to the hospital again if we don't manage pain properly. So you can stop me at any time and ask if you have any question. And it is not only for the patient, for the family as well. So the lose the role of the part of the family as a mother or a father or a child. So he is not an active member if he is in pain, right? And lose working capacity, because everybody wants to go back to the society or go back home as soon as possible and occupy their work. So it is lost if you don't manage pain properly. And for the society and the health budget, it's a big cost and the bed turnover will be very delayed. So the patients, there's a, how the patients stay in the ward, on the beds, on the benches, under the beds, our number of patients. So getting a bed is a big issue in a hospital. So if the patient is unnecessarily staying in the ward, it will be a big problem. And ultimately, it will be losing the working population as well. Right. So all pains are not same, right? So you think that pain is not a single entity. There are different types. So is it important to know a pain type? Yes. So for that, you have to ask 3 questions from the patient. How long has the patient had pain? And what is the cause? and what is the pain mechanism. So by that, you can divide the pain into several groups. So depend on the duration, you call it acute pain, that is pain of recent onset or probable limited duration. And it is due, if it is long term, usually we call it more than 3 months pain, it is called chronic pain. And if the pain lasting after normal healing, even it is less than 3 months, we may call it chronic pain because it has gone beyond the normal period of time, right? So sometimes, and so this pain, chronic pain, usually no identifiable cause as well. So you will see, if I tell about examples, talk about examples, acute pains, any acute conditions, acute myocardial infarction, acute cholecystitis, appendicitis, trauma pain, post-surgical pain, right? So you can give many examples for acute pain. Chronic pain, what are the conditions like trigeminal neuralgia, chronic post-surgical pain, phantom limb pain, that the pain getting after removal of a limb or a part of the body, that patient feels the pain is coming from the missing part, that is called phantom limb pain. And your migraine, sometimes chronic headaches, backaches, very common, and chronic post-surgical pain, chronic regional pain syndrome. There are so many chronic pain conditions. Sometimes you can't identify a cause even. So depend on the cause, we divide into cancer pain. It is progressive and may be acute and chronic, and non-cancer pain, that is all other conditions, which is not a malignant pathology, it doesn't have malignant pathology. So it could be acute or chronic, right? So depend on the mechanism, how the pain arise or how the pain transmitted, you can divide again as nociceptive pain. So most of the time, these acute pain conditions are nociceptive. So there's obvious tissue injury or illness, so you can find a cause, and sometimes called physiological pain. And it is a good pain, actually. It is a protective pain. You know that if the long-term diabetic patients who are neuropathic and they don't, who have autonomic nervous system pathologies, they don't feel pain, and sometimes they get silent MIs. So if you get a typical chest pain, you will take the patient, or you know the patient is in a critical condition or a life-threatening condition. So that in one hand, it protects the patient by bringing the patient to the hospital, and it protects the patient by you know that it is a life-threatening condition and you attend, right? So you are stamped or you are called to see the patient urgently because the patient is having such a pain, a severe pain. So it is a protective mechanism. Otherwise, nurses don't know the patient is having pain, and the family members don't know the patient is having pain. Sometimes you found them drop dead. So it is a protective mechanism. And how the patient will explain it, and what like sharp pain, it is coming from your skin or soft tissues, like your trauma patients and post-surgical patients. And it is a dull pain where it comes from a viscera, right? Anyway, it is going through your normal nociceptive pain pathway. So depend on the A delta or C fibers, you will explain it in different terms. The main cardinal feature is it is well localized, right? You know myocardial infarction pain, it is a retrosternal. You know the appendicitis pain, where the cholecystitis pain, where the pancreatitis pain. So you can identify, mainly because it is well localized, or patient can say where it is coming from. But in contrast, neuropathic pain, It is caused by a lesion or disease in the sensory nervous system. Now it is not your normal nociceptive pathway. It is different. Your pain pathway is also got changes, right? I'm not going for that. But there are some macroscopic, microscopic, or perception, the pain conduction differences, right? And there may be tissue injury or may not, and it is not a protective mechanism. It is something that hurts the patients and make the patient suffer. It is not useful. So the patient will explain it: burning, shooting, pins and needles, or numbness. And allodynia. Allodynia is that you feel pain for non-noxious stimuli. And hyperalgesia is you are feeling pain for even minute stimuli can cause exaggerated pain. It is not well localized. So why these are important as a house officer? Maybe you are not going to manage neuropathic pain, but you can identify the patient and refer to the relevant unit, because island-wide there are pain management units. These patients are mainly managed in those hospitals, those centers. If you find a patient like this, you can call your seniors and refer the patient where the nearest center. So it is helpful for the patient. So that's why I included this part, even it is acute pain management. So assessment is the main important thing in pain management. Unless you assess properly, you can't manage. Any condition you have to assess with history, examination, and investigations. In this one also, it is like that. But in acute pain, it is mainly history, but you have to do examination and investigations to find the cause in acute conditions. So what are the things you are going to assess? Severity, onset, duration, character, or the type of pain, as I mentioned earlier, whether it is nociceptive, neuropathic, or cancer, non-cancer, and any associated factors like weight loss or any nausea, vomiting, anything with pain, aggravating and relieving factors, and radiation as well, and past medical history. Unless you know the patient's past medical history, you cannot prescribe the drugs, because sometimes we cannot use that drug at all, or sometimes we have to do the dose modulations or reduced dose, depend on this. For example, if the patient is having renal impairment, long-term diabetic or hypertension, so be careful managing with analgesics. And if the patient is bronchial asthma, sometimes we cannot use opioids, right, like that. And any low platelet condition, we cannot use NSAIDs. So there are many practical problems. So past medical history is at most important, as well as the drug history, because our analgesics can have interactions with drugs, especially NSAIDs, and obviously the allergies. So these days, allergies is a big topic in the society and in the media as well. So you have to be very, very careful as a house officer. So severity, how do you assess? So what is the pain score, right? Why we are using pain score, I'll tell later. And we use pain score at rest and with movement. And how is the pain affecting the patient? So can the patient move, cough? Can the patient walk? Because we want pain relief during his moving or the functional pains reduction. So the patient, we don't want the patient to be like a log. We want the patients to be active. For that, we have to give the drug. So we have to assess what is the maximum pain score during movements and what is the minimum score at rest. So we are using pain scales. We can say mild, moderate, severe. Rather than that, pain scales are more useful. So we are using verbal rating scales like mild, moderate, severe, as I said, and we can say no pain 0 and 10 is the worst imaginable pain, like myocardial infarction or a labor pain. In between 1, 2, 3, we call it mild pain. That is the pain that patient can tolerate and do their work. Even now you may have some headache or backache, sitting whole day, but it may be a mild pain you can tolerate and stay the next few minutes. But moderate pain is that you cannot work. You may need some drug to control it, like 4, 5, 6 we call it. And severe pain is a pain that your patient is screaming, crying, and he's scrolling sometimes. Even if you see the pediatric patients, they cannot be consoled. They are very irritable. So that is a 7, 8, 9 pain. And we can use a visual analog scale, that is the same 0 to 10 scale. We are putting as numbers and the patient can see. So some patients don't know the numbers, and especially pediatric patients, then we use facial pain scales. They can show what their face at that moment. And functional activity score is something else, that it is usually we assess how the patient's functioning, and more specialized methods are there. They are multidimensional analgesic scales, which is used mostly in chronic pain. So I'm not going to talk about that. So visual pain scale, visual analog scale, numerical scale, and this Von Baker facial scale we are using in pediatric patients. Right. So functional activity score, I am not very keen at this moment because it is mainly for chronic pain conditions. But you can use this one, limiting factors, pain at rest and pain during activity, during deep breathing and getting out of bed, because these are very important in post-operative patients. So you can divide them into no limitation, mild to moderate limitation, and severe limitation, right? So why severity assessment is important? That is, we decide on drug, depend on the severity, and to assess the response, because we don't give the drug and just go away. We have to reassess the patient and see whether the patient's pain score has come down, patient has got pain relief. And to communicate, if you say the pain score is 9 or 10, then the receiving side knows that patient is in severe pain. So it is a way of communication, like your GCS, right? And it is a objective measure because subjective variation is eliminated. So it is somewhat regular or the more useful way. So what is pain relief? That is, if the functional pain score is less than 4, or patient says comfort or comfortable, right? So we assess the type, as I mentioned earlier, that is nociceptive, neuropathic, or mixed type. Why this type or character is important? Because our management is different and the selection of drugs are different, right? Okay. So if I talk about pain management, we can divide it mainly into pharmacological measures and non-pharmacological measures like RISE. RISE is rest, I for immobilization, compression, and elevation. You know, if you've got a fracture, how important the immobilization is. So once you put a back slab or at least some strong ball or a cardboard and put a bandage, right? So it will help to reduce the movements of the fractured bones, and it reduces the tissue damage as well as it reduces pain signals transmitting, right? So immobilization, resting, compression. You know that if you get a sprain or something, you put a crepe bandage, right? It relieves pain. And elevation, like in cellulitis, the tissue edema, this tightness will go off and the patient get pain relief, right? And psychological support, right? So the way you talk also help to patient's help, for the patient's pain relief. The way you talk means that you show that you are caring, you are worried about the patient pain, right? So it will be a very comfortable thing for the patient rather than going ask very harsh manner. If you talk very softly, I know you are in pain. I'll try my best to reduce pain, but you will feel little of it, or you will feel some pain. I cannot eliminate it completely, but I'll try my best to reduce it. So those words will be a comfort for the patient. And some distractive methods, especially in pediatric patients and cancer patients, we are using it. Either television, music, especially the children, the distractive methods are very helpful. So they are non-pharmacological, but important. So pharmacological pain management, that is the most important part of this lecture. And what is the guide? So in the history, you ask every question and you examine the patient to find the cause, whether there's an acute abdomen, whether there's a collection, whether there's warm, tenderness, so any pus collection or abscess, whether there's a fracture, right? With the examination, you can find the cause, right? And investigations, you do blood investigations, MRI, CT, ultrasound, X-rays to find the cause. Because in acute pain conditions, finding the cause and treating the cause equally important. You know that if the patient is in a plaster cast, patient complains severe pain in the toes or fingers, you know definitely it is a ischemic pain, right? So rather than giving morphine or something, you have to come and see and loosen the cast, right? Otherwise, next day the limb will be gangrene. So finding the cause is equally important in acute pain conditions because it may be life-threatening or limb-threatening. So once you do everything, how are you going to manage pain? So what is the guide? Is there a guideline? Yes. So that is the WHO pain ladder, right? So that's why I said mild, moderate, severe, or the pain assessment of pain severity is very important. So mild pain, you can use simple analgesics like your paracetamol or NSAIDs. And moderate pain, 4, 5, 6, you can use your weak opioids and paracetamol, simple analgesics. So severe pain, strong opioids and simple analgesics. And uncontrolled pain, you have to get the opinion from pain specialist. So they might give interventions, peace. Refer the patients to the relevant unit or authority. Even you don't have a specialized pain unit in your hospital, if you have an anesthetist, you can ask the seniors or your consultant, is it possible to refer this patient to the anesthetist, at least give a nerve block? Nowadays, most of the anesthetists know how to give blocks and all that. So whether you can get their help to relieve pain, especially the rib fractures, right? In trauma patients, fracture neck of femur, and a lot of orthopedic conditions, right? The acute pain can be managed with the help of interventions. So you can ask your seniors to get the referral to the relevant unit, even to the anesthetist, right? If you don't have a pain management unit nearby, right? So simple analgesics, I'm not going to talk about a lot of pharmacology. You know your pharmacology well because you are just after your finals. And this paracetamol, you know, oral, rectal, and IV preparations are available. Dose, 15 milligrams per kg per dose. And caution in liver disease. So you have to either reduce the dose or reduce the frequency. So increase the gap. NSAIDs, again, oral very famous, your rectal route, suppositories, IV, IM, and dose 1 milligram per kg. I'm not going to talk about NSAIDs, what are the examples, all that. And you have to be very cautious in renal disease, gastroesophageal reflux disease, low platelet conditions, and long-term diabetes and hypertension. We think these patients don't have renal disease because their creatinines are normal. No, because the creatinine doesn't go up until they get more than 50% of renal damage. So be careful in those population. You can use, but for a very short period, sometimes maybe a stat dose only to break the vicious cycles, not for long-term use. So unless in very few conditions like arthritis, that is also under supervision. Other times, don't use NSAIDs for long-term. And use with antacid. Always be alert about the side effect, and you have to give the drugs to alleviate those symptoms, right? If the patient, the drug causes nausea, vomiting, you have to give antiemetic. If it is cause GORD or gastritis, you have to give antacid. If it is causing constipation, you have to give a laxative, right? And weak opioids, what are the drugs we are having? Codeine. You don't have codeine syrup freely available, but it is available in Cancer Institute, and it is paracetamol combined preparation, Panadine, codeine 8 milligrams and paracetamol 500 milligrams in one tablet. So don't prescribe simultaneously paracetamol, then it can cause overdose, right? And it can cause mild drowsiness as well. Tramadol, it is not recommended less than 12 years of age, and it can cause addiction, right? And has all side effects of opioids. So be careful. You have to alert the patient about the drowsiness, nausea, vomiting, constipation, dizziness, respiratory depression, all, right? And strong opioids, the pethidine, it is not commonly used in most of the wards, but it is very famous drug among nurses. They like to give pethidine rather than morphine, and usually they give either 50 or 75 milligrams. You can give slow IV. One most famous route is IM, and commonly used in labor wards and post-op pain management, right? If the patient, if the nursing staff is not very happy to give morphine, at least pethidine is helpful for the patient. And morphine dose is 0.1 milligram per kg, but there's no maximum dose. You have to give small aliquots until the patient gets good pain relief. So there are several routes: IV, subcut, IM, oral morphine as morphine sulfate tablets, immediate release and slow release as well. So immediate release you can use in post-operative period. And patient control analgesia, that is the devices are not available in each and every hospital. But if you have, it is a gold standard way of, because the patient is managing his or her own pain. The problem is, if you are using patient control analgesia, you have to have a dedicated cannula without putting three-way taps to that line, right? So otherwise the drug will go to the other side, to that drip, rather than to the patient. Then fentanyl, it is mostly the anesthetics drug, very short acting, but it is 100 times more potent than as morphine. And it is IV, subcut, and can be used, but not commonly used in the wards. But there are transdermal patches, and you can use patient control analgesia, fentanyl, but they are in specialized centers like cancer hospital or cancer institutes. The fentanyl, unlike morphine, it doesn't have active metabolites. So the morphine has active metabolites, 6 and 3 glucuronides. So it can accumulate it. So be careful in renal impaired patients. So they can get accumulation and get respiratory depression later. So be careful when you're using in those patient population. Right. So opioid side effects, you have to tell the patients that you will get these things, but don't worry, we are giving drugs to reduce the symptoms: nausea, vomiting, constipation, urine retention. So if the patient having BOO symptoms, that bladder outlet obstruction symptoms, they can get aggravations because of morphine and can get drowsiness, respiratory depression. The problem, the fear of our staff is that patient get respiratory depression or respiratory arrest with morphine. Until they get a good pain relief, they don't get respiratory depression. So what you can do is give the patient, calculate the patient's dose. If the patient is 60 milligrams, his dose is 6 milligrams. Don't whack all 6 at once. Give 3 milligrams subcut and see about 20 to 30 minutes whether the patient is getting a good relief, right? So if it is not, give another 3, or if you are worried, can give another 1.5, right? So likewise, you have to stay with the patient, take some time and give the drug. So until they get a good pain relief, they don't go into respiratory depression. And they can call meiosis. Morphine can cause meiosis. So it might affect with your head injury monitoring, but if you have most of the time you are having CT facilities in most of the hospitals, so it is not a limiting factor not to use morphine in a multiple trauma patient, right? And tolerance, that is, patient need more and more drug to give the same effect. Dependence and addictions, that is, addiction is the craving for the euphoric features of the drug. You know that it can cause euphoria. So these are the myths that we are having when using morphine. So we are not worried about tolerance, dependence, or addiction in acute pain management because we are using for a very short period, few days, right? Give a good, comfortable period. You think about addiction in short term, right? So it is not a big barrier to use morphine in acute pain, right? Acute pain condition and cancer pain is the 2 conditions that we are using morphine freely, but not in non-cancer chronic pain. In that situations, in that conditions, you are not using morphine. So it is not your territory to manage chronic pain as house officers. So you can use opioids or morphine, especially freely. So morphine is it safe in wards? Yes. So assess the indication, whether the patient is having severe pain. Consider contraindications or cautions like bronchial asthma or any other hypotensive state, and cautions, right? Like in renal impairment, even in low doses you can use. And whether you have basic care equipment, whether you have an ambu bag, oxygen source, and monitoring facilities, at least a pulse oximeter, and naloxone, the antidote of opioids. It can reverse opioids in minutes, right? So it comes as a 400 mics vial. You dilute it up to 4 ml, then 100 mic per cc, and give 100 mics at a time. We are not going to whack the whole naloxone vial at once because we don't want to reverse the pain relief action that we have achieved very difficultly, right? So give 100 mics, see the response. If not adequate, give another 100, right? Sometimes you may need 300 or 400. The problem with naloxone is it is short acting, so you may need repeated dose or infusion, right? So in the pain ladder, you saw these adjuvant drugs in a bar. So it is not originally used as analgesic, but you can use with your ordinary analgesics. So these drugs are very effective for neuropathic pain. I just mentioned for the sake of completeness. So gabapentin it is the drug that you can use in wards in acute pain, chronic pain, nociceptive, neuropathic, cancer, and non-cancer. Every pain you can use gabapentin, even in acute post-operative period. It can initially cause a little bit of drowsiness and nausea, so you start with 100 milligrams, and it has opioid-sparing effect as well. So you can reduce your opioid requirement if you are using gabapentin simultaneously. And it is again caution in renal impairment. Ketamine, again, sublingual, subcut infusions are available. Dose is 0.25 to 0.5 milligrams, and you can use in pediatric patients as well. So again, it can be used in acute postoperative pain. So you can give 0.25 milligram per kg sublingually. So it can help to reduce pain very well. So there are a few barriers that if you can think of it, or if you can identify these things, what are the barriers in your ward, you can eliminate those things and give a good pain service. Like drug side effects, you cannot stop it, right? Sorry, it has repeated. And the patient's myths and beliefs. Sometimes patients think it is the painkillers are not good. It is not good for liver. It is very strong. It is very strong drug. Right? Like that is the term that you are using. And lack of knowledge about the drug and not aware of patient's autonomy, that patient thinks that they have to bear the pain and stay in the ward. They have no right to go and say or tell the staff that I'm in pain. So that patient doesn't know his or her rights or his or her position in the ward. That is called autonomy. And the staff factors, the understaff, attitudes, and ego. Sometimes the seniors, they don't like to refer the patient to the relevant authority or a person, get advice from that person, right? And communication gaps, language barriers. So those are the main factors cannot give good pain relief. And system problems, logistic issues, and long process and inefficient staff. So sometimes it is difficult to get a drug on time and correct dose, correct route. And the financial problems as well. Now we are facing at the moment. So these are the main things that I want to highlight in this short period of time. So I hope you understand or you got something about pain management, and I hope you are giving a good pain service for your patient. So my take-home message is respect the human right, and pain is what patient says hurts, assess and reassess. It is the fifth vital sign to be monitored in each and every patient, right? And refer BNF for the side effects, caution, dose reduction, and the per kg doses, and legible writing, because it can cause very harmful effect if you write, your handwriting is horrible. And show empathy, kind talking, show the caring, and this touching the patient, those things also matters to comfort the patient, right? So please give the correct drug, correct dose, correct time, and around the clock, because spacing is also important. So the patient is having some sort of analgesics in therapeutic levels 24 hours. So this is very important. Correct drug, correct dose, correct time, around the clock. I think I have taken 5 minutes more from you. Is any questions at the moment? Right.
Madam, there's totally.
Sorry?
I think no questions seems to be. Okay.
Maybe they are very tired.
So, yes.
At the end of 2 days, this is not a good
it goes
time
tomorrow
to talk.
also, yes.
Yeah.
Right. Thank you very much, madam, for the detailed lecture. So we come to the last day of anesthesia. Tomorrow is hospital management. So do join by 9:30 tomorrow morning. Right. Thank you.
Okay, thank you. Have a nice day. Thank you.